Great, thank you. Okay, one last one, please.
Hello. And it might be a naive question. So I'm just asking like this structural connectome predicted data. I mean, is there any way to validate it with the real system?
Yes, so that is a genuine sum. So
I mean, I was asking also in another direction. So you are predicting like, predicted age versus chronological age. And like from the plot you are talking about like, if it is in a positive direction, your age is like more than the real one. So I was going to ask from that point of view, like when you are having the prediction, you have the data already collected from the patients, and then from the prediction and you know the patient itself. Can you connect that one? That was my query, basically. Mm, true.
Great, thank you.
Okay, thank you very much. Thank you.
Thank you, sir. Thank you, Professor Devarajan. Please join me in thanking Professor Devarajan again. Thank you. So our next speaker is my co-convener for this symposium. So we are pleased to welcome Dr. G. Venkata Subramaniam. Thank you. He's professor of psychiatry at NIMANS Bengaluru and a renowned neuroscientist, celebrated for his pioneering research in neuroimaging, schizophrenia, and translational psychiatry. He earned his MBBS and MD in psychiatry from NIMANS, followed by advanced research training in brain imaging and neurobiology. A recipient of the Shanti Swarup Bhatnagar Award for Medical Sciences, he has over 250 research publications in international journals and several co-edited academic volumes. He is fellow of the National Academy of Medical Sciences. He continues to advance medical health research, innovation in neuroscience as well as practice. Yeah, we are fortunate to have him with us today. Sir, please share your insights. Thank you.
Yes. So good morning, everyone, and thanks, Professor Ballare, for that generous introduction. And I'm delighted and fortunate to be here. Thanks to Professor Mishra, and thanks for organizing everything here, Madam, Professor Lata, and the NASI team. So I'm kind of going to take it forward from what Dr. Sridhar very elegantly and eloquently presented in terms of the network connectomics and its relevance for brain health and disease. I will perhaps selectively focus on the disease that I work, that is schizophrenia, and Dr. Nivedita is there to take it forward in terms of some advanced application. So yesterday we had this mention about translational research in several of the presentation. So if you look at translational research, it has to become more inclusive. This slide kind of summarizes it, where it's not. Yeah, excellent, thank you. So this particular slide summarizes it, where we have the scientists that work in the lab. It has to go from the bench to the bed and beyond. For this, we need kind of an inclusive approach. I will revisit this slide in the end. Now, coming to the disorder of focus, schizophrenia, I think many of us may be familiar with this disorder. It's a complex and etiologically heterogeneous, which has both genetic and environmental contribution. And this is perhaps, especially in its acute symptomatic stage, is considered as the most disabling disease anybody can experience. So that's the gravity of this particular disease. And the symptom manifestations involve features like hallucinations, which is basically perceiving without a stimulus. If one has to give a kind of experiential account, all of us will dream. And sometimes the dreams could be so bizarre and ununderstandable, but despite that, at that moment, during our sleep, we will believe it in full. In terms of what we think in the dream, what we perceive in the dream, how much absurd and ununderstandable and implausible it is, we fully believe in it till we wake up. In the context of schizophrenia, this realization doesn't happen. Dream is considered as one of the models to understand psychosis, which is a component of schizophrenia. So delusions are essentially perception without stimulus, delusion is essentially false beliefs which is contrary to the evidence, whereas hallucinations are perception without stimulus. And this disorder has aberrations that involve perception, cognition, and action, and there are many other symptoms, but today I will be primarily focusing on hallucinations and delusions. There is a consensus that these symptoms involve neurochemical disturbances, predominantly comprising of GABA, glutamate, and dopamine. To contextualize this disorder in terms of another example of the experiential component, those of us who know Professor Nash, a Nobel Prize winner who lived with schizophrenia, he was asked by a fellow mathematician, Dr. Nash, how could you believe that you are being recruited by aliens from outer space to save the world? To which Nash replied, because the ideas I had about supernatural beings came to me in the same way that my mathematical ideas did. So I took them seriously. So this is how it could be. Now, at one level, I mentioned in the acute stage, this is the most disabling condition. As we treat the disorder, 1/3 of patients do not respond to any kind of medications that we give. So this is a challenging component that adds to the disability burden in the chronic stage of the disease. So to handle this challenge, we run what is called as an INSTAR program, that is Individualized Schizophrenia Treatment and Reintegration. INSTAR also means change. We hope to make change in the lives of these individuals where we try to reintegrate the disintegrated self. However, given the challenging components of this disorder, we adopt an inclusive approach that has multiple components here, like medications, psychological interventions, family-based interventions, psychosocial, mind-body-based, medicine-based interventions, so on and so forth. While medications form the sheet anchor to treat this disorder, there is also an increasing role for neuromodulation to treat some of the persisting symptoms. So that's a specific aspect which I'll be focusing in the rest of my presentation. Now, the limits in understanding the brain, especially its disordered state in schizophrenia, is primarily constrained by the limits of our understanding of perception, action, and cognition. So in that context, as kind of presented by many of the speakers yesterday, the predictive processing is gaining more and more traction towards a unifying theory of brain function, and it has application in understanding perception, action, and cognition, and hence it has potential utility to understand schizophrenia. To the diverse audience here, if I have to kind of give a simple example of this predictive processing, this slide may help. Suppose if I am given the slide and asked, there is a shadow which is on the left side of this particular slide. What do I see? and how may this shadow be created. So what I may do is, I'm somebody who's experienced over the past many, many years and seeing many, many shadows and trying to understand how it would be generated. And naturally, I'll be inclined to see what I expect, and I expect what I see. So this is the basis of predictive processing. That is, we see what we expect and we expect what we see. So here, based on my prior experiences, I may say that this shadow perhaps may be created by a dog. Now, I am kind of given additional information. I'm asked to look again. Now I see that this is an unusual situation where a cat has cast a shadow which looks like that of a dog. Now there is a new information which is coming, which kind of violates with what I predicted, and this is a prediction error. Now I can choose to hold on to the model, or I can update my model. If I am experiencing schizophrenia symptoms, I would be rigid with the model I have, and I will say that, no, this is a shadow which is actually created by a dog. There is a persecutor who wants to establish I'm incapable of differentiating between a cat and a dog, so that he wants to prove me worthless. So this is something which is kind of a conspiracy where the universe is trying to make me so much felt incapable. So this is the kind of delusion. I'm just kind of making it dramatic. It happens in multiple stages to make it kind of very evident with this example. So such aberrant predictive processing may underlie delusions, and it can also color our perception, because of which hallucinations may happen. Now, if you look at the predictive network in the brain, it involves regions like prefrontal cortex, temporoparietal junction, insula, striatum, hippocampus, and cerebellum. Dr. Vatsala nicely elucidated the role of cerebellum in prediction yesterday. So this slide summarizes one of the first studies that was done in India, where we looked at patients that have schizophrenia who are untreated and looked at their brain volume deficits. So we reported these findings 2 decades before. We see several of the brain regional deficits map with the prediction network. Subsequently, we went on to do some functional MRI research along the lines of some of the connectivity aspects which Dr. Sridhar nicely elucidated, but here it is using functional MRI data. These findings suggested that schizophrenia patients have frontoparietal hypoconnectivity and auditory network hyperconnectivity, again mapping with the prediction brain network aberrations. So if I have to move from the prediction network deficits to some symptom experiences of schizophrenia, there is a symptom which is called as delusion of alien control, which is regarded as a prototypical manifestation of schizophrenia. In delusion of alien control, the schizophrenia patients fail to realize their self-generated movements. Rather, these movements are recognized as externally generated. The force, suppose if I have to experience the symptom, I may say, the force moved my finger and I was made to press the keyboard like this. You know, for some of us that are familiar with Star Wars, this may kind of sync well with how Darth Vader or the supreme leader Snoke, controls people. So the force moved my finger and I was made to press the keyboard. So if I have to use a predictive or a Bayesian terms, my brain fails to predict and differentially infer what is self-generated versus externally generated. Now this is where the mechanism of corollary discharge becomes relevant. This is a fundamental neurophysiological mechanism which has been conserved across species, where the suppression of sensory consequences of self-generated action distinguishes self versus non-self. In the previous presentation, as Dr. Sridhar was speaking, there was a moment where, as he was speaking, his sound was kind of fed back inadvertently, for a brief moment. So it caused kind of confusion. For a moment, I thought, somebody else is speaking. I think Dr. Sridhar also was initially clueless, though it was his speech when it was fed back. There is a confusion. This is where, if I am speaking, in this live time, if my EEG is recorded, the N100 signal, which is evoked by speech sound, will be suppressed. But if it is fed back, it will not be suppressed. So that's where, maybe Dr. Sridhar got puzzled what is happening. This kind of accidentally happened, which is a nice illustration of the corollary discharge phenomenon. Now, to explain it further, as I make a motor intention to press this keyboard, there's a motor act and there is a proprioceptive input that comes back from the spinal cord. At the same time, there is a kind of forward signal which is called as efference copy, which is fed to the comparator system, that is the parietal cortex related system. So if the efference copy, that is the forward plan, and the re-efference copy, that is the feedback signal, match with each other, my brain will infer that the action is generated by self. On the other hand, if there is a disruption in this corollary discharge mechanism, for instance, if there are aberrations in the self-monitoring system where the parietal cortex plays a critical role, the actions and the words and the inner thoughts I have will be misinterpreted as something which is generated from elsewhere. So this is one component that can help us understand the experiences in a person with schizophrenia. So in delusion of alien control, I may say that the force moved my finger, I was made to press the keyboard. Then at that time, if I kind of talk to myself, maybe the alien is controlling me. If it is a sub-vocalization, because of corollary discharge deficit, this sub-vocalization will be seen as a voice which is coming from outside. So that perhaps may help us to understand the basis of hallucinations. So there are some studies that we have done. This is Dr. Anushri, who's a colleague that works with me. So where we were able to demonstrate in patients with schizophrenia, the corollary discharge mechanism is disrupted. So when they are subjected to this kind of talk versus listen paradigm of the subject's own voice, the suppression doesn't happen. So it kind of aligns with the risk and the genesis of hallucinations. Now, so these are certain aspects which will help us to understand the neurophysiological basis and neuropathophysiological aspects of symptom genesis in schizophrenia. But what we have always been interested is to see how we can translate it and make it meaningful to create an impact in patients' persisting symptoms. So there are several set of studies that we have done in parallel which demonstrated that schizophrenia patients have neural plasticity deficits. And there are theoretical postulates which have been proposed from our team as well as from elsewhere that these neuroplasticity aberrations can explain corollary discharge mechanism. So we were looking for different techniques that can modulate neuroplasticity. One of the technique is this transcranial direct current stimulation, which is based on a simple principle that weak direct current can modulate neuroplasticity. So this is a brain stimulation technique which is non-invasive and safe. The reason I'm mentioning it as safe is about 10 years before when we imported the device for the first time, we knew it was safe, but we didn't know how it will be in terms of experiential. So, I was the first person where we applied the electrode on oneself and see how it felt. It was good in the sense it was tolerable. It was also my anniversary day, so I told my wife in the morning before leaving to the lab that there's a device which has come and today I'm going to test myself. I will be the first and my colleague will be the second. So she told, make sure that you don't forget me by the time you are back at home. So in terms of schizophrenia, if you look at the network-related aberrations where certain nodes are critically abnormal, two important regions, that is the temporoparietal region, which is associated with the genesis of positive symptoms like hallucinations and delusions, And there are also negative symptoms like amotivation, which is associated with reduced activation of the prefrontal cortex. So there is one brain region which is hyperactive abnormally, that is the temporoparietal junction, and there is another brain region which is hypoactive, that is the prefrontal cortex in patients with schizophrenia. So there is in some way there is a nice situation where we can use the anodal and cathodal current administration of TDCS to suppress at one level the temporoparietal hyperactivation, at the other level to enhance the prefrontal hypoactivation. So using this non-invasive brain stimulation technique, which kind of can be applied as I talk, the TDCS can be applied on me, and it is very well tolerated. And we gave twice daily session for 5 days in patients that did not respond to antipsychotic treatment, but continued to have persisting auditory hallucination. There was clinically significant response, which we reported a few years before, and then went on to replicate these observations with modified techniques which are refined in terms of more focal neuromodulation. In parallel, we also did some studies where we could see that when we compare the electrophysiological signals before and after TDCS, as hallucinations improve, the corollary discharge deficit gets corrected. So, and very recently, especially in the context of COVID, we have been able to administer what are called as accelerated protocols, so that the entire treatment duration can be compressed in 2 days rather than the usual protocol of 5 days. Now, at some level, it may all look very elegant and simple. There are clear mechanistic bases and there are tools to correct these problematic symptoms. At times it may make us to think if the brain is so simple. But as I mentioned yesterday, if the brain were so simple we could understand it, we would be so simple we couldn't, which was kind of evident by some of our observation. Like there are patients, when we apply identical protocols, identical symptoms, identical illness chronicity, one patient responds excellent, another patient doesn't respond at all. So this is an illustration of how some of the computational neuromodulations can help us to understand how the differential brain neuroanatomy may influence the electrical field spread. For instance, in the responder here, the peaking of the electricity happened in the temporoparietal junction. That's where we wanted. Whereas in a non-responder whose brain looks very different, it is peaking somewhere else, so there was no improvement at all. So this was a post hoc analysis. What it means is we need to be more personalized and try to incorporate the inter-individual brain anatomy variation in terms of placement of the montages. So towards that effect, we have been working on this Clinical Research Center for Neuromodulation in Psychiatry, which has multiple components that Dr. Gopalakrishnan mentioned yesterday. There's a patient-oriented clinical research, multi-level assessments, there's a strong clinical research training program. There are numerous clinical research training fellows who have been kind of trained under this program. The program is in the last stages of completion, and we have been quite strongly committed to moving the science of neuromodulation to society. And in that context, we have been working with engineers from the Debel DRDO, where we have designed and developed in collaboration with the Debel team indigenous cost-effective TDCS device which can be used at home. So this is something which we have initiated, and we have been successful in a preliminary set of patients. So this is the first publication that have come in terms of using this neuromodulation technique at home. So this is the only neuromodulation technique which can be administered at home. And the TDCS beyond schizophrenia has a lot of applications in depression, in mild cognitive impairment, and many other chronic pain conditions. So the neuromodulation science is kind of getting translated from bench to bedside. Now it is going beyond. So with this, I'll come back to the first slide, which is the last slide of mine. So in this talk, I try to share some of my learnings with respect to the link between prediction network and schizophrenia, and connect it with the plasticity and how this plasticity modulation can be harnessed to treat some of the persisting symptoms. This is just the first step of the complex work and efforts that is required. I think that is where we need lots and lots of collaboration with people like, say, Dr. Sridhar, who can help us to understand connectomics much better and take the treatment tailored to that particular individual, which of course is the goal of our program, that is individualized schizophrenia treatment and the reintegration program, which is the INSTAR program. With this, I will stop and acknowledge the funding agency and several of my teachers, students and colleagues. Actually, my students do all the hard work and I do the easy part of it in terms of coming and talking about it. And this is the team that works with me who come from various different specialities, and these are the other collaborators that work across the different institutes. Thank you again for this opportunity.
Thank you very much. So let me begin with a question. So, based on connectomics, is there a multi-electrode system that would be superior in some sense?
Yes, that's right. So that's what we are kind of working on. I think Dr. Nivetida may also be dwelling into, like I was primarily focusing on regional modulation. The multi-electrode device will help us to modulate the network, and that is something which is ongoing. I think Dr.
Yeah, look forward to her talk too. Yeah, any questions from the house, please?
Talk about electroconvulsive therapy a long time ago. And now we're talking about neuromodulation using almost the same principle. And that's gone out of vogue. Is it just that the voltage has decreased and now it's been changed into a more exotic name of neuromodulation?
Right. Yeah. Thanks for this very important question, sir. Electroconvulsive therapy is an age-old technique. It is still very relevant and we use it very extensively. The principal difference between electroconvulsive therapy and modulatory interventions like TDCS is that ECT or electroconvulsive therapy principle is based on evoking a seizure, a fit. It is kind of rebooting the brain. Whereas in TDCS, there is actually no action potential that is generated. It is basically some subtle shifts in the resting membrane potential, which modulates the neuroplasticity, based on some of the neurotransmitter and other mechanisms that we discussed the other day. So one wants to kind of evoke seizure, that is ECT, whereas the TDCS will not cause seizure. So that's one of the reasons why it is kind of going towards home. So there is something in between which is transcranial magnetic stimulation, which again evokes an electrical action potential, but in a controlled way so that it doesn't get generated into a seizure. Of course, there is a very small risk. There is also one more recent advance of the electroconvulsive therapy, which is called as magnetic seizure therapy or MST, which evokes more focal seizure so that the cognitive deficits are minimal. In terms of clinical application, if somebody has to undergo TDCS, the person has to be extremely cooperative and be willing to undergo the treatment. Whereas in people that have significant agitation, aggression, and suicidal risk or catatonia, we prefer electroconvulsive therapy. But thanks for raising that very important point, sir.
Thank you, Professor Bihari. Yeah, please.
Fascinating talk, Dr. Venkat. We know that a lot of young people or even aged people often get modulated by some of their gurujis in positive sense, some of their gurujis in different negative things. And sometimes, that modulation could be termed as hard as terrorism. Now, my question is that they are not using your system, any modulator, but they are able to modulate their belief system even. So I wonder here, is the machine is more powerful or the dialogue? So if the dialogue is so powerful, why not we can counter and reduce this problem across the world with some dialogue? That's one. Second, if your machine can modulate, I see a big potential to bring peace around the world.
So those are profound statements and profound questions. Now, the uniqueness of humans is also kind of influenced by how malleable and adaptive our brains are. Now, when I was mentioning about neuromodulation, this electrical energy is one window through which we can modulate. Anything can modulate our brain. Like as we interact now, I am kind of getting some new perspective. It is getting modulated. So if you are going to be very forceful, you may convince me after persuasion that I should use to bring peace to the world using this device. So exercises can modulate, neuromodulate, yoga can neuromodulate, but the intensity of or the impact of these neuromodulations vary. Somebody who can profoundly communicate can influence me much, much more than somebody who is subtly persuasive. So that's one level. The second component is, yes, the learning can be modulated when somebody is given something like TDCS. Actually, this has been used in certain defense applications where when the pilots are trained to pick up the radar targets, the training period can be reduced significantly when it is combined with the TDCS. So DARPA has kind of used it quite some time before.
Great, thank you. Thank you very much. Please join me in thanking Professor Venkat Subramaniam again. Thank you. Thank you, sir. So it's my pleasure to introduce our next speaker, my colleague from IIT Bombay, Dr. Nivedita. She's a professor assistant professor in the Department of Biosciences and Bioengineering at IIT Bombay. Her work is in cognitive neuroscience and neuroimaging. She seeks to unravel how the brain decodes perception, memory, and behavior. She's a medical doctor, after which she earned a PhD in cognitive neuroscience from the NBRC in Manesar, and then pursued postdoctoral training at Cambridge, UK, and she has numerous research publications in reputed international journals. She is an active member of the Society for Neurosciences and the Cognitive Science Society. Her interdisciplinary work continues to inspire innovation, curiosity in young neuroscientists, and she inspires a lot of startup and hackathon activity also, which I've had the pleasure of being involved with as well. Yeah. So, Dr. Nivedita, all yours.
Good morning, everyone. Thank you very much for the kind introduction. I don't know, maybe there are slight changes. So I don't work in memory behavior. I will tell you, I work in the area of movement. And my postdoctoral research is not from Cambridge. I wish I did, but it was from NIH Bethesda. But thank you very much, Professor Bellare and Professor Venkat, for the invitation. Yes, so it's both, the previous speakers have made my job easy as well as hard. Easy because they familiarized you with a lot of jargons that I am also going to use in my presentation, and hard because as a novice with an independent lab, a very young lab at IIT Bombay, not even 4 years old. So I'm going to show some data, but may not be decades of work that has been shown before by the previous speakers. So, okay, this is... Yes. So I'm going to start off again with where Dr. Venkat left about neuromodulation, essentially modulating or altering the neural activity in your brain. And how can you redefine targets? So one important thing that he said was about responders and non-responders of neuromodulation. So you give the same stimulation to two different patients. One of them responds, the other does not. Even if they have very similar symptom profiles. So then there has to be something that is different. And we did a study where it is not just the anatomical differences, that structurally my brain is different from yours, but there's a lot of functional differences in the brains of two individuals rather than the structure. So how can we redefine these targets of neuromodulation is what I will talk about. For a very quick introduction, I'm going to categorize very broadly the brain disorders into region-centric and network-centric. And we're going to talk about more network-centric brain disorders, which typically include psychiatric disorders like schizophrenia and depression, and also another category of neurological disorders, which we call movement disorders. Some of you might be familiar with Parkinson's disease, essential tremor, and so on. So these network-centric disorders are not like the very focal or region-centric disorders like stroke or brain tumor, which you know the symptoms are very specific, arising from a single region in the brain. But these network-centric disorders are a spectrum, present with a spectrum of symptoms. Symptoms of one patient may not be similar to the symptoms of a second patient that you might see presenting with the same disorder. Particularly movement disorders are a very good example of network disorders. These are, like the name suggests, movement disorders. Patients have difficulty in producing and also controlling body movement. It could be increased movement or decreased movement. Increased movement in terms of hyperkinetic, that is, they're producing more unwanted movements like tremor, or it could be decreased movements wherein they have difficulty in even initiating movements like slowness of movement, as you see in Parkinson's disease. I'm seeing the YouTube screen here. So, movement disorders, so there are two different networks. So, specifically in movement disorders, if we have to identify two specific networks that are implicated in movement disorders, which networks are affected in movement disorders, there are two of them if I have to specify. One is called, these are the loops. So one is called the cortical basal ganglia thalamocortical loop here that you see. So from the cortex, from the superficial part of the brain, the connections go into the deeper part of the brain, the basal ganglia, then to the thalamus, and then again fed back into the cortex. The second loop we're talking about is the cerebello-thalamocortical loop. Again, this is a second loop which originates from the cerebellum, again via the thalamus, goes to the cortex, and then gets fed back in. So these two loops, again, are not independent. They are also interconnected and interrelated. And problems in any of the nodes within these two loops is what causes any of these movement disorders. A very nice review summarizes that if you're looking at these different nodes as different layers of this illustration, you see the cerebellum, the nodes in the basal ganglia, and also the nodes in the cortex. By cortex, it's a vast area of the cortex, not just the motor cortex, but also the prefrontal, the anterior part of the cortex, also the posterior sensory regions, and so on. So what these are the different movement disorders that we know of, and each movement disorder essentially is causing some disruption in this network. The only difference is that the entry point of this disruption might be different at different nodes, and the way they propagate into the network, causing the disruption in the communication between nodes, is different in different disorders. So now this says that the hardware is very similar, but then the software, the corruption of the software that occurs is what is different to bring about these different movement disorders. So now when we have these network problems, how can we restore them? So of course, neuromodulation can help here. And unlike in psychiatric disorders where we have a good amount of literature on non-invasive brain stimulation, in Parkinson's disease or movement disorders, we have more literature in invasive neuromodulation. Here what we do, we implant electrodes into the deeper brain regions and put a pacemaker, something like a pacemaker that is connected to these electrodes, which keeps stimulating the brain at very high frequencies, above 100 hertz. So now this stimulation changes the circuitry inside, the network inside, and causes very good improvement in the symptoms of the patient. So an alternative are other methods like transcranial. You can use electromagnetic stimulation or TDCS that Dr. Venkat mentioned about already. But the thing is, we know that targeting pathological networks will give you better results rather than targeting isolated nodes for these disorders. But how do I know which network to target? So Dr. Venkat mentioned that they tried the TPJ and the prefrontal cortex for stimulation, and then they've narrowed down to the temporoparietal junction. But again, there you see different responses in individuals. So it's probably not just the node, but the network that you want to target should be more consistent across patients. So in literature with Parkinson's disease, what they use is, again, with invasive neuromodulation. They show that so this is the network. This is the normal Parkinson's disease, normal individual, the basal ganglia thalamocortical network in the normal individual. And in Parkinson's disease, there is a problem which results in lower motor output, less motor output. But what happens when you put an electrode there and stimulate at the basal ganglia, it kind of uncouples this network. So the input and output of a particular region of where it is stimulated, it uncouples it, and therefore restores the motor output to normal levels, or at least near normal levels here. So essentially what it is doing is a lesioning of a particular region without actually scooping out the tissue. So this is what DBS does, the deep brain stimulation does. And this is one example. And then what people have done is to find out what exactly, so what I can do, I can stimulate, and then I see that there is symptomatic improvement. And then retrospectively, I can look at the scans of multiple. You can see these tracks are very familiar, so this and the connectomic tracks. You can see stimulating at which part of the tissue results in improvement of which kind of symptom. So a tremor patient would improve by being stimulated at a certain part of the small region that you're putting the electrode, whereas a person with gait impairments will benefit from stimulating a different node in a different part of the same node, but different tracts. So they've shown that retrospectively that you have to focus more on the tracts, on the fibers, on the connections, rather than the same tissue. That is the node that you're talking about, that is the subthalamic nucleus. So this is in Parkinson's disease. They showed very nicely that there are different fiber tracts that work best for patients with different symptom profiles. And the same thing was shown in patients presenting with different kinds of disorders, including obsessive compulsive disorders. There are 4 different disorders where deep brain stimulation was done in the subthalamic nucleus. But then you can see that the fibers are going to different parts of the brain in patients with different disorders. Say, for example, in obsessive compulsive disorder, the fibers that were more successfully addressing the symptoms or reducing the symptoms were connected to the frontal part of the brain, whereas with Parkinson's disease, you see the fibers tracts are the ones that are connected to a different part of the cortex. So this shows that, say, if I target the brain more superficially here with non-invasive brain stimulation, I'm more likely to be also neuromodulating the deeper region here in the subthalamic nucleus, specific to obsessive compulsive disorder, or to Parkinson's disease, or to Tourette syndrome, or dystonia, and so on. So, but these are studies from, say, probably a couple of decades of work in hundreds of patients with DBS done in multiple hospitals. So in our lab, what we looked at, we wanted to address this problem of dyskinesias. So these are in patients with Parkinson's disease who levodopa is the gold standard drug of choice for these patients. But what happens is when they keep taking this medication, over time, like say within 5 years, about 50% of these patients develop symptoms of these kind of abnormal movements, uncontrollable movements that you see here. This is because of the medication, and the therapeutic effect of the medication becomes narrower and narrower, and the side effects become more and more with increasing time. As of now, we do not have an effective medical treatment for this, and deep brain stimulation is the only solution that works. And unfortunately, not more than 5% of patients are eligible or can afford DBS. So what solution do we have for the remaining 95% of them? So the idea is to identify cortical targets which can be used as proxies of the deeper brain region to bring about changes in the brains of these patients. And for that, we used a multimodal MRI study wherein we recruited a few Parkinson's disease patients, some who were dyskinetic, some who were not dyskinetic, along with healthy controls. And we did structural, functional MRI. In functional MRI, you're looking at the activity of the brain when the person is just lying inside the MR scanner for 8 minutes, not doing anything. And then we did 2 task-based MRIs. So because the function of these, the different motor as well as cognitive functions, we want to see what exactly is the difference in the connections when the brain is actively doing a movement or when the brain is actively doing some kind of cognitive task as opposed to just in a resting brain. And it is pretty challenging to do this in patients, especially with dyskinesis, because there's a lot of movement, and MRI scans, you don't want so much of movement. So we did this when the patient is on medication as well as off medication. So what does dopamine, the medication, do to these networks when they're doing these tasks? So this is the work of my first PhD student who's just about to graduate, Sakshi Shukla. And what we observed is just in resting, I'm not showing the structural results, but just functional connectivity wise, in a resting brain, what we saw was in dyskinetics. Oh, this is not showing the brain here. Yeah, so the brain is not seen, but anyways, so what you see here is blue means decreased connections. So you see there is decreased connectivity between the cortex, that is the IFG is a cortical region here at the frontal part, and the deeper basal ganglia and the thalamus region. So the network shows decreased connections even at the resting state in dyskinetic patients as opposed to non-dyskinetic patients. Now, specifically looking at the task. So what happens when they're doing a motor task? It's a very simple motor task. The patients did the task inside the scanner while we were scanning their brains. And they did they would see when they're lying down, they're seeing a screen, and what is projected on the screen is shown here. So they see 4 different circles, and they're given a response box which has 4 buttons. So they keep pressing the buttons corresponding to the dot that lights up to be red here. So if they see a dot, the first dot lighting up red, they press the first button. If they see the third dot lighting up red, then they press the third button. So this keeps going on for 20 seconds of movement, followed by 20 seconds of rest. And this was done for 4 minutes in 2 runs. So essentially 8 minutes of the motor task. It's just a sequential finger movement task that they were doing inside the scanner. And then we looked at what the brains were doing. So first, the behavior-wise, we saw that this is, in y-axis is the reaction time. Higher the reaction time, the slower they were. And what we see is dyskinetic patients in the off state, when they were not taking medication, were slower in making these movements, as opposed to when they take the medication. Obviously, they became faster when they took medication, and this was pretty much significant only in dyskinetics. All the non-dyskinetics also had a slower reaction, was slower, but not as slow as the dyskinetics. This is the behavior, but what does the brain network show? So this is the activation pattern of the brain, where we can see, so these are the different colors, what you see here. This is the comparison of dyskinetics against non-dyskinetics in the off state, that is when they're not taking medication. Overall, we see that there is higher activation levels of the brain, that is especially the regions of the motor network that are showing up, lighting up more in the dyskinetic brains as opposed to the non-dyskinetic brains. This And if you look at, this is the whole brain activation, and if you look at specific regions, which are regions of interest within the motor network, you do see the same thing. So there's higher activation of the brain regions in the motor network when they are not taking medication, when they are off medication in dyskinetics, and this gets restored, or at least comes back to similar levels when they take the medication later. So essentially, this shows that they are becoming slower, but the brain is really showing up, flaring up of activity, which means that there is inefficient recruitment of the tissue, the neural tissue, to compensate for the movements. But this is what we see in the motor task. This is only activation maps, but then we did not see, we looked at the connectivity analysis, so then the networks within this network, and we didn't see any difference in the connectivity of the networks, but just the nodes that are more activated. So then looking at the cognitive network. So for the cognitive task, we did something called the probabilistic reversal task. So essentially what we're doing here is looking at the cognitive flexibility. So when a rule changes, can your brain adapt to the new rule, and how easily can you adapt to the new rule when you're given a reward? So this is called, so here what you see, what we showed them on the screen are two different symbols, abstract symbols. And one of these symbols, we told them, one of these symbols is associated with the reward 80% of the time, not 100%. So 80% of the time you will get a reward if you chose the right stimulus. So initially, by guesswork, they figure out which of the two stimulus will give them a reward, and they keep choosing that. And after some time, what we do, we reverse the reward outcomes. So now the stimulus which was giving the reward will no longer give them the reward, and the other one would. And they are supposed to identify when this reversal happens. So essentially, they have to learn that the stimulus and the response association that they have learned, they have to unlearn it and reverse the association now. And this is an aspect of cognitive flexibility. And what we see is that, of course, they are making, so the dyskinetics are making more errors in identifying which stimulus gives them the reward. And they are also taking longer to respond. And most importantly, they show less number of reversals. So they're cognitively very rigid. They are not flexible. And they are they take more number of trials to learn that this reversal has happened. So this is what we see in the behavior. But what about the brain network? In the brain network, we did not see, because this was an event-related design, we didn't have enough trials to get significant responses in the whole brain connections, but at least in ROI, so regions of interest within the cognitive network, we see that there is higher activation of some of the nodes which are involved in cognitive flexibility, and this is only in the off state, very similar to what we saw in the motor network dysfunction. So they are failing, the brain is firing too much, but then they are not able to, this is for compensating for their inability to perform the task, but then they are not able to get there. The behavior is still not restored to normal levels. But what we also see here is the differences in connectivity. We see here that in the brains, you're not able to see the brain outline because of the projector, I think, but there's an outline of the brain here. So what you see is that these kinetics have lower connectivity between the basal ganglia and the cortical regions. So the connections are poorer. So there's more activation, but they are not talking, the regions are not talking to each other as effectively as they should be. So even though the activation levels of individual nodes are higher, the communication is disrupted between these nodes. And that exactly is what we see in dyskinetics as opposed to non-dyskinetics. Further, because the basal ganglia, the caudate node caudate is what showed up. What we looked at is specific sub-regions of the caudate. So here we took the basal ganglia atlas. We divided the caudate region, which is part of the basal ganglia, into 3 different groups: the head, body, and tail, because this is this C-shaped structure that you see here. And then what we found was only in the motor task, the disconnection, that is the connectivity is poorer only for the connections with the head and body of caudate with the motor cortex. And when they did the cognitive task, it's the tail of the caudate and the connections with the dorsolateral prefrontal cortex that is poor. So essentially, even within the caudate, you have specific networks that are showing poor connectivity in a task-specific manner. So just resting state does not give you too much information about how this disconnection happens within the nodes of the network. So essentially, to summarize, I've showed you that movement disorders are arising from network dysfunction, and therefore there can be considerable benefits by using neuromodulatory interventions. Although most of the evidence in movement disorders literature is from invasive neuromodulatory techniques, we aim to shift this to gather more evidence to say that non-invasive neuromodulation techniques, when targeting the right network, could be as effective as the deeper brain regions as well, targeting the deeper brain regions as well. So we showed that both in motor task and in a cognitive task, you can see these differential behavior, that is higher activation but poor connectivity, and this is not able to compensate for the lost behavior in these patients. Finally, we also show that during a task, we do show that there is task-specific decoupling of the cortical and the basal ganglia regions in patients with dyskinesias as opposed to those without. And finally, this is only, again, correlational neuroimaging results. So correlation does not mean causation. So the next step would be to identify which of these nodes with, say, TMS, transcranial magnetic stimulation, or electrical stimulation, which of these nodes will give us better clinical outcomes, or at least help us in improving the behavior in these patients. So that would be the next step. Yeah, with that, thanks to my lab again. These are my collaborators, Dr. Rupa Rajan, neurologist in AIMS, where we recruited patients from her clinic. Dr. Shule is my collaborator from Yale, who helped with some insights in the image analysis, and Dr. Arpan, who's coordinated the scanning at NBRC in Manesar. And thank you.
Thank you very much, Dr. Nivedita. Sorry for that introductory snafu, but wonderful talk. So I see a couple of hands. Yeah, please.
Great talk, Dr. Nivedita. Just very basic questions. I'm not from the field. So with the progression of the disease, does the network change? Because you showed the networks in the beginning. So
Yes.
does the network change? And then follow-up is that if the network changes, then if the treatment is based on the network, right? Because the symptoms change in Parkinson's disease. So how is that taken care of?
So yes, so that's exactly what people aim to do. What is called that's something that people are trying to achieve. Yet it's not there. Adaptive connectomic stimulation, wherein you are trying to analyze. So every time the patient comes, you kind of refine the network. Again, redefine which network you want to target, and the electrode or the targets that you want can be modulated as per the requirement of the symptoms. So it doesn't have to be just to suppress the symptoms. It can also be to not have unwanted side effects. So both of this should be done at the same time. And in DBS, as of now, there is a program. They do clinical programming to do the same thing, to address the same thing. By changing the intensity of stimulation, by changing the location of the electrodes that are active, and so on. But that is still done in a very crude trial and error manner, rather than more systematically, because we don't have data to address this systematically yet. And one more with the multiple sites of stimulation, there's at least a collaborator of mine in Finland who works on multi-locus TMS, where you want to wear a helmet, and then at millisecond precision, you can digitally change the electric fields so that you can stimulate different regions at millisecond precision over time. So that is something, again, coming up, but it's not yet there in the field.
Yeah, perhaps you could even do some sensing and see how the connectome changes with time, and do that dynamically using the same sort of a theranostics approach there. Yeah,
Yes,
great.
yes.
Thank you. You have a follow-up, ma'am? Yeah, please. Yeah, yes, Sanjay.
Yeah, thank you for this nice presentation. I mean, really good work. There's a word of caution here. See, normally what happens is that in normal circumstances, whenever the agonistic group of muscles work, the antagonistics relax. So the motor activity of the brain actually decreases, and the metabolism of the brain decreases, which is picked up by the bold images. Now here, whenever somebody has dystonia, you have hyperkinetic movements of both the agonist as well as the antagonist. And that may be responsible for the higher amount of motor activity that you see of functional MR imaging. And it may not necessarily be diagnostic of a particular segment of the disease.
The higher activation.
Yeah, because dystonia causes significant
Right.
increase in tone, significant increase in basal ganglionic stimulation of the entire motor cortex stimulation. So when you see a motor signal on functional MRI, it may not be reflective of the disease. It may just be increased metabolism because of the bold signals, the blood oxygen level dependent bold signals of that part of the brain, simply because the agonists and the antagonistics are working together.
Right,
That's
point taken. But what we see is that, again, it's more interesting because what we see is that activation, the connectivity differences that we see are not with the motor cortex, it's with the inferior frontal gyrus, essentially the inhibitory signal that is not really inhibiting what it's supposed to be inhibiting. So essentially,
because we are doing
disinhibition-
in Sri Chitra, we have made the deep brain stimulator, which will be sold for about 5-6 lakhs. It's already been translated. And we are doing the testing, and also we are doing the largest number of deep brain
DBS.
stimulations for movement disorders in the country.
Yes, and Dr. Rupa Rajan was trained in
Yeah,
Sri
yeah.
Chitra, yes.
So basically, there when you're looking at functional MRI signals, it's metabolism, increased metabolism and oxygen extraction for a portion of the brain.
Yes.
But that increased activity of the brain may be because of simultaneous work of agonists and antagonists as occurs in dystonia.
Agreed,
That's the
agreed.
first point. The second thing, just things which you need to work on. Like if you give, say, a simple medicine like anti-vomiting medicine, metoclopramide, that also causes dystonia. And as soon as you withdraw the drug, the dystonia disappears. Here, you are having dystonia, which is persisting dystonia because the medication, dopamine, not because of some structural changes which are occurring in the brain. So this is another point that you need to really look at. Dystonia is basically because of the medication, not because of Parkinson's disease. So, you please understand this. This is also a very important thing. There are phases of Parkinson's disease. The first is when they start responding to dopamine.
Right.
The second phase is when you give dopamine and they don't respond. So then you give carbidopa, where acetylcholine decreases and dopamine you give simultaneously. So that takes care of it. Then there's another stage where dystonia occurs because you're giving dopamine.
Yes.
You understand?
So
Dopamine causing dopamine.
that is why here we compared dyskinetic and non-dyskinetic Parkinson's patients. So Parkinson's disease is there, and we matched the disease duration and everything, but one category of them had a dyskinesias, the other category did not. And that is why we did, so this is nothing really, and I didn't show any comparison with healthy controls and Parkinson's. It's both Parkinson's disease, but one category developed dyskinesias and the others did not.
So there's one more thing that you need to specify whenever you're doing this research. There is this next phase of Parkinson's disease when even deep brain stimulation will not occur because they are starting to develop non-motor symptoms and degenerative changes. So here you have to eliminate that group before you actually show
Yes.
that the structural pathways have changed.
Yes, so we did see some structural changes. We did look at structural changes. We did not see differences in the structural, except in the inferior frontal gyrus volume changes. That was the only thing that we did. Second, we did look at cognitive scores before recruiting them. So they were all not different. Were not under the MCI category also. So cognitively, they were all intact before we screened them for the study. Yes, we did that. But yes, so we are planning to look into more electrophysiology rather than the MRI, because I think electrophysiology makes more sense to look at these connections, especially when you're stimulating with different frequencies and so on. So that is a different work that is currently ongoing. But MRI-wise, this is the main reason is because we don't have access to the deeper brain signal when we are looking at electrophysiology, which MRI gives you. That is the only reason why we have to do this, and not just EEG, where we can just look at the cortical region. So we wanted a proxy for something that is happening deeper inside on the cortex. And if we don't know what is exactly how these are related, then we don't know. Otherwise, we just blindly keep stimulating on the cortex, and we are not going to get there anymore. So there are pluses and minuses to both in these techniques, especially in human, you know better in clinical studies. But this is one aspect of the other part of the work that we are currently doing. Yes.
Thank you very much, Sanjay, for those questions and comments. And thank you, Dr. Nivedita, for that. With that brings us to the end of this. A round of applause for her, please. Thank you.
Thank you to all the speakers. Now I would like to call up on stage Professor Jayesh Bellare to felicitate our speakers. Can I please have on stage Dr. Sridharan Devarajan, please? Next we have Professor Venkatesh Subramaniam Ganeshan. Can I please have Dr. Nivedita T on the stage, please? The chair of our session. Can we have a big round of applause, please?
Fellows to whom we have sent out this message with regard to the poster evaluation. I understand that there has been some sort of a communication gap, and I think probably that is befitting the timing of our first session topic, which is with regard to the network. So we also had this network connection, not only with regard to communicating this message to our esteemed colleagues, but then I think we also had the network issues with regard to the Wi-Fi connections. We also had the network issues with regard to the online display. So I think all are amalgamating and transforming into this particular stage. Now, I just wanted to put up this request that I think many of our guests, they have, because the registration kit and the delegate bag, wherein we have put up this poster evaluation sheet scores, that was put up in your delegate bag, but then I think many of our guests have moved out from the assigned hotels to the guest house or maybe to some other location, and they have probably not collected their delegate bag. So I think you have, probably you might not be having that poster evaluation sheets with you. So we would personally hand over it to you. But then as was mentioned in the morning hours, it's actually, we are going to have for the physical sciences from P1 to P40. And for the biological sciences, we are going to have it from P1 to P60. We would personally hand over those sheets again to each one of you. And the other thing is, maybe for many of you, it might not be matching exactly with your area of expertise. But then since it is biological sciences and physical sciences, so the allotment has happened for 10 posters per our evaluators. So that is one. And we are requesting you to probably just give 3 minutes of the time to each poster. We have already marked what is the criteria that has to be used for the poster evaluation. And accordingly, after the poster evaluation, you can hand over the sheet to the sectional president, which is Professor Sanjeev Mishra for the biological sciences and Professor Annapurni Subramaniam for the physical sciences, or to any one of us if you are not able to meet Professor Mishra or Professor Annapurni. Thank you very much.
Can I please request all of you to please carry your water bottles along with you, and we'll see all of you here at 11:30.
I have left it here where I am sitting.
That's okay.
have the attention of one and all present here. We are soon going to start session 5, so I request all the participants to be seated in hall number 2.
Inside, not outside.
A very good morning to one and all present here. I am Dayashankaran, the host of your session 5. It's a great pleasure to welcome you all to session 5 of the 95th annual session and symposium of NASI. We are honored to have Professor Ramashankar Verma, a leading expert in biotechnology, stem cell biology, and molecular medicine as the chair of this session. Professor Verma is the director of MN in IIT Allahabad and formerly headed the Stem Cell and Molecular Biology Lab at the IIT Madras. His impactful research on stem cell transdifferentiation, tissue engineering, cancer therapeutics, and rare disorders has earned him international recognition. With over 200 publications and 23 patents, along with his distinguished service on national scientific committees, he is widely respected for his scientific leadership and mentorship. Please join me in warmly welcoming Professor Ramashankar Verma.
Good morning to all of you. Welcome to the session 5. I think we have 3 speakers in this session. 2 are online. The first speaker is Professor Arun. She is a professor, Center for Neuroscience, Indian Institute of Science, Bangalore. We extend warm welcome to Dr. Arun, professor of at Center for Neuroscience, IIT Bangalore, a leading neuroscientist renowned for his pioneering research work on visual perception and objective recognition. He earned his BTech from IIT Madras and PhD in neuroscience from ISC Bangalore, followed by the postdoctoral research at MIT, USA, a recipient of the Santi Sharu Bhatnagar Prize. and INSA Young Scientist Award. Dr. Arun has authored numerous high-impact papers, book chapters, a fellow of Indian Academy of Science. He continues to advance understanding of brain and cognition. I request Professor Arun to start his presentation. Is there? Is there.
Can you hear me?
Professor Arun, can you hear us?
Yes, I'm able to hear you. Can you hear me?
Yeah, we can. Yes, we can hear you. So now can you start your presentation. Welcome.
Okay, great. Let me just share my screen first. Are you able to see my screen?
Yes, sir, we can see.
Okay, great. Yeah, thank you for the introduction. I'm afraid some of the awards mentioned by you are not not mine, but I'll go ahead and start off my presentation. So, very sorry that I'm not able to be there in person. I was looking forward to it, but of course the whole Indigo thing happened. I hope that you could still get some, some of the excitement of this research, even though you're participating, looking at it through online. So let me get started here. So I actually, I grew up reading books of this kind, and this talks about a society where robots are interacting with us, and there are various ethical considerations that Asimov talks about. Very interesting, actually, if you have not checked it out. And but there is a big contrast to what is actually happening with AI today, although there is a lot of hype about AI. And this is best illustrated by this guy who posted this on one of the social media. It highlights the fact that AI algorithms are doing great, they're doing amazing things, but they're not doing the things we want. And one of the key things that AI algorithms are still unable to do is to solve like very simple visual puzzles. They are getting better, and so if you ask AI algorithms to recognize various things in an image, they're doing much better than before. But they're still not at human levels of performance, and certainly not at the level of performance where you can do many important practical applications. You still need to check the output of the AI, and the human still needs to be in the loop. The reason I put these on the slide is because there are still these distorted letter tests that you face whenever you're trying to make any kind of transaction on the internet, and those are there because even now AI algorithms or machine vision algorithms are not able to solve very simple visual puzzles. Okay, so this is the main core question of our lab at IISc. This is the vision lab, and we try to understand how the brain solves vision. And we do this by a number of different types of experiments. We do experiments with human participants where we're looking at behavior, brain imaging. We're looking at object perception in adults. More recently, we're looking at reading in children. We're also doing experiments where we're recording from the monkey brain, because the monkey brain is very similar to ours, and this allows us to understand the neural basis of behavior, perception, decision making, and so on. And a very integral part of our work is to build models of all the data that we collect, compare machine vision models with brains, and hopefully be able to do this kind of two-way dialogue where we can use AI algorithms to understand brains better. And if we understand brains better, we can improve AI. That's the overall sort of enterprise that we have in the lab. So how does the brain solve vision? Well, first of all, this is the monkey brain. You can ignore this for now. The monkey brain actually has a lot of different parts of the brain which are involved in processing vision. And actually, even the human brain has a lot of visual processing in the brain. And this just highlights the difficulty of the problem of vision. And actually, this is what is highlighted here. This is one of our projects that we've launched recently. You might have heard about color blindness, but there's an interesting condition called face blindness, which occurs when your eyes are normal, but the visual processing in the brain is impacted. And actually, visual processing in this part of the brain, the temporal lobe, is impacted. And that leads to this very weird kind of condition called face blindness. This condition, the other end of the extreme for this condition is something called super recognizers. These are people whose face recognition is much better than normal. And we've just recently launched a project. This is called the Indian Face Perception Project. And in fact, if you're interested, please go check out this website and enroll yourself, test yourself. You never know, you might be a person who's face blind, or you might be a super recognizer. And there's actually a spectrum of face processing ability that we'd like to understand, and also understand the reason why. Why is it that you're good at face recognition and somebody else is bad? Is there a particular aspect of your visual processing that is somehow affected, or better or worse? Right? The other condition that is very relevant for the kind of work that we are doing is dyslexia, where people with this condition are unable to learn to read, and that actually locks them out of a lot of advantages that we get by reading. And in fact, there are people who have dyslexia which is very profound and not treatable. And I was recently talking to some neurologists who actually mentioned that they actually know of 20 different types of dyslexia. So they're actually a pretty complex condition. And related to this, we have a project that we are starting where we are partnering with schools and nonprofits to understand the cognitive predictors of fluent reading. That is, what kind of visual processing does a child who's able to read very quickly have, and what kind of visual processing does a child who's not able to read so well. And of course, one extreme is dyslexia, and the other extreme is again very, very fast reading. The question is, what makes a fast reader a fast reader, right? So these are the different real-world sort of implications of our work. But I want to take you to a more basic, basic level where I'm going to talk about two stories. One is we want to understand real-world vision, and the second is to understand novel computations in the brain. Nicely, there's the first part of the talk involves brain recordings in monkeys, and the second part involves some human experiments on humans. So it gives you a nice idea or an overview of like the kind of work that we do. So let's get started with the first one. Whenever we want to study vision, the most common approach, and this is because of technological challenges, is to basically take the animal and bring it into a lab. And if you Google, you will find very commonly illustrations like this, where essentially the animal is brought into a lab and you've got to hook up wires to record from the brain, and you've got a juice reward, the animal is doing some kind of task. And what you'll immediately notice is that this is a really, really artificial setting. But it has been the major way in which you can get extremely controlled and good neural recordings. So not really criticizing that. We've done this kind of work ourselves in our lab. But it involves a bunch of different artificial settings. So for example, you need to implant something to hold the head still while you're able to track the eyes. We've got to train animals on task. We've got to implant electrodes. We've got to record brain activity. But what you notice here is that this entire set of setting actually blinds us from knowing how the brain responds during natural vision, which is what all of us as neuroscientists would be interested in. Of course, needless to say, also has huge implications for animal welfare. So what we've been doing over the last couple of years is to reinvent this entire paradigm, where instead of taking the monkey into a lab, we want to bring the lab into where the monkey is. And so essentially where the animal lives in its home environment, we want to bring the lab over there and then try to understand brain activity as it goes about its natural sort of activities. So how do we have to do it? Well, you've got to do some kind of eye tracking in unrestrained animals. You've got to train animals in a natural setting. You have to implant electrodes, of course, because we need to record from the brain. But we also need to record brain activity wirelessly, because if you have wires and the animal is moving freely, well, monkeys have hands and they'll just pull out the wire. Right? So we need to have a way to actually record wirelessly from the brain. And so this is also a huge technical challenge, because you're recording brain data at a very high resolution, but we need to record it wirelessly, so that poses a lot of different technical challenges. So this is the dream team that sort of made this whole thing work. Our goal was to understand brain activity during natural vision, and these are a number of different PhD students who worked on this project over the years. And I'll start by saying, if you want to understand brain activity in a natural setting, is it enough to just record brain activity while the animal is just sitting in this natural setting? And this is a real photo of our lab at IIT. So you can see the animal is in there. It's a kind of naturalistic environment. It's not even a cage. It's actually a room, right? And so what we realized is that it's not enough to just record the activity from the brain in this natural setting. but we also need to actually be able to record from the brain both in a natural setting as well as in a very controlled setting. So this is the kind of lab that we built to enable doing that. So there's one end of the lab where actually the animals are actually going to come and do a very controlled kind of task. And the other end of the lab is essentially this natural setting. So the animals are living here, and just like all of us, they commute through a series of doors where we can open and close and get the animal that we want into the place that we want. And then finally they come to a place, a workstation, where they'll work on a screen, just like we do, and drink some liquid reward for working on the screen, just like we do. Okay, so this is the whole layout, and this is of course much easier to say than doing it. We've spent a lot of blood, sweat, and tears building this whole thing. And the key innovation that actually we did was to install essentially a touch screen where the animal can come and do a task. And I'll show you a video of how this whole thing works. But the idea here is that if you want to understand where somebody is looking, the head can't be moving because you need to track where the eyes are actually looking. And so the way we actually did this was to install essentially a juice spout where the animal has to put his head in exactly one particular position to be able to record where his eyes are looking and where he's looking on the screen. And so this is the entire layout. So the front of the animal just looks pretty simple. It's a screen, a juice spout, and there's a grill for him to hold his hand. But in the back end, there's actually a bunch of complexity here. So there's an eye tracker, there's an infrared camera to actually look at the eyes, and the entire system diagram is just here. Yes, we're just showing it to tell you that it's a pretty complex setup on the other side. Yeah. So what do we want? How do we want to study, vision in this kind of setting? Well, we first of all train these animals to do a fairly simple task. The task is like this. The trial starts by essentially asking the animal to hold one button on the screen. Then a sample appears. There's a delay period. And then one of two images appear. Either the same sample appears again, and then the animal has to press this button, the top button, or a different image appears, and the animal has to press the bottom button. And this is a fairly simple task, but if you notice, the task actually is divided into different phases where we can study various basic components of cognition. So for example, if you look at the sample period where you're presenting the image, it's a probe for the basic visual response. It's a sensory response produced by an image. In the blank period, it's a probe for working memory because the animal has to keep the item in mind and then match it to what comes later. And so that's a probe for working memory because you're holding something in memory. And then we have a probe for decision making because the animal is now actually having to decide about the image, but he can't make a decision only based on the image. He has to compare it with what has come before. And if the thing that has come before is the same, he has to press one button. And if the thing that has come before comes again, is different, he has to press a different button. So it's the same different task, right? So just to give you a sense of how this works, this is probably the first time that any of you would be seeing, a video like this. So it's pretty dramatic that we're able to train animals to do such complex tasks. So here's the video. So we can see three views of the animal, and you can see the animal is completely unrestrained. He's completely free to do the task. He's doing the task because he wants to, and he wants to get the juice, which is pretty tasty. And so any of us would work for this kind of juice. And so that's the setup. And what you actually see over here in the central panel is that the animal actually is putting his head into a chin rest. And the moment you put his head into a chin rest, you can see that we are able to track the reflection of the infrared tracker on the eye, and we're able to get pretty good eye tracking. Okay, so this is the layout of the task. The reason we're actually doing this is because we want to ultimately compare what happens in a controlled setting with what happens in a natural setting. Because otherwise the natural activity is very complicated and we won't know exactly what's going on. Yeah? So where would we want to record from? Well, we're recording from two important regions in the monkey brain. One region which is important for recognition, it's called the inferior temporal cortex, it's in the temporal lobe. This is, by the way, the monkey brain, and this is the front of the head, that's the back of the head. And another region that we also wanted to monitor and record from is actually a decision-making region which is involved in motor activity. So when the animal is touching a button to make his choice, we want to understand how is the choice being created and how is the choice being created with reference to the visual information that is coming into the brain. And so these are two important regions that we'd like to record from. Yeah. So then how do we go about doing this? We want to ultimately understand how the brain responds in a natural setting. And so I'm going to show you two parts of the story. There's much more to be shown, but I'm just going to show you two simple parts. The first thing is like a kind of like a proof of concept. We want to understand if this will even work in a simple task. The second thing is, will it help us understand sleep and dreams? And so these are two kind of exciting, portions of this. So let's go to the first part. How, will this even work in a simple task, right? Because remember that we're taking a natural setting. And so when you're looking around in the natural world, your head is unconstrained, you're looking at multiple views of an object as it comes towards you, there's motion involved, there's 3D involved. So many things are different from between stuff that you see on a screen versus what you see in the real world. So here's the simplest task that we could think of. And so we started by saying that in a simple task, can we get interpretable brain activity? Because there is so much variability in the natural setting, we wanted to just get a proof of concept. So here's the task. I'm going to show you many trials of the same task that is happening. What's happening basically in the task is a person comes in, opens a box of food and offers it to the monkey, and the monkey takes the food and goes. Now, because it's an experiment, we're not just coming here randomly and doing things. We have a control, we have a sort of set of conditions where two different people could be coming in and three different types of food are being offered. And so that's what is being shown. But already what you can see in this collage of videos is that actually there's a lot of variability in the natural task. Sometimes the animal will actually come and reach in with his left hand, sometimes he'll use the right hand, sometimes he'll look at the box from a different point of view, and so on and so forth. Even though we tried to make this task as stereotypical as possible, still there was a lot of variability in exactly what happens in the task on a given trial, right? So what do we want to do with this? Well, the first thing we wanted to do is to say, okay, I have the neural activity recorded while these animals are looking at stuff on a screen. I can take this neural activity and say, if I imagine that each cell is one axis in a multidimensional space, I can collect all the responses I got when the animal was looking at carrots in a box, or he's looking at raisins in a box, or he's looking at a banana in a box. So this is raisins, carrots, and bananas, and so this is the RCD experiment for us. Okay, so here's the so we trained a linear classifier to use the neural responses and figure out which image is the animal looking at. And ultimately what we want to do is to say, okay, I have the neural responses on a screen. I'd like to be able to relate this to what happens in the real world. And so can I actually train a decoder which is trained on neural responses to images on a screen, and then figure out which food is being offered, which experimenter is being seen, and so on. Okay, so that's the layout.
So you have 5 more minutes.
First of all, we've got to do a sanity check. Yeah. So the sanity check is, can we actually test the decoder on new trials of the screen itself? So here's the fixation task. So we just wanted to see if I present a new trial on the screen, can I get some interpretable and can I figure out which image is being seen? And so turns out the answer is yes. We can decode the identity of an experimenter who is seen by the animal on the screen. We can also decode the food that is being seen by the animal on the screen. And so that's just a sanity check. And the crucial test is, of course, we want to test the decoder in the natural task. And what we find is that we're able to decode the identity of the food pretty well, and only to some extent weakly the identity of the experimenter who's offering the food. And now you can imagine that why this would be the case, because obviously the animal is more interested in food than the experimenter who's giving the food. And so obviously we think that that's the reason why the decoding is actually better for food than compared to an experimenter. Okay. So what are we going by all this? What we are really establishing is a very basic principle to be able to understand neural activity in the natural setting, which is to really say that we can relate what happens on the screen to what happens in a real world visual task. Okay, so that's one. There's a bunch of interesting other findings that I won't be talking about, but this is just a basic sort of proof of concept. Now let's go to the second piece. Will it help us understand sleep? Okay. Now, why do we want to do this? Well, we'd like to understand what happens during sleep, of course, in terms of how the brain activity during sleep relates to brain activity in the waking state. Ultimately, that's the goal, right? So, how do we go about it? Well, first of all, again, it might interest you to know that actually monkeys don't sleep lying down like us. They actually sleep while sitting. And so this is a brain recording that we've done from two animals while they're actually sleeping. And just like us, they sleep, but they sleep for a certain part of the night, and they keep waking up in between, and they kind of roll around or move around, and then sleep again, and so on. So this is all the neural activity that we have recorded, and the orange portions are when the animal is awake, and the blue portions are when the animal is asleep. And you can already see a kind of interesting correlation where there's kind of more activity when the animal is awake. Not very surprising because we're recording those
Recording in progress.
Yeah, can you all see my screen and hear me? Hi, can you all hear me?
Yes, sir.
Okay, yeah. So just to continue, I was showing you neural activity during sleep and wake states. And what we wanted to do in this analysis is, first of all, can I actually figure out if the animal is sleeping or awake by looking at the brain activity? And turns out, again, I'm building a linear decoder, and the decoder is simply looking at the pattern of neural activity across all the recorded neurons and basically saying, is the animal awake or asleep? And so what you can see here is the ability of our classifier to tell whether the animal is sleeping or awake or sleeping. Okay, so that we are able to do that pretty well. What is also interesting is that we can also predict the upcoming transition from wake to sleep or sleep to wake. And so this is what is shown here across a number of different sleeping events where the animal is sleeping initially and then wakes up, or is awake initially and sleeping. And you can see that just before the animal actually goes to sleep or is going to wake up, you see this transition of the decoder, which means that we are able to not only predict whether the animal is awake or sleeping at a given time, but also whether he is going to wake up or going to go to sleep. And then this again kind of makes sense if you think about it, but still interesting that we're able to find something like this. So then the additional interesting question was, can we define a dream state? Okay, and normally when you want to define the dream state, it's actually a phase of rapid eye movements. So we need to be able to monitor the eye movements of the animal. But in this kind of setup, actually we don't have access to the eye movements. So we did something else, which is what we did was to take the average pattern of neural activity in the sleep state and the wake state. And we simply computed a measure of similarity between the current neural activity and the template of the wake state or the sleep state. And so in this similarity score, a positive score implies that it's more similar to the wake state, and a negative score implies that it's more similar to the sleep state. And what you can see is that already the sleep state neural activity is very similar to the template of the sleep, which makes sense. And when the animal is awake, you can actually see that the similarity to the wake state is higher. Now this all makes sense, but there's some interesting portions of time where the animal is actually asleep because we are video monitoring the animal.
Professor Arun,
but
can you sum up please in 5 minutes?
Sure, yeah.
Okay.
So, so basically what happened to the wake state, even though that the animal is actually sleeping. So we call these as potential REM state or putative REM states, and that's what we are actually showing here. And so what we said is, well, if the animal is actually dreaming, can we take linear classifiers which are trained on food, on decoding food, and then check whether the activity of these classifiers is actually higher at the time of this potential dream state. And so that's exactly what we did. What I'm plotting is the probability of the decoder during the non-REM state, during the REM state, and the awake state. And what you can see is that the decoder probability of decoding whether there's food in the box or not is actually the highest in this potential REM state. And it's actually least in the awake state, which makes sense because the animal is actually looking at other stuff than actually the food that we were offering during the wake state during the experiment. Okay, so that's what I have. So that gives us a kind of interesting insight into what is happening during sleep and potentially what the animal might be dreaming about. And so I think since there's less time, I think I'll sort of wrap up here and maybe skip towards the end of my talk. and just say that what I've shown you is really about understanding how brain activity, is organized like during natural vision. So brain activity is pretty scary to study in natural vision because there's so many different factors, but still, nonetheless, it can be studied. What I have not actually talked to you about is that the brain is able to solve all these, solve some interesting types of visual tasks by computing a novel kind of quantity which we have defined called visual homogeneity. And I'd be happy to share more details if someone is interested. And I will just wrap up here by showing a nice picture of our lab during one of our trips and acknowledging all the people who did the work and the funding agencies that funded all this work. And I look forward to your questions. Thank you.
Thank you, Arun, for summarizing the real brain activities and the real vision. Do you have an audience? Can we take some few questions here? Any questions? If there is no more question, then we thank you, Arun, for giving. Round of applause. Thank you so much.
Thank you. Yeah.
Thank you, Arun, for such a wonderful talk. Thank you.
Thank you.
So can you move to another speaker? He's also online. He's basically Dr. Thomas Grigor Isaac from the Center for Brain Research, ISC Bangalore again. He's a distinguished neuroscientist whose research focuses on the brain connectivity, cognition, and the neurodegenerative disorders. He earned his MBBS from Calicut Medical College and MD Physiology from JIPMER, Pondicherry, followed by advanced research in neuroimaging and cognitive neurosciences. Dr. Isaac has authored numerous peer-reviewed research papers in reputed international journals and is an active member of the Society of Neuroscience. His pioneering work on the brain aging continues to shape our understanding of cognitive decline and preventive neuroscience in Indian population. He is going to speak on the title is Understanding Aging Brain from Predeterministic Syndromes. Professor Thomas, please go ahead.
And am I audible, sir?
Yes, you are audible.
Yeah. So first of all, I would like to thank the organizers of the National Academy of Sciences, the 95th annual session and symposium. And without any further delay, I would like to kind of bring to your notice the kind of work we have been doing with respect to aging brain and pre-dementia syndromes. So to understand aging brain is a very fascinating aspect. As we age, what happens to our cognition is something which is kind of being debated and discussed across the world. I will be also covering something about subjective cognitive decline. When you feel that you have a cognitive impairment, but your family members or your relatives say it's not much problem there, you are able to function quite independently. I'll be also talking something about mild cognitive impairment, which is another pre-dementia syndrome, and then something about mild behavioral impairment, as well as a new entity known as the motoric cognitive risk syndrome, and how do we study this in the community. So these are some of the aspects which I would like to cover in next few minutes. So as of 2000, we know that the aging population is increasing in India, and we have about 153 million people who are more than 60 years of age, as per the current definition of a senior citizen in India. The number is projected to increase more than double by 2050. So we are looking at a kind of an aging bomb, if we were to actually describe it. And this in turn would increase the burden of cognitive impairment and dementia. We have tried to look at aging and dementia in India and kind of what is the research happening. And we tried to kind of consolidate it. There are no pharmacological treatments for dementia. Most of the dementia, you know, like Alzheimer's dementia, Lewy body dementia, or Parkinson's disease dementia. Once the patient develops dementia, there are hardly any pharmacological treatments. But what we have are kind of disease-modifying therapies that is now emerging. You would have heard about monoclonals like lecanemab and donanemab, which all are there in kind of use, but not yet available in India. Therefore, the focus is currently on early detection, especially in the pre-dementia stage. So when you detect the pathology of dementia, which actually kind of precedes the clinical disease by at least 2 to 3 decades, you are able to identify the vulnerable population, the pre-dementia population. You can actually intervene either pharmacologically or non-pharmacologically, and thereby can modify the risk and reduce the risk for developing dementia in future. So there is something, a question often comes up. Are we forgetful when we age? We know that that's a question, and there's always a kind of misconception that aging is associated always with memory problem. So this would actually result in a lot of confusion. And to understand this, we should also know about the entity known as benign forgetfulness of aging. Yes, there is an age-associated cognitive impairment. And here the particular person is able to function independently, pursue his or her normal activities, but requires some memory support. There are occasional memory lapses. He may require a small diary. He may require to store his task in a phone, but that is only occasional requirement. The ability to recall and describe incidents of forgetfulness is one aspect of benign forgetfulness of aging. It can be assumed as normal. Sometimes the elderly may pause to remember directions, but they do not get lost in the familiar places. And occasionally there is an issue with naming. Many of us also do have that. The occasional difficulty in finding the right word, but no trouble in holding a conversation, which is known as the tip of tongue phenomena. Sometimes we may not able to get the name immediately of a particular person or an object, but after some time we may be able to recall it. That is absolutely fine. It's not dementia at that point. Judgment and decision-making ability is same as always. Actually, there's something known as crystallized intelligence, which is actually improved as you age. You are able to consolidate things. The multiple brain circuits are able to kind of compensate for any age-related problems as well. So this is typically seen in age-associated memory impairment. The classical aspect is tip of tongue phenomena and the loss of doing multitasking. So that is something which is kind of lost with respect to age. Now coming to understanding pathological condition, what is the difference between normal aging and Alzheimer's dementia? So in normal aging, you can make a bad decision once a while. You can miss a monthly payment. You can forget which day it is, but you can remember it later. Sometimes you have naming difficulty, which I already told, and you can lose things from time to time. But if you have Alzheimer's disease, mostly your executive functions are affected. You will have difficulty in taking care of monthly bills like filing taxes and all that. Losing track of date or time of the year, that is an orientation difficulty. Trouble maintaining a conversation. You have to go back to the conversation. You have to, you will forget the thread of the conversation, forget the important points in the conversation, and you have difficulty in maintaining conversation. Also, you will misplace objects. So these are commonly seen with respect to dementia. Now I have told you the biomarkers of dementia are present in the blood or in the cerebrospinal fluid or in any of the other physiological signatures much before the actual clinical syndrome occurs. So this can precede the onset of dementia by about 2 to 3 decades. So that's where you can look at pre-symptomatic conditions, pre-dementia conditions like MCI, MBA, and so on. And the first thing which happens usually is the astrocyte dysfunction, followed by the accumulation of A beta 42 in the brain, and which would lead to a low levels in CSF, as well as you can also get PET amyloid positivity. So these are the basic aspects. There's a continuum of Alzheimer's disease which has been described by many consortiums, and it has been found that many of the Alzheimer's dementia patients are often diagnosed towards the later end than much before, when they should have been actually been diagnosed. So coming to the pre-dementia syndromes, one of the latest concepts is about the subjective cognitive decline, also known as SCD. So as the name implies, subjective cognitive decline means that you will have self-experienced persistent decline in cognitive capacity in comparison with the previously normal status, which is unrelated to any acute event like a stroke or a cardiac event. It will be also based on your normal age, gender, and education adjusted performance on standard cognitive test, which is used to classify MCA. So basically, it means that you, by yourself, will feel that you have a kind of a cognitive impairment compared to your baseline before. But there is no objective phenomena. You feel, the others feel that you are able to maintain everything. You are functioning absolutely fine. And when you compare with your similar peers, there would be also no fault with respect to their performance. So that is a very, very initial stage of pre-dementia syndrome. There is a global prevalence data which shows that at least a quarter of the people, more than 60%, may likely have subjective cognitive decline. Now, subjective cognitive decline can be reversible. It can revert back to previous state, especially in people with diabetes or people with hypertension. When you actually correct that, it can revert back to previous state. Sometimes it can be stable, that it will not worsen, nor will it kind of reverse back. There is known as the stable irreversible form of SCD. Sometimes it can be irreversible. That's where we have to be careful. SCD can progress to dementia. Now, the progression to dementia, the annual conversion rate to MCI is about 5.4%, but to AD, it's much less, about 1.12%. So actually, if you see, these are very important aspects. But there is another condition known as SCD plus, wherein you are slightly more elderly, you have ApoE4 positivity, and you have a very kind of recent onset of SCD. The annual conversion rate is about 19%, which is quite important. So these are important aspects. I'll not go into much of the details, but this is something which we all can be aware of. So if you can classify SCD based on domains affected, it can be in the single domain or multiple domain, amnestic, non-amnestic. If you look at based on the patient's complaints, it can be amnestic, that is predominantly memory related, anomic, predominantly word finding or naming difficulties, amnestic anomic, where there's a combination of both, and atypical, where there are other behavioral issues as well. Now, there are some markers of SCD. We have looked at, there are blood markers, there are also MRI markers. Just to tell that the people or SCD subjects with ApoE4 carriership, there's atrophy of the left hippocampus, lower volume of the basal forebrain and CA1 region of the hippocampus. And DTI also shows significant changes as well. I have told about SCD plus, I've introduced the concept briefly. Here we know that the subjective decline is more in memory rather than other domains, and they have a larger risk of progressing to Alzheimer's dementia. Now coming to another concept which was there since last 3 decades, which is known as the mild cognitive impairment. So the SCD came in the last decade. Mild cognitive impairment was described by Peterson about 30 years back. And what they have actually looked at into is this early pre-dementia syndrome, clinical syndrome, wherein there is a memory complaint by the participant and or the family, but they are functionally absolutely fine. And the objective impairment in one area of the cognitive function is more than 1.5 standard deviation for the age-appropriate norms. So there is actually a fall in cognition, but it is in a situation where the functioning is absolutely fine, but within 2 standard deviations. So that is the concept. And if you look at subtypes of MCI, there can be amnestic, where the memory is definitely affected, and non-amnestic, where other cognitive domains, there are actually 6 cognitive domains as per the DSM criteria, of which if apart from memory, other cognitive domains are affected, you can say that that's a non-amnestic MCI. You can have a combination of both also. And both amnestic MCI and non-amnestic MCI, there's high risk of progression to developing Alzheimer's dementia. And imaging shows some signatures, not very characteristics, but actually imaging can, functional connectivity can help us in identifying mild cognitive impairment. So that's something very important. And the imaging also, amyloid PET, you can see in people with mild cognitive impairment, there is a large amyloid deposit, especially in all the areas associated with cognition, but predominantly starts with the entorhinal cortex. Now, we'll look at the pharmacological management, non-pharmacological management. Different guidelines are there. Now we know that monoclonals are available and that can be utilized, especially in those who can actually afford it, because at this point of time, it's not yet available in India. And pharmacological management should include actually discussion with the family members. And non-pharmacological treatment is often advocated. And when the family as well as the patient, and patient because he is functionally okay, they are able to kind of discuss the options, and donepezil, galantamine, rivastigmine, all cholinesterase inhibitors which are used for Alzheimer's dementia can be initiated. MCI can also progress to dementia. The annual conversion rate to all-cause dementia is somewhere around 6%. So that's something which we have to be mindful about. In India, the prevalence based on the LASI DAT study, which is the longitudinal aging study in India, diagnostic assessment for dementia is about 17.6%. And prevalence was found to be higher in older age groups, rural residents, and those with lower education. So that's something very important. In our cohorts at the Center for Brain Research, where we handle the Tata longitudinal study of aging, as well as the Srinivas Aging, Neurosenescence, and Cognition cohort, we have identified that in the urban cohort, there is about a 9% prevalence of MCI, whereas in the rural cohort, the prevalence increases to about 15%. So this is the kind of understanding that we have. And with all these concepts, we understand that MCI is the situation where a lot of interventions are now happening. But there are a lot of consensus now that you have to identify SCD and MCI. Sometimes it can so happen that the person can directly progress to dementia without going through the MCI stage. So the SCD person can directly go into dementia without going through MCI. MCI person can also go into dementia. MCI can also be stable. So identifying these unique risk factors can help us in identifying what are the particular aspects of the vulnerable population to go over to dementia. That's where the importance of understanding pre-dementia syndromes are quite important. Mild behavioral impairment is another important kind of concept which was proposed by Dr. Sahinur Ismail. And it has been proposed as a diagnostic construct which is aimed to identify people with increased risk for developing dementia. So here the thrust is on the behavior. So if they have neuropsychiatric symptoms and change of behavior, rather than cognitive impairment, it's likely that they can go into kind of a dementing situation. So that's where you look at MBI as a behavioral counterpart of mild cognitive impairment. There are a lot of criteria, some particular criteria for MBI. That is, if you should have decreased motivation, affective dysregulation, impulse discontrol, social inappropriateness, abnormal perception of thought content. And you should know that all this is there, but still they are able to maintain independence of function in daily life with minimal aids of assistance. They should not have any other psychiatric disorder like depression or anxiety. Once you rule that out, still there is mild motivation, apathy, decreased interest in activities, social inappropriate behavior. All these aspects are subtly there. We have to kind of look at identifying MBI, and this is a particular vulnerable population who can go into develop dementia. So that's where there are a lot of studies, and it has been found that MBI is actually more of at a higher risk for developing into dementia, especially non-Alzheimer's type, like frontotemporal dementia and all. The higher risk are quite huge. There is one more very novel syndrome known as the motoric cognitive risk syndrome or the motor cognitive risk syndrome, MCR or MCRS. And it is associated with increased incidence of dementia, particularly Alzheimer's disease and vascular dementia. And it is diagnosed when the patients meet for all four of the criteria. Like they should have subjective cognitive complaint, as well as they should have slow gait. So by slow gait, it is defined as slow gait speed of less than 1 standard deviation below the age and gender appropriate mean gait speed values. But they should have an ability to ambulate and absence of dementia. It's very interesting that a gait is a signature. All of us, our gaits can be utilized to identify ourselves. Somebody need not see our face, but with our gait they can identify. And any changes in gait, especially, is a very good kind of a clinical sign to identify early cognitive impairment. So that's where MCRS is quite important. And definitely the areas, because the motor system is impaired, the pyramidal, the extrapyramidal tracts are also getting affected. There are a lot of correlates. I need not go into all this in detail, but I feel that these are important aspects that we can understand. Now, I have told you about these different pre-dementia symptoms. One is the subjective cognitive impairment, the subjective cognitive impairment plus syndrome, the mild cognitive impairment, the mild behavioral impairment syndrome, and the MCRS. Now, why all this is important? Because they are conditions. If you actually see, as per the LASI guidelines, the prevalence of dementia in India is about 7.4%. That means about 8.8 million people in India live with dementia are diagnosed with dementia at this point of time. So that means that gradually the numbers are going to increase. So how do we try to work around is to understand what are the risk factors for dementia. The Lancet Commission has given early, mid, and late life risk factors. And addressing these risk factors can actually help in prevention of dementia. Now, when you also identify people who are vulnerable, like in the SCD group or in the MCI or MBI or the MCRS group, you can actually provide these interventions in a larger and a deeper scale and reduce the kind of incidence of or reduce the emergent dementia. So that is the thought. For this, our Center of Brain Research at the Indian Institute of Science actually works on identifying these unique risk factors and also trying to bring together and developing a composite biomarker score which can help in identifying these vulnerable populations and help in looking at how many of them go into develop dementia and how we can prevent this. So we have two cohorts, as I already told. In the urban community in urban Bangalore, we have the Tata National Study of Aging, which is about 1,000 subjects whom we follow up annually. And they are, as we all know, Bangalore is a place where you have people more of tertiary occupation, higher literacy, more migration, more multilinguals, more genetic heterogeneity. And we also have a rural cohort. The Tata study is supported by the Tata Trust and the SANSCOG, which is the Srinivaspura Aging, Neuroscience and Cognition Studies supported by the Pratiksha Trust. There are about 10,000 subjects whom we follow, and you know Srinivaspura is a land famous for cultivation of mango, especially mango cultivation. And it's agricultural community, lower literacy, lesser migrations, more mono and bilinguals with less genetic heterogeneity. So you have these two urban and rural populations, and you can identify the risk factors specific to the urban population and the rural population. And this well-characterized cohorts can therefore help us in identifying what are the factors which would likely lead to
Prasad
cognitive
Thomas, can you
transition
wrap up in
to
5 minutes?
dementia.
Prasad Thomas,
Yes,
can you
sir.
wrap in 5
So,
minutes?
yes. So this is my last slide. So this is where identifying these large-scale elderly community cohorts can help us in identifying pre-dementia conditions. And once you identify these pre-dementia conditions and signatures of these pre-dementia conditions, you can actually work around at a multidisciplinary level to reduce the risk of incident dementia. So that is what we have been doing at the Center for Brain Research. And we have these two important cohorts whom we are following up. And we are also trying to link the other cohorts across the country to bring about tangible outcomes for the elderly population in our country. I thank you for this opportunity and would be happy to take questions.
Thank you, Prasad Thomas, for giving an overview of dementia. Is there any question from the audience? Yes, please. We have a couple of questions, Prasad Thomas.
Sir, I would like to ask you if there is any evidence of neuronal dysregulation in processes such as long-term potentiation and long-term depression in patients suffering from dementia or Alzheimer's disease?
Yeah, okay. So thank you, sir, for that question. I think that's a very important point you have raised. So LTP definitely is affected in all the patients who have dementia. That is why if you look at the entorhinal cortex, any drug, which even antipsychotic drugs or any infections or toxins or vitamin deficiencies, all of this can definitely affect the LTP and can result in kind of episodic memory affection and lead on to dementia. So definitely LTP is one of the hallmark signatures which is usually seen in patients with dementia. Yes.
Okay, sir. Thank you.
Any other question?
Yeah, I like to ask you a question. In my personal experience, not as a doctor, not as a psychiatrist, is that I've seen that people who have dementia, if you give them a better social interaction, the dementia improves. Or worsens.
Yes.
Sometimes it has been inferred that if an elderly couple, if they start not interacting with each other and not interacting with the outside world, the dementia, chance of dementia increases. Can you comment on that?
Sir, yeah. I think, sir, you have raised very important point, which can be used both as treatment and early diagnosis. Social connectedness definitely has a very important role in prevention of dementia. The Lancet Commissions goes to say that at least 5% dementia can be prevented by actually improving social connections. And at the research, CBR also has shown that more network diversity and network roles you have, it is kind of protective against developing cognitive impairment. Now there is also an issue that once you develop dementia or once you develop cognitive impairment, overstimulation can also worsen your cognition. So that is something which has to be studied in detail. There are, of course, a lot of studies, but to identify the utility as well as the problems with the excessive over social stimulation is something which has to be studied in detail. Now, social stimulation markers like oxytocin, and it has been found that BDNF is very well correlated with social connectedness. So there are a lot of these studies. You can actually, at this point of time, the research tends to say that social connectedness is very useful, especially in elderly, to reduce the risk for developing cognitive impairment. Yes, sir.
Is any more questions?
Yeah,
Yeah, please.
yeah, Professor Isaac, very nice question. Just one, where the family relations are, when you talk about oxytocin and its relation with how people are active and then how they maintain relation, pets keeping at home is related to oxytocin and their activity, right? Do you also, would you like to comment on this? People who keep their pets, do they have really any connection to a late dementia in case there is going to be a prevalence?
Okay, that's a very interesting and important question. Most of us do have pets, and pets do help. There are a lot of studies not on dementia but on anxiety, depression, and in people with differential abilities, where pets have supposed to be very good and utility is there with respect to social cognition. Now, with respect to whether pets can improve memory or whether pets can improve other aspects of cognition, something which requires more research. But there has been a lot of evidence to say that keeping pets, especially during the COVID, has improved in social connections and reduced the risk of developing depression. Now, late life depression is also a very important risk factor for developing dementia. So, may not be directly, but indirectly it has a role. Also, pet therapy is, or utilizing pets is actually advocated for people with dementia. So, in both ways, definitely having pets is more important, but also caring for the pets is also important as well, both.
If there's no question, I have a comment.
Yes, please.
So I understand, Dr. Isaac, you couldn't come here because your wife was expecting a baby. So I believe that you became a father yesterday.
Yes, yes. I became a father on Friday evening.
So hearty congratulations to all of you, both you and your wife. Huh?
Thank you, Professor Thomas, for such a wonderful talk. I'll appreciate that. Thank you. A round of applause.
Thank you.
We can move to the another speaker. I think he's here right now. Dr. Palas Ghosh. He's Assistant Professor in Department of Mathematics. It is my pleasure to welcome Dr. Palas Ghosh here, Assistant Professor, Department of Mathematics, IIT Guwahati, whose research span biostatics, machine learning, and clinical trial design. He earned his MSc in Statistics from the Indian Statistical Institute, Kolkata, and PhD in Biostatics from the University of Louisville, Kentucky, USA. Dr. Ghosh has published extensively in reputed international journals and served as a reviewer for several leading statistical and medical science publications, an active member of International Biometric Society and the Indian Statistical Institute Alumni Association. He continues to advance data-driven healthcare analytics and personalized medicine in India. Yes, please go ahead.
Thank you. Thank you for nice introduction, and thank you the organizer and especially Professor Dr. Rangan for inviting me and speak in front of you. So today I'll talk about data privacy. So if you do care about privacy, then it's good. You will like the talk. If you do not care about the data privacy, still you may like the talk. Okay. So because it may be required sometimes, and data privacy in India, especially with the researchers, it doesn't exist at all. So I worked with the doctors when I was in Singapore. I mean, I designed clinical trials for the personalized medicines and all the stuff. People send me Excel files with passport numbers. And if you give your mobile numbers to any shopping malls or etc., they will sell their numbers with 50 rupees, 200 rupees, and that's why you get the call, depending on how much purchase you have made. I mean, that's kind of data privacy we have, but thankfully India do have a data privacy law that is passed in 2023, and that is very strong. So as a researcher, if you do not care about the individual data privacy, you may go to the jail. So listen carefully. So I'll talk about this digital journey, and basically I try to merge the two things. So one from the statistical literature that is exists long before. Before AI, everything was statistics. Now that the school thing, and if you want AI, that is AI, not statistics. So one is the called randomized response technique from the 1965 JASA paper, and I will borrow something from the computer science literature, and that's called the differential privacy. Okay, and I will try to merge them and to find out some optimal solution there. I will not waste time here. So let's talk about that. What is sensitive data is all about, and what sensitive here in this particular room may not be outside, and the sensitiveness in India, US and Europe, they may be different depending on the different cultural aspects also. But when we are talking about the sensitive data, any data that is containing some kind of personal informations, that is sensitive. It could be your name, mobile numbers, and it could be your financial details, credit card numbers, it could be your fingerprints. A lot of laptops have fingerprints, and now you suddenly discard the laptop and that your fingerprint is there. So I can steal that information and get all your financial benefits in my account. That's how the fraud things happens. Even the face recognitions, okay, if your database is not strong enough to protect your privacy, then everything is gone. So all these type of things are called the sensitive data, okay. And now we'll talk about the privacy. What do we mean by privacy? You as an individual, you should have the total control how your data is collected, stored and shared with others, even for the research purpose. And at any point of time, if you disagree with that one, the company who is collecting your data should stop that to sharing others. Okay. So even when we say, share some of the emails even within our institutions, we just send anyone's mobile numbers. That's against the law. Okay. And as a researcher, I'm a statistician in mathematics department, working with the clinicians also. So when you share your mobile number, that is actually, you're violating some data privacy law. Okay. So you need to be very careful when you are dealing with the real persons or human data. And you know that how consent thing in hospital works. Okay, all of you are aware of these things, and that is a kind of violation there. So another thing is that it is common perception that if you do the anonymization means that you remove the personal information, names and mobile numbers, you think that, most of you, that data is private, nobody can crack, something like that. Now this is for you. So this has happened in Germany with the 3 million data, and New York taxi sharing data, and also London, and also for the Netflix data. They just anonymize the data and share the data. And researchers, those are smart, not like me, so they crack down. So this information is related to that one. How they do that? That's a complex process, and computer scientists and the hackers, they do continuously like that one. So I'll give you some flavor of that one, what is happening there. Okay. So this is the original data, and it contains some names, mobile numbers, these are fake numbers, and the professions and all those stuff. So what I did, I just removed this name, give some placeholders there, and I completely removed the mobile number, okay? And then I also removed the professions here. Now this is the anonymized data, and you think everything is fine, okay? Now look at this in the third name, the female, 73 years old, having HIV. Now it may happen that in that particular area there are only these female exist above 70 years old or very few. Then it is very easy to find that who is this female is, and then you are leaking this private information. Okay, you think about that. You are leaking a very personal medical information to the public also. Now if this has happened, so what do common people think? That even if you are collecting data for the research purpose, they will unwilling to give you that consent that I do not want to be participating in this, in this study. Personally, I do not participate in any survey because I understand that what will happen in Indian context. Okay, so what I will do that here, I will restrict my talk to the binary data, yes, no, 0, 1, click, no clicks, that kind of things. And I'll talk about that, how this even binary data, when you have other information in your study like covariates and other stuff, it can reveal a lot of other things, and things may really getting complicated. And if you still do not like my talk, I will give you another incentive, that what privacy I'm talking about, Apple and Google, they use that one. Now you listen to my talk. Okay, so since Google, before that I will talk about a very old technique when AI was not there, that is called the randomized response. What it does, when you take the response, the outcome, it change or tweak the outcome randomly to prevent the privacy. Okay, and just using a flipping of coin, I will show you that. And there are many randomized designs started from 1965 by Warner is a JASA paper, and there are various versions of that, and this is coming from the very latest from the computer science literature. I will discuss mainly this one because of time lag. I will not be considered too much, but I will give you some idea of that one. Okay, so what do you mean by the randomized response? Suppose you are asking a very sensitive questions. Let's think about that. Every institution, all of you are aware of, and also India and all over the world. So illegal drug taking is a paramount problem. So I want to estimate in an institution how many students are taking the drugs. Or if you can think about, if you want something else, you can, what is the proportion of abortion, alcohol consumptions, or any other questions that is the sensitive, I want to estimate the proportion of that in the particular population. So if you ask directly, students, do take the drugs, you know that what will be the answer. And this is not a problem for that particular person. This is because the stigmatized thing associated with that particular sensitive questions. Okay, so do you take the bribe, or are you present in this talk physically or mentally? So that's a sensitive question also. Okay, so that means whenever you ask this kind of sensitive questions, I am bound to, because of the social stigma and other issues, I may not answer it correctly. So what it does, randomized response, it added some noise to the collection of data that will give you a sense of, even if you answer yes, that may not be the answer to the questions. So that's the beauty of this randomized response, and it is from the 1965. Now, so this is let's understand that what is Warner design from 1965. So if I'm going to ask a very sensitive questions, and my objective is to try to understand what is the proportion of that sensitive group pi. So if you do not understand the mathematics, it's still fine. Okay, and if you understand mathematics, that is very good. So now I want to estimate this proportion. So what I'll go to you and ask the sensitive question, and also hand it over a simple coin. Okay, so the probability of that particular coin getting head or getting A is P, lies between binary, 0 to 1. So what you will do, you will turn around and toss the coin privately. I do not see that outcome of that coin. So depending on your outcome, you will answer. That's the randomized part. I'm tweaking the answer yes, no. Okay, so if your spinner or the toss or the coin of the toss landed in A or head, you will answer, do you belong to the sensitive group? Yes. You do not belong to the sensitive group? No. But if it is tail or lands on B, if you answer in the opposite way. So here it was yes, now it is no, and it is yes. So from what I observe, I do not observe this result, I observe from here. That means there is no way I know that whether you actually belongs to that group or do not belongs to the group. That's the beauty of it. And once you collected all the data, so statisticians calculated simple, very, very simple probabilistic calculations, and this is the pi a is the proportion of the yes response when I collected the data. So with that, I can easily get that true proportion estimate of pi hat. So what it does, even if I have the problem, I do not know that your individual answer, but still I get that population portion of it. And similarly, you can calculate the variance. The moment you get the estimate and variance, you can do a lot of statistical inference with that one. People call it artificial intelligence now. So there are various versions, as I say. This is another version. Because of the time, I will skip one. So there are a lot of psychological aspect with that one. Based on that, how do you ask questions? And there are who work in the behavioral science. Even just framing a 2 questions, they can take 6 months, depending on whether how they will get actual true answer or something like that. So these kind of things are there. I will skip that one. So this is another version, the forced response design. instead of tossing a coin, here we are throwing a die. If 1, then I will say forcefully no. If yes, if 6, then I will forcefully say yes. And if anything else, that means 2, 3, 4, 5, then I will answer the truthful. Now from here, you are unable to detect that whether it is real answer or fake answer. You are protecting individual privacy. Still, I am getting the estimates. I will not go into the details. There are another version using the 2 pack of cards, because whenever you are saying that yes, people think that I'm still answering that sensitive questions. That's the problem. So they use that color of the cards. So you will just say that this black color or red color. That's also, psychologically much more better compared to others. And this one, as I say, from the computer science literature, it is coming. So you toss the coin, and if it lands in heads, you answer truthfully. If it is tail, you toss the coin again, and if it is heads, you will answer forcefully yes, otherwise no. And this is again the estimates of all those stuff. So there are some mathematical issues. So if you know that when you are designing a study, you need a statistician. Sometimes you get rid of statistician, but still you need a statistician who see the things and design what is the required sample size there, and that's why you need a statistical hypothesis based on the pilot study or other data previous. So if we have, this is the power equation that I will use later. If you do not understand this one, that's still fine. So now, so this is the statistical part, and I will move to that computer science literature part. And here, this is a fascinating story. So all of you, maybe, it's very closely 99% or something like that, you believe that when you are sharing the aggregated data, sample average or something like that, you think, and that's a natural process, that nothing is revealing. And now we'll see something else. So what happened, there are 2 journalists, Mr. X and Mr. Y. They report the average salaries of a private company. Okay, IIT salaries doesn't matter, you know my salary. Okay, but here for a company, they do not have access to the individual salaries. They have the total number of employees and average salary. So that's the information they have access. No access to the individual salary. But what they published in a newspaper, Mr. X in January 2025, that the company has 100 employees and the average salary is 55,000. In February, the Mr. Y reported 101 employees having 56,000 salary. So, and then the difference is only the timing of the data access, January versus February 2025. Now, based on this one, another journalist, Z, compared the reports and find out the new employee salary, and he has the information that nobody else resigned the company. That new salary is 1,50,000. Not bad in India. Now, Mr. Z identified from the social media where Ms. K said that I joined this company. This is her salary because there was no resignation. You look at the consequences. So what happened? No personal details were directly revealed, neither Mr. X by Y. But all that because of the time frame, Ms. K's salary is leaked, and that's a problem. And she filed a complaint, but everybody follows the rule. So your notion of sharing that, aggregated number is not working. Okay. So what would you do? So we have a concept from the computer science literature that's called the differential privacy. Okay. So it's a probabilistic framework. So what it does, it says that even if you have a small changes, whether you add one data or delete one data, that means if you can think the Excel file with just deleting one row or adding one row, that will not add anything or do not expose private details, even if you compare that with the multiple time points. So that's the thing. And here we have the formal definition of the differential privacy. So even if you do not understand probability, that's still fine. So here we have 2 databases, X and Y. So 2 Excel files, X and Y. Only difference is that at most you are either adding one row or you are deleting one row. So what I am saying that if you have an algorithm, say for example randomized response algorithm, you operate on that. So just like you change yes to no or no to yes or vice versa. So then the probability that it belongs to some subset is, and similarly for the say these two ratio of these two probabilities bounded above by e to the power epsilon. So what intuitively, common man saying that I have 2 probabilities based on the 2 databases and their ratio is bounded above by e to the power epsilon. What it does mean that the probability when epsilon is very small, the probability is not changing too much. So it doesn't matter whether I add or delete any individual to the database, it will not reveal much information. But when your epsilon is much higher, that means two probability are differing each other. That means that individual does matter. Okay, so you are revealing more information. Okay, so this is a, very one of the foundational things about this differential privacy, and it's added a lot of other things. So I will skip this one, and there are various versions of the differential probabilities also. So now this epsilon is called the privacy budget. Lower the better, and generally it is set between 0.001 to 1. And we have calculated the differential privacy budget for the different designs. You may skip that one. So now what I am saying that I have told about this differential privacy and the randomized response. So the question is how to design a randomized response which is kind of trade-off between the privacy from the computer science literature and the accuracy, that is power, from the statistical literature. That's what we are doing, and the problem is that if you want to have a better privacy, you will lack the power, and if you want to keep power high, your privacy is going to be high, and that is you are leaking information. So that's the trade-off kind of things. You may connect with this if you are aware of the type 1 error and type 2 error in hypothesis testing. Okay. So similarly, say for example, I want more power, but I want less privacy. So that's the dilemma or the trade-off I am talking about. So here we propose these things that I will first restrict the privacy to an acceptable bound. Then I try to find the sample size which will allow me the power that I want. And then after some algorithmic approach, you can find out what will be the optimal value of the sample size and the design parameter. This parameter is basically the probability of coin toss, or you have a multiple coins, then the probability of it will be a vector. Okay. So these are the few designs that will give you the differential privacy and power and so on. And so basically in this case, forced response, I will find the differential privacy here, it is 1, and then I will optimize for which value of the design parameter P it will be optimized. I'll skip all those stuff, and this is the data. So the question, it is from this paper asking that, have you ever provided misleading or incorrect information on your tax return? If I ask you, you will say no. So they did this study, but with a ad hocly taking the probability of P1 and P2. And if you calculate the privacy budget there, it is 2.3. That means it can leak a lot of private information. So we have access to the similar data from this paper only, which is much smaller sample size. And we show that using that sample size, we can keep the privacy budget to be 1 and power to be 80%. But you look at the difference with the optimal values of this parameter. So it is possible if you design in our way, then you can keep the optimal parameters value, and that will ensure that you have lesser privacy budget compared to this one. So what we propose, basically we propose a trade-off between the privacy and the accuracy in terms of the power, and you can design. So we have an app also where you can just go and see that how things work. And basically how to calculate the sample size when you are considering both power and the differential privacy budget. You can design the trial, and that will give you that privacy at the acceptable range and also the power at 80%. And the problem is that if you do not do carefully, then your optimal solution may not exist. These are the few references, and this is the acknowledgement. So this is a work with my PhD student Bittu Kormakar, who is also there. And with that, so I also develop work in synthetic data, but I do not have time. So if you there, you can check this one. And with that, thank you from this beautiful campus.
Thank you, Pallab. So nice of you.
Thank you.
I think we should not disclose your phone number also now, right? Is questions from the audience? Anything? Anybody? No tax return filing, no data. Please, please.
Beginning of your lecture, you mentioned that I don't share any data and I don't participate in any survey work.
Yes.
So if everybody doesn't participate in survey work, then how the research will be conducted?
Yes, that is the problem. So as a researcher,
this might lead to a statistical issue and problem.
Yeah, I mean, as a I mean, scientist, we need to develop the conscience among the people of India that if you are sharing our data with your data with us, that data is safe. And frankly speaking, that perception is not there.
Not there at all.
And if you, I mean, I have seen that one. If you go to that any hospital, you will say that somebody is collecting.
Yeah.
Why collecting? My boss told me to collect that one. But when you go for the consent, because if you are asking data from someone, if that person is illiterate, you have to find some of the family members of that person, whichever language they understand. If it is blind or something like that, you need to have a consent person who can give consent for him or her, then only you collect the data. And once that data is going on there, I mean, you know that how it is deal. So you just give any of this insurance provider company in the online, you just give your phone number and make that, I have purchased a car of 15 lakh. You will get all the calls within half an hour.
Yeah. That is correct.
Yes.
Please.
So, just a comment. It's a fascinating talk.
Thank you.
It's because we are also collecting a lot of cohort data. So this is something I care deeply about. But in the bigger context, do we individuals, as individuals, you talked about the legal frameworks and all that stuff. Do we really have a choice of not sharing data, given the fact that even if you go to rental agreements, sign rental agreements, they ask your Aadhaar. You buy an aeroplane ticket, I don't know why they need your Aadhaar.
I do not provide Aadhaar anywhere.
But how do you survive? I mean, do you actually manage to get...
I give the voter ID, where you cannot recognize me.
But a lot of things actually you need Aadhaar. For example, the filing tax return, you cannot e-verify.
That's true.
So you are, in fact, you don't have a choice. So as scientists, where do we stand in developing the science of choice? How do we educate the policymakers this choice is important?
Yes, that's a good question, and somehow we need to raise in the right platform. And thankfully, India is also understanding. So we have a law in 2020, that is data protection law. And earlier, I mean, you will go to a lot of shopping malls, they do not give you that bill receipt. They will give you your mobile number. That they are getting your data by free. Okay. Now they have passed that, I mean, it's mandatory that you cannot ask mobile number forcefully, but people also need to be educated. I mean, they will say that just give your phone numbers and I will send you. So that's the whole thing. Yes. So you need to be thinking in that mental process that whenever something is coming free to you, you are the product. Okay, so your data is valuable. Similarly, all the LLMs are free in the Indian market. Because why? They need your data to train that model. Okay.
So, just a question.
Yes.
When we talk of AI healthcare, you need a lot of anonymized data.
Yes.
So what does one do with it? Because if you're going to develop your own AI and models for that, are you really because you need data, you have to share it.
Yes,
to what extent do we anonymize it to be sharing with them?
Because
there's a format which almost everybody asks you for, and then if you don't share data, you will never move forward for it.
Yes. So that's why I did not have the time to. So we have a app we developed here, so called the synthetic data. So you might have heard of the term. So in chemistry, synthesis is quite familiar, but in there is called synthetic data. What it does, we take the real data and understand the statistical patterns to there. Then we generate the data. So all the data are fake here. Okay, that's what LLM does. So we have a statistical solution. I submitted for these Indian Foundation model, but nobody cares about me because if you are doing something ahead, then nobody cares about you. So I hope one day they will understand. So that it's the syngene-data.ai. So it's a free and it's statistical based, not AI based. So the company that developed synthetic data called Gretel, NVIDIA purchased it in 3,000 crore last, beginning of this year. So I am not doing that kind of things. I am not that intelligent. But what I do better than them. So in the small scale. So I submitted that, but nobody giving me the funding. So if I get funding, I will have app or whatever. So where you can give your real data and it will give you the synthetic data with the latest statistical, I mean, all the correlations and the other structures will be there, but no individual records will be there. So that's the future, and it's a very high value, but I hope somebody is here there who can tell the other people, who will give me funding.
Thank you, Palak. And I can share you one thing. If you go to Apollo Hospital, all your data is sent to US. I'm just telling you truth. It happens. Because I work at Apollo Hospital in Chennai, so I know that.
And sir, like one friend of mine, he told me he used like ChatGPT extensively every day. So ChatGPT now knows that he has a daughter. He married his girlfriend who was a PhD student in IIT Guwahati. He is from this district of Assam. Everything.
Yes. So Google knows about you more than you know about you.
Exactly.
Thank you, Palak, for such a scintillating talk. We must congratulate him.
So thank you, speakers. Now I would like to call upon stage our chairperson, Professor Ramashankar Verma, to felicitate the speakers. Though we don't have Professor Arun and Professor Thomas with us today, we would like to thank him on behalf of the organizing committee. Now I would like to request Dr. Palash on the stage. Can we please have a huge round of applause? Thank you, Dr. Palash. I would like to request our chairperson to stay back on stage. To continue, I would like to request Kusum ma'am to felicitate our chair. Can we please have a big round of applause? Thank you, ma'am. Thank you, sir. So we are now breaking for lunch. Lunch will be served at the same place as yesterday. And next session will sharply start at 2 p.m. So I request your presence in the same hall at least by 1:55 p.m. This is a kind request. Also, the participants of poster presentation, please put up your poster in the lobby at the earliest. Thank you.
So that brings us to the main topic, which is neurological rehabilitation or neurorehabilitation. So basically, the objective here is we want to restore motor function in these patients by performing goal-oriented movements in order to promote neuroplasticity and cortical reorganization. Now, there are different therapies that fall under this umbrella of neurorehabilitation. I already mentioned occupational therapy, physical therapy, where you have some therapist who is working with you and helping you to use your arm better. But there is, with the advent of technology, there is also the use of robotics, electrical stimulation, virtual reality environments. Now, when these therapies were first introduced in about the 2000s, or a few decades earlier, there was a lot of potential for them, but they only led to modest improvement and recovery. And the reason for that is they followed what is known as bottom-up approaches. So they were too focused on performing the right movement or focusing on the right hands, sequence, and so on, that the person would be literally driven by these devices. So a person could be just passively be there without actively engaging in the therapy. And as a result, it failed to engage the patients enough and led to what is known as motor recovery plateaus. So they would improve somewhat, but then the recovery would sort of flatten down. So that's when people realize that what we need is top-down approaches where we are sort of giving more or involving the person more into the therapy. And one of the ways of doing that in early 2000s was if you can measure the attempt for movement, right? So if we can use something like simple electromyography sensors which can measure that, okay, at least you're trying to move the limb in order to cause the muscles to contract. And by measuring that, we can say that okay, you're at least attempting to move. So we could use that to then, control the therapeutic device of our choice, whether it's a robot or stimulation or so on. Then people realize that that isn't enough itself. So actually what we want to do is we want to measure their intention for movement. And if we can do that, then we can use that to directly control the therapeutic device. So that led to the idea of brain-machine interfaces or brain-computer interfaces being used for rehabilitation. Now here the idea is that we want to measure motor intentions, right, which occur during the preparation or planning of movement before the actual execution of the movement. Because this has shown to improve neuroplasticity by following the Hebbian principle, right? So neurons that fire together, wire together. So if you can detect this intention during the planning stage itself, then you can provide the feedback from the movement, and then that will help wire the neurons better and improve the recovery better. So that brings us to the idea of brain-computer or brain-machine interfaces. A layman definition is essentially it allows you to control and communicate with the external world without the use of movement, right? So essentially what it involves is three main steps. You have a signal acquisition step where you want to measure the central nervous system activity, which could be either through electrodes that are placed on the scalp of a person or implanted inside. Then you want to convert that signal into some sort of an artificial output, which can replace, restore, or enhance movement. So there are steps involved in typical machine language lingo, such as feature extraction and feature translation. So when you couple all these three steps together, you are essentially allowing a person to communicate and control with the external world without the use of their own hands. Now, in terms of, if you look at different approaches for recording brain signals, there are several different ways. You can either place electrodes on the scalp, which is known as electroencephalography or EEG. This gives you signal which is sort of a low frequency representation, but it is the most easiest to acquire, and we'll go into more details in a couple of slides. Then there are more invasive approach where you actually need to perform a surgery and implant the electrodes either deep within the brain or on the surface of the brain, which obviously gives you much more bandwidth and room to work with the signals. The signal to noise ratio is better as you are more close to the source of the activity, but there are of course risks involved from surgery and so on. So so there have been many examples in the literature of what are known as motor BCIs, or essentially brain-computer interfaces that want to decode the motor commands or motor intentions of a person. And people have shown that you can use it to, let's say, control a wheelchair. So if somebody is paralyzed, unable to walk, the wheelchair can be controlled with the bind so that they can navigate around. Or you can control a robotic hand which can assist someone who is in this locked-in syndrome to basically feed themselves by controlling the robot. Or it can help someone become more mobile by controlling an exoskeleton so that they can stand upright and walk a few steps so that they are more independent in this case. What we were interested in, can we use a brain-machine interface and combine it with a robotic exoskeleton so that a person who is paralyzed and unable to use their hand normally is able to regain that ability over time, right? So this was a different sort of application. All the previous applications were on assistive devices, whereas we were looking at restorative BMIs, where we want the person to get better and eventually be independent of using the brain-computer interface. So just to give more technical background about EEG acquisition and different types of information that we can get from electroencephalography. So here, as you can see in the top figure, EEG is mostly the accumulation of the postsynaptic potentials that arise when an action potential is fired. And it's recorded, it's essentially the accumulation of all the activity of pyramidal neurons which are in our cortex. And the summation of thousands of these neurons becomes strong enough that it can penetrate through all these different layers of the skull and the scalp and be able to reach an electrode which is sitting on the top of the surface. Now, typically in an EEG setup, we have about 64 channels recording from different regions of the brain, which are responsible for different functions. If you look at the signal, there are mainly two types of signals. One is spontaneous or background brain activity, which typically tells you when, if a person is feeling sleepy or has an epileptic seizure and so on. So these are spontaneous brain rhythms that happen uncontrollably or involuntarily in the background. But then there are also these specific markers known as event-locked or event-related potentials that only arise in response to some stimulus or cue. A classic example is an external visual stimulus. So you can have characters on the screen flashing at different frequencies, and that will give us a visual evoked response that corresponds to that stimulus that's being provided. But then there are also these internally cued or internally generated signals when you start to imagine or prepare for volitional movement, right? So these are not dependent on the external world, but it's your own preparation or intention to move. And it has been shown that both types of signals can be used for creating a brain-computer interface, but we are mostly interested in the second type of signal because that is where there is potential for motor rehabilitation. Okay, so even when you look at motor-based event-related potentials, there are different methods on how this signal is extracted. So one thing that has been shown is that when we start to visually imagine a movement, so we perform what is known as a motor imagery, there is a drop in the signal activity which can be determined predominantly over the motor cortex. So using some frequency domain methods, we can identify, like from power spectral density, when that drop occurs in power, right? This is showing the same information in terms of a spectrogram. So we can identify when that drop in power occurs and then use that to decide that, okay, the person is actually wanting to move at this particular time. Another way by which motor intention can be deciphered is if we look at movement-related cortical potentials. So these are lower frequency signals as compared to the other type, the ERDs, or event-related desynchronization, shown here. So these signals occur in the much lower band, but they are directly related to the preparation of movement, right? So as you're preparing to move, these signals increase in magnitude. And here you can see from EMG that the movement happens at around time equal to 0, but even around 600 milliseconds to about a second in the past, these signals begin to appear. So if we can train an algorithm to detect when this slope occurs, we can use that to control an exoskeleton before the movement actually happens. So that is, again, this requires using some time domain-based methods as compared to frequency domain-based methods used earlier, followed by some machine learning. So in our specific case, where we wanted to build a BCI-based upper limb exoskeleton therapy, so here I'm showing you an example of a patient who was 6 years post-stroke, right, 71 years old. And in a moment, I'll play the video to show you how this interface works. So here you can see the top and the bottom is plotting in real time his brain activity. You will notice that around this contralateral side, when that spike in brain activity occurred, that's when our algorithm detected that, okay, this person wants to move and activated the movement of that exoskeleton. Here's another example, or second trial. So you'll see that that spike of the activity occurs when he's preparing to move, and that's what is causing the exoskeleton to move in this case. So here the exoskeleton was just doing a simple elbow flexion exercise, in movement, but we were interested to see what kind of effect that had on the recovery of this person. And interestingly, with this interface, we were only able to perform about 150 repetitions per session. Now, this is much, much less than any standard robotic therapy protocol where they perform thousands of repetitions in a session, right? So we were doing much lower than that, but we wanted to see if that is beneficial in any ways or not. So to our surprise, we found that using standard clinical assessments, such as action research arm test and Fugel-Myers upper extremity score, these patients, we had about 10 patients who underwent this therapy for a month. So they did in a much better position than what they had started with at baseline. So we can see their recovery after they have stopped the therapy. This was at post 1 month. And that recovery continued even up to 2 months follow-up. So definitely this therapy had some beneficial approach on that. And what was the real benefit to the patient? So just to show you one example, on the left, you see this person when he started, before the start of the therapy, so at baseline assessments. And you can see he's having difficulty in opening his hand. So he's not able to pick this can and sort of place it in front of him, right? So he's unable to use his hand at all. So this is 17 months post-stroke, right? And then on the right, you will see him at the end of 2 months follow-up, that you'll see now he has much better control and he's able to pick and transfer the object. It has not completely recovered, but we only had about 1 month of training. So if we had continued this for several months, maybe the improvement would have been much better.
Dr. Bhagat, you have about 4 minutes to go. Is that
okay? All right.
Thank you.
Yeah, okay. So coming back to the main scope of this talk on role of BCI in neurorehabilitation, right? So one is that by using a BCI, we can ensure patient engagement during therapy. So replace that traditional thought of having more reps is better to having more relevant movement and having more engagement is better for recovery. So we have changed that initial, whatever preconceived notions that people had. The other area where BCI can play a role is we can objectively evaluate how effective our therapy is. Because essentially by monitoring the brain activity, we can monitor the changes in brain dynamics as a person is going through therapy. And we can potentially identify biomarkers for neuroplasticity. I'll give some examples of that in the next couple of slides. And then finally, by using BCI, we can improve the access to effective rehab therapies, even for marginalized patients. By that, I mean patients who have cognitive impairments. Currently, there are no studies or no research which includes them in sort of BCI-based rehab therapies. So I'll present you a way by which even these patients could benefit from using a BCI. So coming to the second object or role where BCI can be useful is identifying biomarkers for neuroplasticity. So from our patient population who underwent the therapy, we used some techniques such as source localization and functional connectivity assessment and looked at two particular networks, which is a frontoparietal network and singulo-opercular networks. Now, these networks have been associated with motor preparation, intention, error processing. So kind of the signals that we are trying to capture with our BCI. And what we found is that when there was increased connectivity, or for the trials when the BCI was successful in controlling the robot, there was increased connectivity between these two regions. So that is what we are measuring here on the y-axis, the connectivity when using the BCI. Whereas the traditional approach where they were just measuring attempt, right, or using an EMG sensor, there the connectivity was weaker. So definitely by using the BCI, we are able to engage the user and improve the connectivity between different brain regions. Another metric that we looked at is the movement-related potential. What was the change in their amplitude before and after therapy? And what we found is that the amplitude did increase significantly post-therapy, and it also correlated with the patients who actually improved on clinical outcomes. So this improvement was most over the ipsilesional area, so the same region which had the stroke. There was increase in activity in this region, which we could assess with the help of EEG. Okay. Another area, as I mentioned, was how we can improve patient access to such kind of therapy. So currently about two-thirds of stroke patients experience cognitive decline and impairment. This affects their attention, memory, learning, and so on. And most importantly, post-stroke cognitive impaired patients are typically excluded from BMI-based rehab therapy. So together with my collaborators, Dr. Pragati and Dr. Subhashri from NIMHANS, we have come up with this idea of cognitively adaptive brain-computer interface, right? So here in the green box, we show the typical brain-computer interface where you have signal acquisition, extraction, and so on. But now on top of this, we have a cognitively channel paradigm which performs cognitive assessment of these patients, and based on their level of cognition, we can adapt our classifier so that it is more conducive for them to use. And they are not overburdened by something which is very complicated for them to handle. So that is an area that we are working on, and we hope to have some results very soon. So finally, I want to talk about what are the other applications where BCI can be used. So I talked about motor restoration, but there are also applications in memory restoration, where patients who have loss in memory, they can use a BCI for that. Another area which I don't have time to talk about more is passive BCIs. So whatever examples I gave to you so far are known as active BCIs, where you are actively trying to understand the intention of the user and take some control. But there is a whole field for passive BCIs, which maybe next time I can talk about. Then there is also, a futuristic application where you could have brain-to-brain interface, right, or bidirectional BCI. So these are still upcoming areas. And finally, we only looked at one modality, which is EEG, but there are other modalities like, for example, near-infrared spectroscopy, which could also play a role in improving BCI performance and their role in neurorehab. So with that, I want to acknowledge the funding agencies and collaborators who have worked with me on this, and I'll stop here and take any questions that are there in the audience.
Thank you, Dr. Bhagat.
Welcome.
Any questions? Yeah.
Yeah. Good afternoon, Dr. Bhagat. While your talk focused on those non-invasive implants, I was also wondering about invasive implants, like, for example, the more famous Neuralink, and how do you see the future progressing in this?
Yeah, that's a great question, and I do get that a lot.
Yeah, I'm sure.
So the way I see, the way I see it, yes, definitely there is a use case for invasive implants, but I think it is more for patients who need assistance with their movement, because we are talking at something that can be permanently implanted and doesn't need to be removed now and then. But with restorative brain-computer interface, what we are looking at is something, it's kind of like a therapy that you do for 3 to 6 months, and then you naturally recover your ability to move that you no longer depend on. So there, I think there is a more role for non-invasive brain-computer interface, because it doesn't involve surgery, and you can effectively remove it once the patient has, overcome that motor recovery plateau that I mentioned.
Thank you.
Yeah, hello, Dr. Nikunj. This is Dr. Sanjay Bihari. Hello, how are you? So we
hello there.
Hello.
I'm good.
Yeah, a lot of collaboration. Just a few words of caution. The first of them is, in any stroke, there is going to be some recovery. I'm completely agreeing with you that rehabilitation is an absolute necessary for every stroke patient. However, every stroke, there is a penumbric zone and there is neural plasticity. So after a while, there will be some recovery. And we don't know how much of it is because of rehabilitation and how much of it is because of actual recovery, spontaneous recovery. So, it has to be treated with a little bit of caution there. Too much of optimism may not be the right answer. The second important thing is when I look
Yeah, no, that's a great.
The second point I'd like to just mention is when I look at your patient who had actually improved, you see, whenever a patient becomes even hemiplegic, there is a return of what we call the thalamic or the basal ganglionic power. Okay, which means that his shoulders and his elbow, which is responsible for most of the movements, or his ability to stand with and stagger, that improves. But what doesn't improve are the finer movements, which are cortical movements. So the stroke, which is a cortical, cortical and a little bit of subcortical activity, is basically controls the fine movements, and the basal ganglion and the controls the the supporting movements. And therefore, when you say that the person has improved, this may be a spontaneous improvement of basal ganglionic or thalamic power in any patient who has become hemiplegic. So this also you need to look at. So maybe some electromyograms can be done on these patients specifically to actually assess for an objective improvement of the cortical distal fine movements, especially fingers' ability to actually pick up objects and all that. That's another third point. And the third point is even patients with significant stroke, EEG, electroencephalography, is not sensitive enough to actually give you any discerning changes between lack of improvement and any improvement thereof in any of these patients. So these are some, I'm just not a matter of criticism, but from an end user experience, what I want to tell you is that when you're doing your research, and too much of optimism has to be tempered with a little bit of these small issues which we as clinicians encounter on a daily basis. Thank you. Yeah, any comments on that?
Thank you so much, Dr. Bihari. So, to your first point regarding spontaneous recovery, so the patients that I showed who participated in a clinical trial, they were all chronic patients, so they had suffered their stroke from at least a year to several years in the past. So they are sort of otherwise plateaued on whatever benefits they could have recovered naturally or through any other ongoing intervention. So they are sort of flattened out on that. And in fact, to confirm that, we did our baseline assessment twice. So we only recruited patients who were stable at baseline. So 1 month apart, we used to measure at 1 month apart, we used to do 2 baseline assessments on different scales, and only if they were flat, we would recruit them in our study. So just to sort of minimize this confounding effect. The other part about finer movements, that is totally true, and we are actually working on that. Now, with this exoskeleton that I showed, we were limited because it only had an elbow joint, so we couldn't train the finer movements. But now, as you know, we are working on different interventions using electrical stimulation and so on, so that we can even train the finer movements. But what was interesting here, that the person, although we were training the elbow joint, the improvement sort of generalized to different distal limbs as well. So there was improvement. I can show you the ARAT scores. There was improvement in the hand functioning, like pinching and grasping, even though that was not the main focus of our therapy. So that's kind of I would say, I hope I've addressed all your concerns. But we have to be very cautious in overestimating these points. Point well taken.
Dr. Bhagat, thank you very much. I think we have one more question, a very brief one.
Hello, sir.
Okay, sure.
So you had talked about the signal acquisition from EEG direct brain. So rather than direct brain, do we can signal acquisition from the spinal cord or limb nerves, like radial nerves, are those nerves? So in these nerves, do we get lower noise in compared to the direct EEG?
Yeah, that's a great question. So I think if you directly record from the nerves, you will definitely get better signal to noise ratio, right? But you will have to do a surgery to sort of implant the electrodes close to the nerve. But I think the other problem here is if you're recording from the brain, you are actually picking up, or you have close to picking up the intention, like during the preparation of movement, right? Whereas in the sequence of motor control, what reaches the nerve is the final control signal to just activate the muscles. So you would be missing out a lot of the information that goes during preparation and planning of movement. And you would be only directly recording what is the final executive control. So I think in terms of the latency also, you will have much lesser time to sort of react, and because latency is very important for neuroplasticity. So I think from the brain, that is the benefit, that if you can pick it up well in advance, like, I was showing you some data like 600 milliseconds up to a second in advance, then you have much more room to, do better neuroplasticity.
Okay. Yeah, thank you, Dr. Bhagat. Very interesting lecture. Clearly, it's invoked a lot of interest in the audience, and we wish you were here.
Thank you.
For further discussion. So thank you very much. So the next speaker is Dr. Arpan Banerjee.
All right. Thank you.
Yeah. The next speaker is Dr. Arpan Banerjee from, he was a professor at the National Brain Research Center, which is a DBT-funded institute in New Delhi. And I had the good fortune to share a taxi ride with him from the airport to here, which was very educational. It's the first time I met him. And unlike your previous speaker who was given leeway of extra time, you won't be given leeway. So 20 minutes is your time limit.
Oops.
Okay.
I prepared for 30, but it's okay. We'll see. So what I work on is, and I think the topic has briefly been touched by, I saw when I entered for Nivedita's talk, is this idea of flexibility. So I will kind of dig deeper in the realm of emotion of how do we see flexibility. So the inspiration actually, like historically, didn't come from science. I think it came from this work of art or several works of art. So particularly this movement in like in painting is called this surrealism, where painters dabble with depicting art forms, the idea of hallucination, of taking something completely improbable, outlandish, and trying to make meaningful concepts. For example, what you see here is a famous painting by Salvador Dali, and I think many of you must know him. And its painting is very famous. It's called Persistence of Memory. What it describes is melting watches, which means at that time in 1930s, this was the time when, like about 10 years afterwards, Einstein's general relativity. So a lot of people thought that Dali was trying to take that idea of the time is flexible and putting it in the frame of art. But when somebody asked him, he said it's camembert cheese being melting, and that's what gave him the inspiration. So in different kind of concept can flexibly be attached and to different things. For example, this can be something like destruction, war in Europe at that point of time. So a lot of things embedded. So based on who is actually watching it, and you go through these flexible concepts which you kind of fluidly kind of traverse. So that's this idea of flexibility that I will be talking about. So not entirely about art, though that would be much better in these days. So the idea of cognitive flexibility in technical terms, and one of my great friends and researcher, Lucy Nauddin, in this recent paper defines it as broadly defined as the mental ability to switch between thinking about different concepts according to the context of the situation. And Nivedita was showing some task which is essentially forms under the paradigm of reversal learning, which means that you give a rule. For example, in the left you see the Wisconsin card sorting task, and this is something administered by neuropsychiatrists who typically ask people to follow a rule like sorting the card according to spades or hearts or whatever the suit, and suddenly you ask them to switch the rule to something according to the color or number, right? So people having damage in their frontal lobes, kids underneath the age of 5 typically have problems to deal with this sort of tasks. So they have problems to deal with the idea of flexibility, changing rules. So that's really, this is all about. So taking a different kind of a direction. So this is not moving easily. So I have to move it from my computer. Okay. So the idea in a recent paper in American Journal of Psychiatry, Insel, who is from NIMH, proposes that this kind of flexibility and the task like this can give you sort of. Okay. This one, right?
Yes, next slide.
Okay, now it's working. Earlier it was not working. Okay. So the idea is that if you want to develop, go forward, like, in the future, so you should be able to look at one patient at a particular point of time and look at the behavior and understand what kind of depressive symptoms or, state they are in, rather than rely on some kind of a marker based on question. And this whole idea going forward is called this research domain criteria in precision psychiatry, which they want to take us. And one of the things that really is going to go make us accelerate the growth in this direction is when we can devise certain tasks, such as dynamic tasks, which can assess your behavior in real time and come up with a marker in identifying which state of psychiatric states that you are traversing through. So, and what are the means that you are going to reach there is, ultimately you want to get rid of this DSM or ICD, is to develop this kind of tasks, develop cohorts where you can apply with, of course, all the data regulations, we learned about the data regulations, what is very important. So eventually we can train AI algorithms to identify certain markers or certain behavioral states from the behavioral kind of assays that we typically use for animals or whatever, right? And thirdly, that, you can also you need to study the biology at a very different, multiple levels of organization, from molecular level to the systems level. So just one more slide of introduction. It's again the same problem. So when we talk about now about flexibility in the emotion regulation, and that's what I call is the affective flexibility. So it deals about how do you change your emotional state. Let's say when you woke up today, you were in probably a neutral state. Maybe you suddenly went to your breakfast table, had a cup of coffee, you became very happy, and it's a beautiful day, beautiful campus, so likely you are going to be happy, but then you learn about the Indigo flights are not working properly and you get sad. So you go through this state. So you don't want to be sad. You don't want to look at parliament and be sad, for example, right? So, so you want to get out of this state of anxiety and despair. So you need to develop your systems, circuits to be flexible. So the idea again, inspiration comes from art here. So this Edvard Munch is a Norwegian artist who talks about his first described scream, which is this idea of your state of anxiety being depicted in a work of art. And if you see on the right, there is a fMRI study where kids were shown these pictures of fearful faces, and a particular location in the brain, amygdala, was recorded. And you see the activation of the amygdala changed, and you show different kind of degree of fearful faces. I mean, for kids, this is a very fearful stimuli. I mean, fearful faces. For adults, maybe not as such, unless they are politicians. Okay, so now coming back to this, this emotion regulation, when we talk about emotion regulation, this face perception, somebody talked about faces, has a very sort of, I think Arun talked about faces. So identifying emotion from faces is very critical, and this is important for our survival, social kind of being. So people think there are different kinds of basic emotions, such as this, sadness, happiness, fear, anger, surprise, and disgust. And this was the idea proposed by psychologists like Ekman and Spanscape. And what then next is they make you see this face, whether you are happy seeing a sad face or, I mean, it's lame stimuli if you ask me. But nonetheless, it gives you a marker whether you are if you are not very excited about a happy face, that means you are depressed, to cut the long story short, right? This is the way psychiatrists kind of deal with the problem, I mean, right? And now, this has led to kind of a lot of intense debate. This is not the right way. So a lot of researchers like Lisa Feldman Barrett has proposed that must be a dimensional model to emotion, which means you break up emotion into a two-dimensional space like arousal and variance. Arousal means how excited you are or how bored you are. versus valence means how sad or how happy you are. So if you are positive on the valence means you are on the positive part of x-axis, and negative on the valence means you are sort of here, right? And arousal and valence. Now, going back, like the brain areas have been identified with different kind of, emotions, and this has been challenged, like this kind of view of the brain. So to a more integrative kind of a way of the brain, like, people think now there is a core kind of network for affect which goes through these different kind of emotions as we move along in time. To cut the long story short, we come in, we kind of develop this task. So we want to sort of, assess these kind of core networks as we are going through a daily routine of, emotions. Now, how do you create this kind of emotions in real time? So what we rely on, Hindustani classical music, which gives you a lot of intense kind of emotions if you enjoy some kind of rhythms, not necessarily be a musician. So this is the work really what I'm going to present is not published, so take it all with a grain of salt, it's not peer reviewed. So we want to take all the comments to publish. So, and work of my graduate students Shashwati and Ritu, and also a master student, Austin. So what we want to do is, we have a joystick like this. So we ask you to play a video game, which is when you are listening to music, you are supposed to put your joystick in these kind of locations. So if you are very happy, you are here. If you are very excited, so happy and excited, like if you are listening to some Haryanvi music or dance music, you are here. If you are listening to some kind of ghazal, you are very sad and excited, something like this, right? So this is where you want to be. So, and we do this with fMRI, except that we don't play like, some Bollywood numbers. We use this kind of different Hindustani classical ragas. These ragas were tested out by one of my colleagues, Nandini Chatterjee Singh, in this very sort of, I think landmark paper on Hindustani classical, one of the only kind of papers. And what the idea was that, you have different sections of ragas. For example, Hamshadhwani, which a lot of, if you are into classical music, you'll recognize this is associated with calm and happy state, versus Basant Mukhari, which is associated with extremely sad and melancholic state. So we have different kind of raga. Like Rag Yaman is also kind of, somewhere here, it's calm and happy, versus, again, Rag Marwa is also associated with sadness. So we can mix this and mix and match, and in what a classical musician will say, we make a Jor raga, which means a fusion of different ragas, and we play a long stimuli and ask people to rate their emotions. And this is something what it sounds like. So when people are hearing this in the scanner with some noise, so this is how it starts. So as you see, they are recording, and I can record their emotional response with the joystick. It took us a long time to set this up, because in the MRI it's not easy to do the joystick movement, keeping still, everything. He's a human being we are talking about, yeah. And I'm not going to, in the interest of time, go through all the things. But what I want to say that, as you can see, this is a projection on the two-dimensional plane, what you are seeing in time. So essentially, if you go towards the end, what you would see that you span the entire emotional space. So we get all sorts of emotions, right? So we get all sorts of emotion in real time. We can assess now the brain recordings in also the real time. So I'll stop there, here. So now what we did next, based on this earlier study, we expected some kind of a response. Like if you are happy, you are here, you are sad, you are here. So essentially like some sort of a square wave pattern, and we kind of measure certain kind of behavioral markers. Simple things: distance, displacement, instantaneous acceleration of the joystick movement, right? So this gives us some sharp boundaries. So if you are, imagine yourself, like if you are happy in kind of a happy state, you are kind of going, oh, okay, I'm not going to move, I'm going to stay in this space. Versus if you now suddenly change your emotion, you are changing the quadrant. So your velocity and acceleration is going to change, right? So you are not going to accelerate when you are in a stable emotional state, versus you are going to change that value of acceleration as you are changing through emotion. So we can then, instead of relying on their any kind of response, like whether they are happy or sad, use these behavioral measures to identify whether they were happy or whether they were sad, whether they were like, in different states, right?
So this gives us the boundaries, right? So these gives us what we call the boundaries of emotion state. And what we also have is an event boundary where we know we have changed the stimulus emotion where the stimulus emotion has changed. So accordingly, we can measure something like a response time. So let's say I have changed the raga, and the subject of course doesn't know that the raga has changed. They are supposed to respond to the emotion. Now the event boundary from the time of the event boundary from the time the response click, when the acceleration changes, gives me a reaction time to how you change to a basic emotion, right? So that's what we want to do. Now if we plot, so this is your expected curve we should expect, and as you can see this is quite a lot of subjects, about 60 human subjects, which is a big number. Okay, and they almost follow, the correlation is extremely high. So we can play with people's emotions by the music essentially, so we can regulate that emotion. So this is a great validation that even dynamically when you arrange this kind of ragas, it allows you to play with the emotion. You basically now you can look at the dynamics of this part of the like brain scans, and you can see what are the brain networks involved in happiness, versus here you can look at sadness. So, and in a very naturalistic sort of way how it changes in real life throughout the day. Yeah. So first of all, we did a neuropsychiatric battery on these people. So, and as you can see, none of them had, like, there are some bouts of, so these are the emotionality scores, perceptual ability, musical training. So this is called this Goldsmith musical sophistication index. You can do, so musicians will be close to above 60 typically. So none of them were musicians. So we make sure of that. We have the Beck's depression inventory we had, which is a depression in sort of a, rating. We also have this generalized anxiety disorder GAD-7 severity score, and as you can see there's some people on the borderline, but they are not clinically detected as yeah, so I have 5 minutes. Okay, good. So we have this as a normal sort of healthy sort of battery, but there is significant variability, right, as you saw in those violin plots. When we measure this emotional spread, which means the area each person is traversing within that with the joystick, we see some little bit of, not significant, but some trend. But what we found out that these emotional shifts, when we measured the shifts, like for example, how many times they are changing the emotion with the response times, it is highly correlated with their emotionality scores. Meaning this kind of measures gives you, like, it's also correlated with the symptomatic scores which you are supposed to get if you administer some kind of a neuropsychiatric battery. So we further looked at all these different kind of measures, and what was interesting, this emotion inertia, which is a term which we kind of proposed, is something that takes you from happy to sad and sad to happy. And interestingly, when we were seeing this in the behavioral domain, people were highly correlated with this Beck's depression inventory. So for example, if somebody who is like even in this normal sort of range, this person is probably closer to depression. Not clinically diagnosed, but has a propensity. So that person seems to have a higher initial inertia, meaning that they have longer time they are taking to go out from a sad state to a happy sort of raga, responding the happy raga as happy after they have listened to a sad piece of the raga. So versus somebody who is in the lower end of the spectrum is going faster to the happy state. So this we didn't find when we reversed the pattern. When we tried to look at happy to sad, we just totally uncorrelated. So what people in depression are having when they are listening to the raga stimuli, it's a unidirectional thing from going from sad to the happy raga. That time the emotional inertia is more. Yeah. So this gives us again a sort of window to kind of look at the brain data. To validation of these, the neural validations comes from the following. You remember I talked about the acceleration versus the non-acceleration states. So if I take the segment of the brain recordings when people were accelerating versus non-accelerating, meaning you are like changing your emotion versus not changing emotion, and this is actually non-acceleration minus the acceleration, you see the limbic system. So this is essentially the areas of the brain which is known to be all those fearful images, responsive to fearful images. It's coming up, all these emotional areas. Versus when we look at the acceleration, when we are changing the kind of states of the brain, versus the stable emotion state. What we see, this entire frontoparietal networks are getting executive control networks. Some Nivedita talked about the inhibition networks. So those seem to be, lighting up, meaning that at those sort of regimes, we can look at the flexibility or the affective flexibility networks, which we are toying with the term. What kind of if you have a good name, please suggest me. So we'll name it like that. So we essentially want to name this as this affective flexibility sort of network, which is very essential for maintaining your flexibility. So so that's about it. So we in the future we have tested this in a completely different culture in US. So this is a recording from one of my friend's clinic. So he is a neurologist in Loma Linda Hospital in US. So he was very excited. So with this music stimuli, because a lot of this work is done, intracranial EEG work is done with epileptic patients with surgery. So you get a chance to record from deep areas of the cortex. So incidentally, we have recordings from not for any fun purposes, but for their epileptic assessment. Seizure location, know about the seizure location zones. So we have recordings from insula and amygdala as well as hippocampus. So we are recording a lot from hippocampus. We have human hippocampus. And when they are listening to this, classic Hindustani classical music, and believe it or not, they kind of respond almost in the same pattern. They are going through the same kind of, I think this is the recording from one subject. As you see, I showed you in the beginning the recordings from the human volunteers in the fMRI. Looks pretty similar. They kind of ignored this quadrant. Most of the people are, this one person at least is here. So this is the way, this is the setup in the hospital. That's where they are and this seem to calm them down a lot. So this has two values. Usually they are very kind of, they don't want to participate in a lot of experiments because they don't understand. This doesn't relaxes them. They are not really interested, of course, for the science. They are agitated. They are in whatever state of mind they are in. But when you play this music, it also soothes them, it also calms them. So they really want to participate in these experiments. So these are a very good sort of place to sort of, do long recordings. We can record at sleep how their emotion changes, the emotion networks are changing. We have lots of recordings of that. Another thing that we are also doing, this is actually a graduate student from Ashoka University. So this is in collaboration with them. So he is actually a very good musician. So he was interested. So he wanted to see how the neurochemicals change in the brain when you are listening to different ragas. So here we are using MRS, which is a magnetic resonance spectroscopy technique where you can measure different metabolites of the brain. And we also saw here in this beautifully, this is called this dynamic MRS technique, where you can measure the change in GABA and glutamate levels of the brain as they are going through these different sections of the ragas. So we don't have any statistical sort of thing here yet. Arijit has not done that, but we have collected about 5-6 subjects. We want to go about 20 subjects. So these are the summaries. So, identifying the computational substrates of affective flexibility. So one is at the level of the behavior, which I showed you, which gives you a immense handle on addressing the issues that are we face every day, meaning we are all some state of, always we are changing this, our stability states of emotion. Are these clinically meaningful? So we can actually address this kind of questions. Emotion inertia, which I sort of developed from a behavioral level, seems to be a valid marker and show correlation with symptomatic markers. Stable emotion states are characterized by activations in the limbic system versus the switching period, which are very interesting in the context of cognitive flexibility. And it is really a lot of things you can do with it, because you can look at autism spectrum disorder, where you also think the flexibility is lost, also comes from this frontoparietal and frontal executive control networks. So essentially this whole dynamic stimuli paradigm follows this research domain criterion that proposed by Insel, and kind of takes us away from the research design criteria of psychiatry. And I would like to thank the collaborators who have been part of this journey for a long time. Rosalind Moran with the Gates Foundation grant, Beena Koshi from CMC Vellore, we are doing some work on malnutrition. Mohammed is taking forward the intracranial EEG work, and Vivek is also from ISR Biharampur assisting with the neurochemical sort of work, and Nandini and Dipanjan and other people in sort of NBRC. And thank you to all of you and the funders.
Thank you very much, Dr. Banerjee. Yeah, I'll take the privilege of starting first. Just wait, sir. Sir, just wait. I have a question first. Dr. Banerjee, very interesting talk. And in regards to the Raga experiment, I was a little surprised that the supposed control experiment, which is of doing it in the US, you say that they had similar
that was not the
responses.
control. That was not the control. So that was an the purpose of doing it in the US was actually to get close to the amygdala and record from there. So because you don't get through fMRI, you still some activation, bold activation. So if you want to really look at amygdala neurons and the field activity, you have to get to the amygdala. So that's what the US cohort allows us to. It gives you an additional validation that the music, the rhythm in the music is kind of the emotion that you get from, in a very physiologic level, is also very similar across cross culture. There's an interesting study, that study I showed you, that Nandini study. So that was more of the control which I cited. That Frontiers in Neuroscience, Human Neuroscience paper. So they not only look at India, so they looked at other cultures like Norway, they looked at the US. And if you look at non-musicians, everybody, for example, whether it's a non-musician from Norway or Uttar Pradesh or South India or US, they identify Hamsadhwani as calm, happy, Vasant Mukhari as sad. So that's very unique.
I understand that part. I mean, so I was going to come to the sort of ethno-cultural interpretation of this, because I understand you're doing ragas on all these people. You're playing ragas for them. But in fact, the real control would be to play jazz on an Indian population, for example, just for the sake of argument, because jazz is a much more sophisticated version. There isn't really a good or a bad or a happy or a depressed feeling in that. And that's much more nebulous and much more sophisticated in its emotionality. So, and there are other Western kinds of music which, because there's always a threat that in the US, for example, or in any of the developed countries, these people are already exposed to Indian music to a certain extent. They go and eat Indian food once in a while, and they're always playing sitar, etc. They watch Indian cinema, etc. They're far more exposed to Indian ragas than Indians are exposed to jazz, for example, or to any of the other.
That's a great suggestion.
So I think for it to be valid that it's cross-cultural, I think you have to switch the music. Anyway, I'll stop.
That's a fantastic suggestion. Yeah. I think he was next. I think.
Okay, sir.
Yes, I mean something new. I'm listening on that. So if you can comment on this thing, like emotional inertia, very interesting. So can it be considered, or can it be used to sort of diagnose mental condition of a person?
Absolutely, that's our claim. That's our main claim.
And how some kind of biological markers are also involved in that inertia process.
Right. So
and
what?
Third one, last one, can it be regulated for some positive purposes?
All three, yes. I mean, short answer is yes to all the three. Though we have not done the last one absolutely. The first one I hope I showed, and then if we take it, hopefully then in the next stage we can take it to some actual clinical population. And I think there it will be easier to show. Here it is difficult because it's in a subclinical regime. We are kind of explaining the variability, which is always much more difficult. So it works, which is very beautiful. So which gives us the confidence it will work on a clinical population. But whether how it can then be used as an interventional sort of a perspective, I can't say, because that we have to do. There's one thing that people have done, like in the context of autism, is that when autistic children, for example, were kind of instructed with spoken speech versus sung speech, like instead of saying that do this now, you say do this now. So they will respond to that. So this kind of stuff is done in a lot of autistic clinics, for example, who are interested in kids' behavior. So, but not very systematically, which we want to do at some point.
Kind of negative control, last 30 seconds, negative control I'm talking about, you are sort of working on, let's say, healthy subset of people. Let's say if you choose someone who from other behavior, having some mental condition.
Absolutely, this is the clinical validation.
And when you are doing this same kind of experiment, are you also getting some kind of very different or opposite kind of trend, etc., etc.? I'm talking about negative control.
Yes, we should do, and also in that token that the other kind of sounds has to be. So this is one Hindustani classical raga was something I used because it has been validated. But if we get, for example, a jazz stimuli, so difficulty in doing this kind of stimuli is that the psychologists are very difficult people to convince because they also are also into a lot of statistics. So you have to do a lot of piloting and lot of studies to say that this actually some jazz piece or some kind of some piece elicits a particular kind of emotion. So you have to do a study on that. So ideally speaking, you have to use different kind of stimuli, and maybe music is not the only thing. And maybe something like gaming paradigms where you can have more emotional content, like movies based on war, for like showing some kind of emotional feeling. So all these kind of things can be used. So we use a movie stimuli, so which is this movie Anand, which we have used. So that is Ritu's work, that is for another day. So we have not even analyzed the data. So we have used that. So we have looked at other markers with EEG as well. But hopefully some other time I will be happy to
Okay. Thank you, Ravi.
Yeah. See, taking off from what Amit asked about the ethno-cultural aspect of music, we are all exposed to even lyrics of music, right? And most of the ragas which you mentioned, if they are happy, they are associated normally with happy lyrics. And at Mukhari, Adha raga is normally associated with sad lyrics. So this expectation of the brain to be in a certain state based on the lyrics is already kind of built in our culture. So how do you
separate that out? That's a good point. So usually what you are saying that most of even the Bollywood songs are based on some kind of ragas. So in a way that you are exposed to the ragas. So
and the lyrics, so the expectation to be in a state. Because
right now obviously we don't have lyrics, but in a way they are exposed because they have heard some Bollywood music. No, honestly, no clear answer to that.
Okay. Yeah. Then the other thing is, since ragas are a combination of notes, right, musical notes. What about the other culture where, like in the Far East, where you have only pentatonic scales?
All these are possibilities.
And there again, you have happy emotions and sad
emotions. Absolutely.
For example, jazz, pentatonic jazz. Is there in the Far East?
No, absolutely. See, this is just the reason. So this I use the raga as a tool, just because it was validated this set of ragas for some emotion. But we should test out. So these opens up the whole lot of possibilities. That's the whole point. That it's not need to be this set of 8 ragas or 10 ragas. It can be anything. It can be jazz. It can be. So another group. So there is this group where I'm collaborating from MIT. They believe that there is a universal language network. So similarly, the same group also, and some of us believes there may be a universal musicality network. So in a sense that allows you to understand. So it's basically the same network. So which we find out it's this whole Broca's area and auditory areas.
So is there also some work? I'm an outsider to your field, man. But is there also work with rhythms on this?
Yes. So typically this Nandini's group showed earlier that when you take the same raga and increase the tempo, increase the rhythm, usually you change with the same set of notes, you make it faster, it gives you a happy sensation. So tempo, so I actually didn't say that. So that's one control I used. So all the raga that you see, which we played, always in the Gat phase. So if you do it in Alaf phase, it will always be sad and melancholy. Like for example, Hamsadhvani, if I present it in the Alaf phase, it will not be as exciting or calm as, it will be slightly on the negative side. Versus if you go faster, like when you reach Teen Tal, everything sounds happy.
It's much more complex than...
It is complex. It is complex.
Yeah. Last question, Padra, just briefly.
Yeah.
Most of the time we found the music, whatever raga it is, it tends to put a person into sleep. So how many times you have found that your patient gets into sleep rather than getting into all other things? Irrespective of whatever raga you play, because I have my own.
So that's what the joystick, they were playing a game, remember?
No, with that also, the patient can go to sleep because
it happened to 2-3 people, we threw them out of our analysis.
No, you don't throw them out, the language.
The students are at work, so they can't sleep.
That's another, well, we don't want to say that.
Okay, Dr. Banerjee, thank you very much. It was a very exciting talk, and thank you everybody for attending this exciting set of lectures. And I don't know what's next.
Thank you, Dr. Nikunj, for your inspiring talk. And now I would like to invite Professor R. Swaminathan to come on stage and felicitate Professor sorry, Hamid Sharma. Now I would request Professor Arpan Banerjee to come on to stage and Professor Sharma to felicitate him. Thank you, professors. Now I request all the participants of the poster presentation to move on to the foyer, and everyone else to please have some refreshment, and we will recontinue our symposium from 3:55 p.m.
A very good evening to one and all present here.
Recording in progress.
I am Dayashankaran, your host for this session. Now we are honored to welcome Professor Ishan Patro, Professor and Head of Zoology and Neuroscience at Guwahati University and former Vice Chancellor at Ravenshaw University, as the Chair of Session 7 of 95th NASI Annual Session and Symposium. Professor Patro is an eminent neuroscientist with over 4 decades of impactful research and has more than 36 years of dedicated teaching. A fellow of multiple national academics, he is celebrated for establishing India's first university teaching department in neuroscience at Guwahati University. He has also led major initiatives such as the DBT National Program on glial cell research, bringing together premier institutes across India. Recipient of prestigious Lifetime Achievement Awards, Professor Patro is widely respected as a scientist, mentor, and academic leader. Sir, we warmly welcome you, sir, as the chair of Session 7.
Thank you very much for this extremely generous introduction. Thank you very much. I take the privilege of inviting the first speaker. Both the speakers are speaking online. The first speaker is Dr. Krishnaveer Singh. Yeah, both of them are speaking of. They are here? Okay, where are they? They are speaking online. That is. So, the first speaker is, where is? Your name plate is here. Okay, I'm sorry. Let me introduce Dr. Krishnaveer Singh. He is the co-founder and CEO of Listen, an initiative of mental wellness program leveraging AI and technology to make mental health care more accessible across homes, schools, and workplaces in India. We have been listening to these 3 buzzwords from the very morning. With expertise in precision in radiotherapy and adaptive treatment planning, he has published widely. His work continues to advance both mental health accessibility and clinical excellence in cancer care nationwide. I request you to present your lecture, please.
Works? I think I am audible. Yeah. Hi, my name is Dr. Krishnaveer Singh, and my topic is Healthy Minds, Smarter Clinics. It's a privilege and real honor to be here among so much prominent academician. It takes me back roughly 15 years when I completed my PhD from some college somewhere in this world. But essentially now, today, I think I am the business person. Somebody was asking me. I run a company, one of the largest mental health company in India called Listen, and we focus on child and adolescent healthcare, and so good to be part of it and hearing to some very illuminating work that is happening, and so glad that is happening in India. Okay, so whole idea here is that we run multiple clinics for children with neurodevelopmental delays. Then we also working on some AI-powered solutions. We are also empowering our therapists. Actually, in any private setup, we may have the largest number of mental health professionals employed in a single company, if I would say, obviously not under a single roof. We have more than 150 plus therapists, occupational therapists, speech therapists, clinical psychologists, counseling psychologists, and psychiatrists as well. And idea is that how we can scale it, right? So I will focus a lot on the scaling part and the role of AI there, right? So the deep science that I am learning today from you guys may not be, it is not that exciting, but yeah, there will be some numbers which is impactful and how many lives we are touching. Okay, so moving forward. Yeah, okay, good. So the moment we are in the setting the context, right? And as Professor very rightly said, we are hearing these buzzwords from the morning, right? Obviously, this esteemed audience is very well aware about the Indian mental health crisis. 1 in 7 of us, officially at least, suffer from some kind of mental health need. Then on top of it, the number of mental health professionals, especially psychiatrists, is so low. The ideal number should be 3 per 100,000. We have only 0.75, right? And interesting part is that if you think about artificial intelligence, one of the most important roles that artificial intelligence is playing, we agree, we disagree on that, the clinical effectiveness of it. 50% of the people who have mental health need is going to ChatGPT, by the way. And out of that, 80%, by the way, 80% people are getting some kind of good support also, right? This is as per the ChatGPT places. Also, quite a few therapists are using it for their notes and stuff like that. So that's the movement we are in, right? As I said, like I'm a business person, I have to work as per the need of the market as well as the need of my customer. So I cannot ignore AI. Now, when we think about it, so Listen started 4 years back. Before that, I was in Uber, and there was some mental health episode with me and my co-founder Tarun, and we decided to build this. So we came up with these 6 A's. I think again, no patent here, but the whole point here is that if you think about it, right? Awareness, acceptability, and anonymity, right? That's largely the societal problems. And accessibility, affordability, and assurance stands for quality. That is where somebody, an operator like us, can try to solve it a little bit. Now, today's talk, I really want to focus on child and adolescents' mental health, because again, mental health is huge. A lot of things are happening, a lot of interesting work is happening. If we just talk about the children who need support for their neurodevelopmental delays, that is around 10% of the population of children in India, that is around 13 million. And unfortunately, like any other place, less than 20% are treated. So what actually happens, this is now what happens on my clinics, as we call them, Sunshine by Listen, right? Parents see some physiological issues, right? When they see those physiological issues, like my child is not speaking well, my child is not walking well, things like that, they try to find out what's happening. So first of all, the diagnosis is in disarray, right? And whenever, again, please listen to me from the perspective of scale, because our vision is to solve mental health at scale. So there could be some very good work happening in some place or the other, right? But if you think about the population at large, and even in bigger metro cities, right? That's the problem. Second thing is that even if you get some solution, 95% of the market is a single clinic of single specialty like occupational therapists, speech therapists, etc. Then on top of it, if you are able to get into some kind of treatment, and I'm talking from the parent perspective, right? I have 2 kids of my own, one is 13, another is 10. And my son had a speech delay. Thankfully, he was not on the spectrum, but me and my wife has gone through that pain, and which may be resulting in starting Sunshine by Listen. Then there is a treatment turmoil. It's not a one-day affair, we all know about it, right? So essentially, what is happening, it's a very, I would say, non-clear kind of thing. It's not like you're measuring a blood glucose or a blood pressure, right?
Then the progress parallel, how we are moving forward, right? We get so many people from other centers, from other places where they said like, we did 6 months, we don't know what happened, right? So that treatment journey is broken. So what generally is happening, let's say another 5% of the market is not like what we are doing. We are obviously doing one of the few things, but mostly is that you bring all kind of therapies at one place. You get integrated services, because when the child is on a spectrum, just one particular therapy is not needed. You need different kind of interventions at the same place, right? Second thing is you standardize the treatment. Whether you walk to our Pune center, or for that matter our Kota center, or for that matter our Delhi center, right? You will get a standardized treatment. The diagnosis is standardized. What are the assessments we are using, those are standardized, right? And then we obviously, the last but not the least, right? And this is my own learning. From the business side, I worked in Flipkart. It grew by 10x during my time period. Then I worked with Uber, which grew by around 5x, those 5-6 years, setting up those marketplaces. Standardizing the supply is one of the biggest challenge in India, right? We never thought like we will not have drivers in this country. When you put any population, and I was the GM for Mumbai, drivers was not gold, diamond for me, right? I know many of you would have written some strong words against Uber Mumbai for surge. Main problem was there was no supply actually. So similarly, here also you have large number of people who are graduating, especially speech, special ed, and occupational therapists, right? Maybe, and counseling psychologists also, not that much clinical psychologists and psychiatrists, but standardizing them, it's a big problem. How you handle the customer, how you handle the parent who is going through that turmoil, right? That becomes quite a bit important. So that's what a child development center should do, and that's the first step in moving forward. But the problem is, like, and this is our map, we are in so many cities and stuff like that, right? But it's still 90% of the people will never have any access or affordability. Even wherever, like, if I grow 100x from here, right? Or not just me, in fact, all the CDCs grow 100x from here, we will not be able to reach 90% of the people. And that is what really excites me, right? That's really bring the techie out of me, right? Though I may have moved away from publishing in technology, but I have not moved away from technology, using technology. So, lot of interesting things happening, and I come from a very small town in Uttar Pradesh called Muzaffarnagar, जिनको पता होगा मेरठ के पास पड़ता है. So I'll use this Hindi phrase कि AI तो वरदान है. It's literally a boon for us, because it's an opportunity which none of us thought existed even few, not years, maybe like, we can talk 24 to 36 months ago, right? Before the, ChatGPT 3 came along in the route, right? So why I'm saying so? Because the role of AI is transforming how the whole ecosystem is working. First of all, it's about early screening. AI can identify a lot of markers are there, you can train them, and it's not the whole idea, again, friends, very important for us, all of us to understand, right? I'm not saying that AI will replace a therapist. AI will replace a human. It's a lot of assistant that can do. So from that perspective, a lot of early screening, and it can also help in awareness. Friends here will know that if you intervene a year ago before you took your child, the chances of him getting better managed is actually 5x. So that's where it plays a role. Then obviously decision support, where we are using, right, lot of guidance to the therapist from how the decision can be making, because again, it's not just a problem like as I told about blood glucose or a blood monitor, blood pressure. In itself, right, it's not easy. I was hearing, right, and there was a discussion, I think in the last talk about the optimism of the research. And yeah, we research people get optimistic, we want our papers to be published, right? But essentially, it's a difficult thing to have a very accurate, that is where it can help. Therapy augmentation, lot of time can be support during the therapy also, lot of help can come.
And last but not the least, it can really help the customer, the parent of the child, to have an outcome tracker. A very clarity, like, in your hand, you can see what's happening, right? And specifically for that kind of healthcare issue, which is so suboptimally defined in terms of outcome. So that is where the case comes. Now, that is where the step 2, which I think at least Sunshine by Listen is, but that is where the CDCs are today. That I think the topic of my talk, right? Smart clinics, right? So smart clinics comes, you have the core child development center, service oriented thing where all the therapies are happening. Then obviously you put the ops engine behind it, which is like more of a CRM or ERP, whatever you want to call. But from layer 2 it starts happening. You have therapist, you have Ray AI, sorry, it's our own word, but basically an assistant of parent. I think in the interest of time, I wanted to show you a video. Do we have the time, sir? Okay. Anyway, I'll show you something towards the end. So essentially, it shows like how all these three comes together, and from the starting, and this is happening as we speak. You walk to one of our centers, you will get diagnosis. That diagnosis, or even before diagnosis, a lot of things you can talk on WhatsApp, the AI that we have developed. You can answer your question, what is speech therapy, how you are different, what is occupational therapy. I didn't know about occupational therapy before I started my own company. I thought like physiotherapy, what's the difference between PT and OT, right? So those kind of things we can answer. Then you can have all the things happen at one place. You will get session by session notes what's happening. So that is happening right now. But again, 80% of India cannot afford it. And if we want to solve at scale, how we can do it, right? So this is the part which I want to talk about. So what we really want to do is that generally, and this is not just for us, we are always below the market, that's the thing. At center, full therapy for a month, because it's a 1 hour therapy, takes you anywhere 15 to 25,000 rupees a month, right? 6 months at least, you are down by 1 lakh rupees. Then we are talking about hybrid. We are already at center plus home. Some of the things you can do at home, some of the things you can do at the center. But really the third one, right, which is if you can actually help an at-home AI-led, where you are actually, again, very important when I show it to you, it's not about you are exposing the child to the screen. No. One of the larger, and again, I'm not a researcher, but from my own knowledge, right, we see somehow around 1,000 children on a monthly basis and seen more than 10,000 children till date.
You have 8 more minutes.
Screen has a big issue in terms of increasing the ADHD, right? So that is where the accessible part comes into the picture, and this is that's where AI from an opportunity actually becomes a necessity if you really want to take it to the masses, right? And where you will enable the parent with the help of the AI, at least in the mild and moderate cases, to provide a solution, at least some solution to the problem. What we are doing it very quickly, because I want to show you something towards the end, is that we are developing this 4-layer architecture. One is the acoustic model, that's the ears. That is happening, we are generating more than 9,000 sessions data on a monthly basis. Then on our clinicians that are working, those 150 people, they are the judge. By that, the AI learning is how to be the judge. Then obviously we are putting a lot of things behind the brain, because there is actually literally zero data on the AI algorithms for special need children in India. We are developing that. And then obviously we want to reflect back it to the parent in terms of an empathetic voice, which feels like, you are helping them and they feel like you are connected. So this is what we are planning to do. These are more about us, but I think I'll just skip this. I just want to show you, because of the interest of time, and this is my last slide. What the future looks like, where we are working with this 4-level architecture.
He is 3 years old. He should be speaking 100 words by now. But he only manages 9.
नमस्ते पूजा, मैं रेणु, आपकी पर्सनल चाइल्ड ग्रोथ पार्टनर। क्या हम कंसल्टेशन शुरू करें? यस, चलिए। वेरी नाइस। पूजा, अर्जुन को बोलो अब माँ ट्राई करे। माँ। माँ। थैंक यू पूजा, काफी यूजफुल सेशन रहा है। बस 1 मिनट, मैं सब प्रोसेस कर रही हूँ।
Ray understands exactly what each child needs.
These are the markers basically.
Perfect. Here's Arjun's personalized plan.
Every day, 10 minutes. Every small win, celebrated. Progress isn't perfect, but it's real. Week after week, sound by sound, parents become partners. The child finds confidence. 8 weeks ago, Arjun couldn't say mama. Today,
Mama, party please. Oh my God, Ray, आपने सुना? Ray auntie, पानी. I am so happy, and I am speechless.
Ray is being built on 600 plus hours of daily therapy sessions at Sunshine. Across speech, occupational, ABA therapy, and special education for all kinds of development issues. Building granular intelligence, having deep expertise in specific domain, as well as integrated intelligence with multidisciplinary coordination across. Because Arjun is not the only one. 30 million children in India need development support.
So yeah, that's it from my side today. And thank you very much for listening to me. Happy to answer any questions.
Thank you. Just wonderful. We can take a couple of questions if they are there. No? Actually, 1 minute. Yeah. Actually, your the movie at the end, you know that's
So,
the entire story.
Can I go? Yeah, please. So, yeah, it's very interesting. I mean, there is a lot of scope, certainly, for a lot of different use cases. Have you considered, putting up a use case in these standardization platforms? Because right now, so I am sort of the convener of these international standards for which ISO has started for PCI interfaces. And there are multiple use cases that are being discussed. I can give you a contact of the Bureau of Indian Standards person who can help you to put it up as a use case. The advantage is that, there is a bunch of experts from P15 countries who look at these different, based on your data, that it will remain confidential, but you can get ISO certification. And I think more of these techniques for trustability need some kind of certification and some kind of, validation through some agency. I mean, international agency is the better one. So I think, what are your thoughts on that? Have you thought?
No, I think that's really good because, as you said, one of the most important thing in healthcare is trust. And trust comes when you have a third-party validation if there are certain standards. In fact, we would be happy to mark ourselves according to that. As I said, we try to find out any data published in a certain way which is
at least commercially somewhere in terms of AI for the children with special needs, you will not find. Even a single speech therapy model is not there. So would be happy to participate and bring more and more indigenous data for standardization. Really good session, thank you. Sure, I think ma'am has a question here.
Many of my friends across they have come across such problems. The thing is, only the child is not only responsible. Okay, it's during the pregnancy time, whatever the medication the mother consumes, it plays an important role, because 0 to 3/3 month. One should take care. Pregnancy is a natural phenomena. Actually, extra medication is not needed. Okay, and nowadays they are simply giving calcium, B2, B12, B12, lot of supplements, and without awareness mother consumes, and it has an impact on the child. So both aspects are important. To our olden days, mother, they were not exposed so much of medications, no?
No, absolutely, and not only that, think about all the pollution that is there, that is happening around us.
And another thing is, parents should take care after the birth. Both mother and father plays an important role to take care of the child. And because of the job and they are very much busy in schedule, no, a little bit of negligence. They leave their child in the daycare centers and all. It has an impact. So it is up to us to take.
No, absolutely.
Before it goes late.
No, absolutely. If you ask me, I give you one sad statistics. 40% of the issues where we were not able to continue the required treatment as per the prescribed, you can say prescription, because the parents didn't agree with each other. Mother wants to do it, father doesn't want to do it, father wants to do it, mother doesn't want to do it. And unfortunately, it's a very tough thing for the parents to continue as well, right? Because it's a long-term problem. And in fact, obviously there would be some published study. If we just do some Google Scholar search, we'll find out children with IVF and children who are born pretty late in the 30s and 40s of the parents, they pick up the developmental issues faster than other children. That's lifestyle, that's our life choices, everything is happening. I agree with you on that.
Thank you very much. I'll go to the next lecture. The next presentation is by Dr. Rimjim Agarwal. Dr. Rimjim Agarwal is a co-founder and chief technology officer of BrainSight AI Private Limited, an accomplished neuroscientist and technologist at the interperson of AI, brain research, and mental health innovation. She holds a PhD in computational neuroscience from NIMANS, Bangalore. And Dr. Agarwal is a member of the Organization for Human Brain Mapping. I hope she is online. Please. Dr. Rimjim, please start your presentation.
Yes, I hope you can see my screen.
Yes, ma'am, your screen is present.
Great, and I'm just putting it on the full screen. Thank you so much for the warm introduction, and thank you so much for the opportunity of presenting with such esteemed members. What I'm going to present today is how the technology can be used and how AI can power it, specifically in neurotechnology. So these are some of my points of why we require AI for neurotechnology, how AI can power it, what are the key advances that we are having these days, and how a technology from lab can come to a clinical space. So you all know that brain is such a complex organ. If you look into what brain is connected, how the brain is connected, and there is a specific analysis for it. It is called as connectomics analysis. What it particularly entails is the detail of how the brain is functioning and what is connecting those functional regions. Now, if you look into how the connectomics has evolved, it has evolved from understanding it from a very small organism, models like C. elegans and models like Drosophilus. So in those first, these were studied and it took 20 years to understand the connectomics of these organisms. It is said that for brain, it will probably not be possible to understand the brain and connectomics of the brain in our lifetime, maybe in other generation. But then how can we understand it in a way that is interpretable at the moment? Another way of looking into it could be a macro level understanding of brain, which requires understanding of various modalities to get together to interpret some of the information at higher level instead of going at the micro level. And that's a technology we are currently working on. We have several studies done on it, and that I would like to present over here. Now, macro level requires three major modalities, which is structural MRI, functional MRI, and DMRI. To understand this better, I usually give an analogy of how Google Map of the brain is utilized. So in the Google Map, if you see, there are traffic map, which can be understood as analogous to the functional mapping of the brain. However, completely brain is much more complex than that. The tracks could be understood as the uh, road maps, and destination can be defined with the structural understanding of the brain. So when we use these three together, it can help us to do the analysis on top of it, and it becomes better to understand how the things are utilized in terms of translating the signals in the brain. So the details that we utilize for understanding the tracks is water molecule moving inside the brain. Now, capturing those water molecule and interpreting it in the format which could be helpful itself is difficult, and there are many techniques which can be utilized. Earlier, deterministic tractography was utilized, and now we are using probabilistic tractography. To simplify it, these are two different methods where and probabilistic is more sensitive and deterministic is more specific. Now, if you look into another set of modality that I mentioned, it is functional MRI, which is where we are taking the maps and translating where different functions of the brain lies. And that is the functional map. Both of these, when it comes to the from the machine, are very grayscale in nature. Structural image as well as functional image, both of these images are very grayscale in nature, and it doesn't look like in the format that I have just represented to you. So it requires us to do a lot of processing on top of it. Now, these processing itself has many important phases. We are doing the processing of a complex data set, which is 4D data set. Time series 3D analysis of brain is happening, and that's a very complex data set to process. Extracting the relevant signal, classifying and inferencing those signals, and providing information back in the format which can be utilized by the clinical person, clinical professional who's utilizing it for their work. To give you a context, these are very much needed in performing surgeries. Now, the region of the brain where language region is there, where vision is there, or where is the motor cortex for the person, and it is individualized to a certain level. It is very important for neurosurgeons to know what potential risk he could be running into before performing the surgery. So overall pipeline that we have is also subdivided further and making it a very complex system to do the processing and inferencing of these data sets. If somebody is interested, I can go in detail about this. Otherwise, I would skip it for the interest of the time. So giving you one example of what the denoising look like and why machine learning is very crucial in some of the denoising perspective, because these data sets are coming from a machine, and we require very robust mechanism to remove it. The denoising itself could be of various kinds, and there could be various types of noises that we need to recognize. There are multiple steps that we perform, and these are not limited to what is there on the screen. So in many of these specific regions, we are utilizing machine learning led denoising, skull stripping, many more which is required to process the data set to give us the best possible outcome, which can be further utilized to do the inferencing on top of it. Some of the use cases that it can be used right now is on the screen. Like number one, there are so many patients who are undergoing brain surgery, and many of those lose many of the important functions. Like if the tumor is very near to the vision, there could be some deficits which can cause after the surgery or post-surgery impact, or the tumor itself causes a huge impact on the connections or the functions of the brain. Speech deficit, cognitive deficit, motor deficit. There are many deficits which are possible during the brain surgery or after the brain surgery. Then there are around 90% of the people who are undergoing radiation therapy. They also require proper planning when the radiation therapy is happening, so that the regions of the brain where radiations are crossing, they also need to define the dosage. And if it is a very crucial region of the brain which is required for cognitive activities, if those are receiving high dosage, then there are cognitive deficits which happen for many people. And it has been seen that 90% of the people experience cognitive decline within the 6 months of 6 months of undergoing the radiation therapy. In such cases, there are both malignant and benign tumor cases, where in the malignant cases and in benign cases have to live with that for the whole life, and the improvement in cognitive domain are not as much as in the recovery. And for the rehabilitation also, all these functional region understanding is very crucial, and only 50% of the people are getting any individualized rehabilitation in the world, and the requirement is huge to understand what are the good therapies and plans for improvement. So these are some of the use cases and studies that we are working on. However, this is the output that we provide to clinicians, which helps them. So there are language connectome and motor connectome on the screen. It is a 3D map. I would explain quickly, like this is a track which is connecting the functional region of speech, out of which there are these important eloquent cortex network and also some of the cognitive networks, which are very crucial for understanding. This is one of the data coming from one of the institute we closely work with, and it is compatible with the S8 neuronavigation system of Medtronics. It is also compatible with BrainLab neuronavigation system and HRS neuronavigation system for making it easy for neurosurgeons to work with the data. So these are some images which are output of all the machine learning algorithm plus the processing that we have been doing in the background, and some of the outputs that we have is also corroborated with the clinical outcomes present with the hospital. So this is default mode network. It is also a cognitive network. Default mode network and central executive network are the two networks which are specifically looked into quite a lot with some of the hospitals that we are working with, because they have planning and execution, which is very crucial for patient to have a better quality of life post-surgery. So this is from another neuronavigation system. These are some of the validations that we keep in place because it is required for us, and it is also a validation done using DES, which is direct electrical stimulation performed in awake craniotomy, so that it can play as the basis of validation of these. Now we have been part of more than 1700 surgeries across India and present in 52 plus hospital buildings and another 40 hospitals performing the pilot using our toolbox. And we are also doing studies in radiation therapies to make sure that the cognitive decline outcomes could be improved over time. So various important functions that I just mentioned, neurosurgery, neuroradiology, psychiatry, we want to eventually utilize these in psychiatry space as well, so that if we have better understanding of functional deficits and changes, it can eventually be used for better therapies, but it would take longer amount of time because MRI is not usually performed in psychiatry right now. So majorly we are working with the neurosurgery and neuroradiology. However, we have started working in psychiatry with some of the institutes and started analyzing the data for pre and post assessment of improvement after medication or therapy to indicate what are the major regions of the brain which could be of interest to some of the clinicians. I will wind up with one of the important understanding that what we are doing right now is solving the whole puzzle. However, like I mentioned before, these are multiple layers in which we are working. The processing happens, extraction of signal happens, classification happens, and information engineering happens. In these, for a certain use case, we need to maybe change the information engineering layer, or we need to change either the extraction of the signal, or we need to change the classification and inferencing. So the possibility of utilizing the technology along with AI and machine learning is huge. We have started getting interest for medical device company to do the validation of their devices. Like there is a hearing device and it helps in improving speech overall. So they want us to analyze the language region of the brain and how it is performing pre and post after utilizing the medical device. So many such important use cases are also coming up, which is of immense potential in future for improving the clinical understanding of brain. So that's what we do. And we have to undergo a lot of compliances, and all these are the compliances that we undergo. And if somebody wants to talk about it, like how these to be done, these compliances can be done for the medical devices, I would be happy to discuss about it. Thank you so much. If there are any questions, I would be happy to take it.
Thank you very much, Jim. This was a very decent presentation. Speaks everything and slides up. Any questions or queries or comments, please? Okay. Yeah, please. Yeah, Dr. Imsim, this is Dr. Ravishankar here. I'm out of your field, but I just have a curious question, which is you mentioned in tractography, you follow the path of the water molecules in the brain, right? For signaling.
Yes, so it is orientation of water molecules in the brain, which is the principle of diffusion MRI.
Yeah. So how does that, where does AI come in there?
So once we have processed the data, like one example that I mentioned, there is something called as Gibbs noise, which is a very standard in neuroscientist fraternity to make sure that we are removing the Gibbs noise. Now, it has been happening over the past years. It has been happening using conventional logistic algorithm, but now we are utilizing machine learning on that so that it can recognize the noise coming from various sources, because we are getting data from so many machines. So it should ideally become more robust. And that robust nature comes from us training the machine that, okay, these are the types of noise which we are getting. This is the input, this is the output. We train the data, we train the algorithm using this data, and then it gives us the denoised image, which is, for the validation, we compared it with the good gold standard denoising algorithm which were already present in neuroscience space. And now it is performing for a large number of data sets using machine learning.
Okay, thank you.
And and the second place where we are using machine learning is also now we are training database to understand the tracks and the streamline in the DMRI itself. So DMRI has a larger streamline base. Like I mentioned, there are multiple methods. There is deterministic, there is probabilistic. Using the probabilistic outcome itself, we are now training DMRI output algorithms as well to give a better output by using these methods, because these methods are very expensive, and ML algorithms are lesser compute and time expensive.
Yeah, sure. Thank you.
Thank you, ma'am. It was a nice presentation, and I'll go a little bit into technical. I was just curious to know that have you used this data augmentation in your pipeline? And I also wanted to know from you.
Can you be a little louder, please?
I also wanted to know that first question is that have you implemented data augmentation in the pipeline which you have developed? The second thing what I wanted to know from you is that suppose if we use different type of data augmentation methods, for example, GNN, VAE, variation autoencoders, and now you might be seeing this, people are using these diffusion models also. So in fact, diffusion model reduces a lot of noise. So like, in case if we use the data augmentation step and we use these three different algorithms, and then how it will affect the the sensitivity F1 score and all. So have you experimented with those? Like, just wanted to know.
Absolutely. So functional MRI is slightly difficult to it is difficult to do the augmentation of functional MRI itself. However, because the variation in functional MRI is huge and we don't know there is no way to know what would be the correct data outcome and what would not be. However, we have used it in the structural MRI doing the tumor segmentation. So when we are doing tumor segmentation, we augmented the data. We had around 80,000 data points, and we augmented it further to make sure that we have an understanding of enough data set in the structural MRI part while we are doing the segmentation of edema region, the necrotic tumor, and all those details. So we utilize it in structural MRI because there are ways to validate if the augmented data is correct or not. However, in functional MRI, there are no ways, so we are not it would be extra effort to make those technology to do the augmentation of functional MRI. We have not used it in functional MRI. Does it answer your question?
Yeah, thank you. Any more questions, please? No. Somebody
Thank you.
from.
So you have used UNIT, I think.
Yeah.
We have used autoencoders actually.
Yeah, Dr. Kothari is.
Nice presentation, Dr. Rimjim. I have a small query. You are a private company. So what sort of services do you provide and who are your customers?
Our primary customer segment right now are neurosurgeons and neuroradiologists. We are now present in 52 hospitals in India commercially. Last year, we got our licenses of CDSU manufacturing, which is like software as a medical device, in March 2024. And now, after that only, we can perform the sales after getting the license. So now we are in 52 hospital buildings in India, and another 40 are doing the pilot studies with us. Pilot as in like what we give is they can utilize and see if it is useful in their surgeries or not. Also, they do awake craniotomy, so it also helps in validation. Immediately, they can validate our results while they are performing the surgeries. So, yeah,
What is
the
impact of your presence in 52 hospitals in terms of outcomes?
It's humongous and it's very humbling. I would say it is great to see how the technology can be utilized positively. Of course, we needed to de-risk a lot of things before giving it into the hands of neurosurgeons, and that is a responsibility that we had to perform. And on top of that, we always go back and take the feedback and incorporate it, improve our algorithms, improve our accuracies and everything. So of course, it requires a whole village to make a technology
and collaboration.
The possibility of expansion of your kind of services are huge. What is your comment on that?
Eventually, we want to be medical technology or a research technology which can be used across the world for anything related to brain. We are sitting on a gold mine of important brain data set which can be utilized in an ethical way to improve the clinical condition of the people, the workflow of how the clinical workflows are happening right now. So it would be immensely helpful. That's how we see that everything coming into the brain should be done by brain site, maybe ethical brain Google, comparable to that. That's what we want to be in
Thank you,
future.
Rimjim.
All the best.
Thank you, Rimjim. Thank you very much for your
Thank you.
lecture. And thank you all.
Thank you, speakers. Now I would like to request the chair of this session, Professor Patro, to felicitate the speakers. I extend a heartfelt thanks to Dr. Rimjim for her insightful online lecture. And now I would like to call upon stage Dr. Krishna Veer Singh. Can we have a huge round of applause, please? Professor Patra, I would like to request you to stay back on stage. Now I would like Professor Mishra to felicitate our speaker. A huge round of applause, please. Thank you, sir.
So we'll start our next session, that's the plenary talk, in few minutes. Just bear with us for 2 minutes. So we're going to start our next session. Please kindly take your seats. Harsh? Sonu ka hai? Yes, put it on. Huh?
Yeah, just put it my laptop in.
All Sonu ones. No, all Sonu.
No,
He
don't
has
put my
already put
laptop.
them.
Do not put laptop. Do not put your laptop, please.
Just a second.
Yeah, you put it in.
He's just calling
You
the...
put it to presenter mode. नहीं लगा दो.
I'll introduce and then...
I know, I just want to check it because it's a little bit technical.
Sure.
If you change the laptop, I'm stuck. I will not get the presenter. मेरा वो कार्ड भी इधर लगा कार्ड है ना वहाँ पड़ा है वो कार्ड वो हाँ लेके हाँ you put it in presenter view yes yeah what is the name of the just in case I have backup. And this goes this way, right? Yes. Thanks. Yeah.
I would like to request everyone to please settle down. We are going to start our session. I would like to welcome everyone for the 8th session. So we have survived 7 sessions. We are in the 8th session now. And this session is a plenary talk. To chair this session and to introduce our speaker, I would like to invite Professor Vinod Singh, President of NASI, onto the dais. We have heard about Professor Singh many times, but I would quickly want to introduce Professor Singh again today. So Professor Vinod Singh is Professor Emeritus and Institute Chair at IIT Kanpur and President of the National Academy of Sciences, India. And he's a renowned synthetic organic chemist. He's been honored with Swarna Jayanti Fellowship, Shanti Swarup Bhatnagar Prize, and the Padma Shri. As the founding director of IISER Bhopal, he has played key contributions to national science, and he's also played a transformative role in shaping India's scientific and educational landscape. So we warmly welcome our chair and our guest for today. So, sir, please.
Good evening. Today we have the privilege of welcoming Dr. Swati Piramal, Vice Chairperson of the Piramal Group and one of India's most influential voices in science, healthcare, and responsible business leadership. She earned master's degree in public health from Harvard, MBBS from Mumbai University, blending medicine and management to transform India healthcare ecosystem. For over 30 years, Dr. Piramal has driven innovation at the intersection of medicine, industry, and public policy. In her role as director of the Piramal Foundation, she has led transformative work in rural healthcare, education, women's empowerment, and access to safe drinking water. Dr. Piramal's contributions have been recognized nationally and internationally. She is a recipient of the Padma Shri, France Knight of the National Order of Merit, the Knight of the Legion of Honor, and numerous awards celebrating her impact on business, public service, and global health leadership. She has served on the boards of Allergan India, Essilor Luxottica, Sidra Medicine at the Qatar Foundation, and previously Nestle India, and brings decades of academic association with Harvard University. It is an honor to introduce a visionary leader who continues to elevate India's presence on the global stage. Please join me in welcoming Dr. Swati Piramal. Over to you, ma'am.
No, I just want to advance it through this. Good evening, everyone. It's an honor and privilege to be here today.
Excuse me, ma'am. Can we remove the flower? Because the flower is hindering, we are not able to see your face.
Okay, maybe. No, the problem is my presentation is a little bit technical, so it will just help to do this one. Yeah, that's better. Good, beautiful. Thank you so much. Thank you so much. Professor Devendra, the head of this august institution, and Professor Mishra, our old friend, because of whom I'm here today. He's the convener of the 95th annual session of Professor Vinod Singh of NASI. I'm really delighted to be here on this plenary session for the 95th annual session of today. And I'm really honored to be inducted as a fellow of the National Academy of Science. I'm going to speak about a few things on my agenda: the future of health, learning from the past, the opportunity in the geopolitical turmoil that our country is in, using systems thinking and seva bhav, technology and partnerships that prosper, giving women's health a voice, the lamp that lights, and the seva bhav anthem. Today our country stands at a crossroads. Her strings have to be turned for a deeper and more complex music than those of nature. They have not yet found harmony. They are apt to break into the ugliness of discord. They are incomplete and painful in the global turmoil. In this geopolitical turmoil, it is actually the great hope of the future. We require ups and downs in our life's geography in order to make our thoughts active. Today, the scientific life is a journey into an unknown country where winds and storms flow but keep our minds active in dealing with them. We are like a stray line in a poem, which ever feels that it rhymes with another line, but must find it or miss its own fulfillment. This quest of the unattained is a great impulse in man which brings forth all the best creations. If you look at the journey of science, as illustrated by the Narlikar book, in the pre-1950 came Ramanujan's mathematical genius, Saha's ionization, Bose's particle statistic, Raman's discovery of light scattering, and Ramchandra's structural biology. And post-50, it was nuclear power, the Green Revolution, the Indian space program, the high-temperature superconductivity, and indeed setting up CSIR, which really collaborated with industry. I think these were all our great achievements. However, strikingly, none of these post-1950 achievements came from Indian industry. They were mission-driven, government-funded endeavors, and unlike US, Europe, China, South Korea, where science-led companies like Google, Apple, Roche, BioNTech, Huawei, Samsung, many others became global innovation leaders, India still lacks a comparable science-based enterprise in industry which has made a global mark. I feel that a block of stone is unplastic. It is insensitive, it is inert. But for a sculptor, he carves an image out of it. Science is a place for humanity's sculpture, a place that is not just a factory of scientific papers. And in a line I will quote again and again in this presentation from my mentor and guide, Dr. R.A. Mashelkar, think of what we can do. But it solves the problem of our country, and think of what we need to do. Instead of thinking just like a scientific papers and writing them, is we can do it. Of course, our brains are very good. But what do we need to do in our country? By providing a unique, multidisciplinary research environment. It nurtures curiosity, innovation, and impactful problem solving across all major domains of science, engineering, medicine, agriculture, and emerging interdisciplinary areas. So the future of health, I believe, lies in thinking about not what we can do, but what we need to do, making a difference in the quality of life by reducing the burden of disease. A few days ago, I heard a story from a Swamiji. There was once a man walking in the forest. He was troubled by grave financial difficulties, but took a walk to clear his thoughts. On the way, he saw a fox. The fox had only 2 working front legs, and his hind legs were paralyzed from injury. The man was puzzled. Though the fox was disabled, he didn't look like a starving animal, and in fact looked quite hefty. He observed the fox quietly. At dusk, he saw a lion holding a piece of juicy meat, walking towards the fox and dropping the meat in front of him. The man was struck by a thought that the Lord in his wisdom had the lion share a piece of food to the disabled fox. Just like that, he had a realization that he thought the Lord would take all his financial troubles away. He went home to tell his guru about this realization. The guru said, you only thought of what God would give you, despite having both your hands and feet. How would it look? How would you feel if God's intervention, metaphorically like the fox, would benefit you? But what if you thought that you were a lion? What service or seva you could do for others? Doing the service for others is the most important thing in life. As a young doctor, I was driven by this idea of seva bhav. I saw a child who had lost the power to walk due to polio. And I started a polio rehab clinic that served 25,000 children a year. Mother Teresa came and blessed us. In a few years, there was so much success that we closed the clinic. And this showed me an early success that public health matters, that you can make an impact using public health. And today, of course, we have a widespread polio immunization program. This was very early, and it hadn't started at that time. I'm a doctor, an industrialist. I like to call myself a philanthropist, somebody who gives back. But for decades, we ran a pharmaceutical industry and making the best quality medicines which could heal every citizen in our land. But I was convinced that health problems of India could be only solved by Indian science. I had over 500 scientists trying to find new drugs in the vast botanical richness of India. I just saw a beautiful book on the botanical medicines you have only on this campus. And I tried to do this across India. I fought for patents and innovation. It was widely feared at that time that our people would die in a tsunami of patented drugs. Nothing of the sort happened. We Indians are a very smart people. And I can remember the words of President Kalam. Your argument, he said to me, rests on the assumption that Indian scientists will be the one producing new medicines rather than Western scientists. But what makes you think that Indian scientists can suddenly do this? And he gave the example of a bumblebee, that everybody thought a bumblebee could not fly because it was fat, it had small wings, but the bumblebee flew. And therefore, he said, that's what you need to do with your research. A big challenge, however, is India's R&D investment by industry. It's really very low, and we have to increase it to match our peers. My scientists had 250 patents in new to the world drugs, out of which 3 have reached the global market. I can confidently say that if our regulatory system was partial to Indian innovation, more would have reached the global market. 20 years ago, they were convinced that only generics would work, and what was invented abroad must be copied in India. Yet we fought an uphill battle, but I still wonder why some of my drugs are sold all over the world, but not in my own country. We must change this. Regulation and price control must encourage innovation. I actually drew this picture using AI because it reminded me of the time as a young doctor I went to the regulator and I said, this is my new to the world drug which is used to repair cartilage, sir. Could you please give it? I've done all the trials, all the evidence is here. Will you approve it? He took his book out, black book, and said, which was generic copies, and he said, no, but it's not in the generic list. So how can I approve it? And it never got approved, but it was now sold in Germany, Switzerland, and many other countries. So this regulatory framework must become a facilitator, not a bottleneck, I believe. Innovation is never a solo act. The journey from mind to marketplace is a symphony, not a solo performance. Yet our awards still privilege individuals. India must move towards celebrating teams, scientists, engineers, financiers, entrepreneurs who together assemble the complex puzzle of innovation and deliver solutions that change lives. Our relationship with Indian science, as Tagore said, is a key to the future of health of our nation. It is Satyam, which is data, Jnanam, which is knowledge, and Anandam, which is for the health of people. Our living body has needs to eat, to sleep, to work, or rest. But it has one permanent wish, which is hidden, and it is deeper. It is the wish for health. It works every moment, fighting diseases and making constant adjustments with changing circumstances. Winter, summer, the pH, anything our body is adapting. Medical science must establish and nurture that conscious desire and those which are latent deep inside, healing the body naturally. 77 years after independence, India is still lagging in our SDG indicators. I'm sorry to show you this video, but it is something that my team saw for real, and I've tried to show you what is actually happening in 200 million of our countrymen who live in the tribal areas.
मेरा नाम जैस्मिन खौरा है। मैं कोरापुट का चंडीगुड़ा में रहती हूँ। मेरा कम्युनिटी परोजा है। हमारी कल्चर में 3 पर्व मनाया जाता है, चैत पर्व, आम पर्व और दिवाली पर्व। जब हम पर्व मनाते हैं तो हमारे ट्रेडिशनल में ये कि हम घर में खाना नहीं पकाते हैं और दारू पी के नाचते घूमते रहते हैं। हमारे ट्रेडिशनल में यही है। और एक टाइम ऐसा हुआ था जब हम पर्व मना रहे थे तो हम अचानक से नाच रहे तो अचानक से खबर आया कि एक औरत ने उसकी 2 साल बेटे का गला काट दिया। तो तुरंत हम जाके पूछे क्या हुआ बोलने से वो बोले कि नहीं, हमारे एक बाबा जी ने बोले थे कि नहीं, अगर आपके घर में पैसा सुख शांति कुछ चाहिए तो अपने 2 साल बेटा का गला काट दो।
And so this young girl was then sat to work on it.
2 से 20 से 30 से हम काफी 300 से ज्यादा लोग हैं। तो जैसे कि मैं बोलती कि बहुत बली प्रथा चल रहा है, जैसे दारू पीते हैं, एजुकेशन भी करते हैं और चाइल्ड मैरिज भी करते हैं, उन्हीं के ऊपर हम काम करते हैं और लोगों को जाके हम समझाते हैं। तो पहले 2 और 30 से थोड़ा हमको दिक्कत हो रहा था, लेकिन अभी हम 300 से ज्यादा है। तो अभी हम घर घर जाके और थोड़ा पड़ोसी घर में मतलब गांव में जाके भी उनको समझाते हैं और थोड़ा अभी सुधार आया है।
So young leaders is whom we promote to help in tribal communities tackle the big problems, hemophilia and so many diseases which really significantly affect our tribal population. We focus on improving the lives of vulnerable communities. This is the Piramal Foundation. The dots that you see are where we work all over India. We leverage the power of youth and the spirit of service or seva bhav. Yet why haven't we able to solve the great big problems of our country? 200 million people live with diseases like stunting, hemophilia, drug-resistant TB. Why can't we use system thinking to solve the problems of infant and maternal mortality? I would like to share a few slides about the work we do at the Piramal Foundation here in Assam and around India. This is a small army of young people. I said, is my own little army. 5,000 alumni, 800 new Gandhi fellowships every year. Currently in the Northeast, we have nearly 1,000 people working. And these people are driving change from the high incidence of breast cancer that we see in Kamrup district and in the Northeast to tackle the problem of primary health in flood-prone areas where the facilities are washed away 6 months in a year. The 5 states marked in blue, we are in one of them, are the bottom quartile with significantly lagging indicators. So since 2010, Piramal Foundation has been a catalytic force in Assam, strengthening health systems, empowering decentralization, and driving digitization for the last mile. 83 mobile medical units provide doorstep health in every single village of Assam and Arunachal Pradesh, and have been doing it for the last 15 years. And indeed, in the flood-prone areas, I believe they're called the CHAR areas, we provide medical support, and we reach really remote locations through this accessibility. In one case, living life on the edge, we saved a mother and a newborn who was born on a boat in the flooded waters of the Ganges. Improving access to maternal, newborn, and child health services in the tea gardens of Assam through innovative models, cross-sectoral partnerships, and strengthening health systems. I believe IIT Guwahati also working here, and really we would love to join hands to improve this. One of the things we do is called Sarathi 104, Health Information Helpline, 24/7 services through a clinical decision support system using 800 algorithms. So digital transformation is the key to change in the public healthcare facilities in Darang district. And everywhere we are getting scale. We're not doing things little. It's 2.5, 3 crores, 10 crores, 20 crores, 30 crores of people who we are trying to really help. Whatever we do as a philanthropic organization is only 0.1% of effort or money that we put in. But it reads, because we work only with the government, we get scale and we have a 10% impact because of that partnership. So 0.1 goes to 10% because the government is India's largest NGO and it has the most money to spend on the social sector. So Michael Porter did a study on our work in the 112 aspirational districts. We started working with 25 and now it's 112. And he showed that we outperformed almost every other person who was working there. So the impact that we had in infant and maternal mortality is something I'm so proud of, using labor room practices, using mothers who are in, very high regions of Kashmir even, or really the remotest areas, excuse me, to improve infant and maternal mortality. Digital transformation was critical. Using our technology, our command and control center in Patna tracks all the district hospitals. Now UP and Kashmir also are looking at this model. And this is how we use technology to look at TB in tribal areas. Yeah. Excuse me. So Red Wing is our drone supply, which goes and flies to the remotest areas of India and brings a sample back. It's really nice to see the drone with the TB sample. So this is how we apply technology to remote areas. We can't work alone. So we have a wide number of partnerships, both domestic and international. I think women are the center of creative expression, a cadence of restraint in her behavior, producing the poetry of life. In India, we call her Shakti, the creative power. Yet in India, women have a weak voice regarding her own health, which comes after her family. And therefore, Indian women suffer disproportionately. 70% have anemia, mental health issues, rising dramatically, bone strength. The list is long. But we try to have technology and solve the problem of all these complex genetic disorders using genomic sequencing. The lamp we light in the darkness of a room is a tiny wick as a little oil. Yet the flame is not timid, burning as it is in the heart of immense darkness, for the truth of the light is infinite. On a personal note, I turn 70 next year, and I've spent a lifetime in science, medicine, industry, with Dr. CSIR and SAC-PM. Many of you were with me on those boards. At IIT, Mumbai, Harvard, Monash. And I thought, it's nearly time to retire. Now, I can just do what I want. But you know what happened? I got a letter from Professor Ashok Mishra, says you have to join this august institution of NASI. I got a letter from the Prime Minister saying that I must serve on his board. So I said goodbye to all my retirement plans and said I must try to do this. So Rabindranath Tagore wrote these lines in the Sanskrit language. He said, a bird is twice born. Once born in an egg, it's born, and then it finds the freedom of the unbounded sky. The liberation of your limited self to the freedom of the spirit shows that dualism, an existence in obvious facts and its transcendence into a realm of deeper meaning. You are not a sum of facts, but a goal that is beyond all that is past and in the present. And that is where I thought, it's like a bird, you find pleasure and comfort in your nest in the past, in my company, in my work. But today, I think I have the pleasure within the bound walls to release out into the limitless sky. So my heart sings as of today. And I want to, in summary, want to just leave you with a few thoughts again. What we need to do instead of what we can do, using Seva Bhav and systems thinking in all our work, using partnerships and technology and getting scale. Is not about a few lakhs here and there, a little center here and there, but across the country and really solving the deep problems of poverty, lighting that lamp of knowledge. I'd like to leave you with what I call the Seva Anthem. It was written by Rabindranath Tagore about the same time that he wrote our national anthem. And it was in Bengali, right, sitting at his house. I restored it. The poet Javed Akhtar wrote it in Hindi. We put it to music, and it is shot on all locations of our foundation where we work across India. So it just gives you a brief glimpse of the scale of the work. And just to show you that, oops, replay. This last one. Yeah. Yeah. Can you play this? Yeah. Yes, yes, it's going. Oops. Did you check it? Sorry. Okay. A little bit volume. Thank you. Yeah, sure, sure.
think Madam will be happy to take queries, questions anyone has.
Okay. Sorry, what was the
You
outcome?
showed that drone survey was done, no? What was the significant outcome that came out of that exercise?
Oh, the Porter survey? Oh, that they surveyed all the foundations and NGOs working in the aspirational districts. They found that in 25 districts where the Piramal Foundation was working, because of the way we think, systems thinking, Seva Bhav, we outperformed all the others. There were many other groups working, even Gates Foundation and others. But when the Prime Minister saw that, he called us and said, now from 25, you have to do 112. So we didn't know what to say, but we had to, have more people and try and do this. So here in Northeast, we work in all the aspirational districts. My colleagues Najib and Toiba here, they really work on the ground with young people, with youth, to change things here. And we found, for example, that Kamrup and the Northeast had the highest amounts of breast cancer were in Kamrup district. And I said, why? Why should it be more than Bombay city? But we found, and it was done with Dana-Farber, so make sure that our numbers and data are right. It was because of tobacco. And, in the east, the northeast, it is stomach cancer because of fermented fish and meat. And those things, why can't we know the causes, why can't we do something? Why should we have 200 million people with genetic disorders when we have the best genomic facilities? So my mind's thinking about a biobank where we can put all these tribal communities together to see how we can find some genetic linkage and really solve the problem using science. So what I showed you were the big problems of India. Maybe the PhDs that we are doing should actually look at those problems and see how can we solve them instead of just doing some nice work, which is, of course, very good. But how does it then coincide with what the Prime Minister wants and says, I want to lift these out of multi-dimensional poverty. Unless 200 million people then match the rest of the country, we will not be able to get there. So that was the outcome of the Porter study. Please.
It's always such a pleasure to listen to sheer poetry always and motivating. So my question is, when you showed in the tribal belt, they did self-organize themselves and you moved into a group of 300. So do you see this expanding circle of influence and self-organized communities and regional leaders coming so that the foundation can gradually step away and move to newer areas and then they self-sustain. So unless in a country we are able to have these self-sustained, self-organized initiatives, one would get limited to small pockets.
Exactly. So we have 800 what we call Gandhi Fellows, which depend on youth, and they go out into the community and make change. But we started a new fellowship called the Karuna Fellowship, looks at disadvantaged women, women who have some problem. Either they're widowed or they're disabled, and they learn digitalization, the great digital area of moving into the community. And we have found, like, for example, hemophilia, you go and tell people, don't marry this one or that one, not going to work. So we have the champion from inside. A nurse herself had hemophilia. 5 of her brothers and sisters had hemophilia and had bleeding disorders. And she was so passionate about it. She became the change maker for the whole community. So it was really important to get the change from within. So we never do things alone. We collaborate with hyper-local, different NGOs. And we always work with the community. We always work with the government. But something like a biobank has to be done by a government because no private enterprise should do it, because it should belong to the government. So I think that's the way I think will be the future of health, is just getting high science into the real problems of our country. Thank you for that question.
Thank you, ma'am. I don't see any hands, so please join me in thanking Dr. Swati Piramal.
Ma'am, thank you, ma'am, for the very insightful and thought-provoking lecture. I would now like to request Professor Vinod Singh to felicitate Dr. Swati Piramal.
I'm wearing Assamese sari, so nice Assamese.
We are also finishing the induction ceremony for Madam because she has to leave. Santosh? Santosh?
So may I please, ma'am, with your permission, read the citation? The National Academy of Sciences, India, Dr. Swati Ajay Piramal, Vice Chairperson of Piramal Group, Mumbai, has been elected Honorary Fellow of the National Academy of Sciences, India, NASI, for the year 2025 for the enormous contribution of public health and philanthropy. Please join me. Congratulations. Yeah. Special host, past President Ashok Mishra, please. Thank you. Thank you. Yeah, very first.
Nasi has only 10. You're one of the 10, I think.
First woman, a woman's voice speaks.
इनको दे दीजिए जो कुछ बाकी का नहीं. Thanks, Ashok. Sign the register. Yeah. Yeah, so now the fellows meeting, right? We can begin that. So do we start we can start the fellows meeting? But that's part of the fellows meeting, yeah. So we seamlessly now transition into our next event, which is the fellows, the meeting of fellows. We've already had the fellows induction. We have to begin this. We have a special event, a short event, which is a book release. So I would request Professor Ashok Mishra, our past president, to please come up and give us details of this special book, book which is unique to India and something that NASI is proud of having put together, which has to do with the birth of calculus in India, right? So please, sir. Why don't you introduce him?
Okay. So I'll just be very brief. Professor Ram Subramaniam Krishnamurthy, as his full name is.
Yes, sir. Please come.
He is a professor. To give you a little background, the government said that we should start Sanskrit in IIT Bombay in the year 2000. So what we did was we got people who would be Sanskrit scholars as well as scientists. So he's a PhD in high energy physics, theoretical physics, and then also an expert of Sanskrit. So we hired him as a faculty member in IIT Bombay. But I'll just go fast forward. And then later on, when I was, during my presidency, which is a long time ago, but of NASI, we commissioned a book basically to translate. Well, let me give this background. As I understand, in Kerala, there was a Kerala School of Mathematics, which existed for 200 years, and calculus was actually born there. But for some reason, as I understand, after 200 years, there was a gap, they were lost, but the scriptures are there. So we requested scientists, come Sanskrit scholar, to translate that and explain what is going on in that book from a grant from NASI. So he took his time to do it, but finally the book is ready. So it took a long time, but it's a very unique thing, and now we have a center for traditional Indian knowledge, which has started in IIT Bombay. So this will be one of the things which will start. I know Swati ji has to leave, so over to Ram, as I call him. So 5 minutes, he'll explain about the book, and then we'll release the book.
Short 5 minutes, sir.
Okay. Namaste. So I'm delighted to be here. And it was a brilliant talk by Dr. Swati. This is something which was totally unknown to me. So when I came here, I'm just reminded of one thing. Professor Mishra said in one sentence that we had a brilliant school. I don't have much time to talk about that. But this book, which is going to be just released, is called, the title, The Elusive Ratio and the Advent of Calculus in India. What we mean by this elusive ratio is the most mysterious number, pi. We don't have, right? So the first infinite series expansion for pi is from the Kerala school, which is almost 3 centuries before. Normally, we study it as Grigori Leibniz series in our calculus course, but the series is just given in a verse. Vyase varithi nihate, rupahrite vyasasagarabhihate, trisharadi vishama sankhya bhaktam rinam swam prithak kramat kuryat. Vyasa is diameter, varidhi means number 4, vyase varidhi nihate, so 4 times d, rupahrite vyasasagarabhihate, trisharadi, 3 means 3, shara means 5, adi vishama sankhya. Vishama sankhya means odd number. So he just says that the series is 1 minus 1 by 3 plus 1 by 7 minus 1 by... So it just goes on alternating series with all the odd numbers. This is the first expression, as all of us know, for expressing pi with the equal sign. Pi is not equal to 22 by 7. It is approximately equal to. So that's what. So how did they invent this series? Not only they found this series, they have also discovered the series for sine theta, for cosine theta. All people who know engineering, we know this. They have all been beautifully couched in the form of verses. So this book is essentially talking about, and that's why we have called it as Advent of Calculus in India. So that said, I just want to add 1 or 2 points just within 2 minutes. So inspired by listening to her talk. So the 2 slides were really striking me. One is you just had this beautiful where the planetary motion is there, the person is sculpting, etc. So how India has been really flourishing with various kinds of science, architecture, arts, etc., etc. Then you had the Seva Bhav. So I'm just reminded of a beautiful saying by the greatest poet Kalidasa. I was just reminded as I was listening to your talk. He says, in Meghaduta, we would have heard of beautiful lyric. So there in one verse, he ends it saying, Apannarti prashamana phalas sampado hyutamanam. Uttamanam means the noble people. Sampadaha, the wealth they possess. What is it meant for? Apanna arti prashamana phalaha. Apanna means one who has gotten himself into some form of affliction. Arti, the pain that he experiences, prashamanam is removing. So the wealth that one possesses is primarily meant for alleviating the sufferings of those who are in need of some support. So this is how he brilliantly ends. And actually, he beautifully weaves, so our culture, he beautifully weaves this with the poetry. So he says the Megha, which is supposed to travel, he tells the Megha that if you see somewhere that the mountain has fire, most people will be affected in the mountain, the animals will be affected, the trees will be burnt. The wealth that you possess is in the form of water. So you just stop there, shower, finish the fire, and then move forward. So I just wanted to tell you, you have taken that so seriously in your life. I'm so happy, delighted to learn that. And I must also say, Professor Mishra, so he was just trying to tell, so when I joined IIT, see, science, etc., they have a lot of funding. You understand? But I was working in a domain where neither science nor history. So like Trishanku, I was in between. So Professor Mishra said that we are going to support you with NASI. So he used his power. Apannarti prashamana phala is applicable to him also in a different way. So the wealth that he possessed in getting me in at IIT Bombay, that was a great transit. I never felt. I just came for a conference and he had this vision to just invite me to join as a faculty. So I thank the NASI for providing me this opportunity, and the book will be released shortly. Thank you.
Thank you. Yes, sir. Yeah, come. No, both of you, please come. Yeah, please. Yeah, please do the honors, ma'am. Yeah, you can.
You will add further thoughts.
Yeah. Thank you very much.
Oh, please. Definitely.
Yeah. You can give it to Nasi. Our copy. Because this one doesn't have the preface. We have to put the preface. So, do we continue with the meeting? So, we continue now with the proceedings of the meeting of fellows. And the most important task ahead of us.
Somebody has a flight to catch, so we can call.
Yeah, so I will move quickly, and I think the main task before us is to induct our new fellows, and I thank you all the new fellows especially, who have come here and will be inducted shortly. So the induction consists of us giving you the certificate and reading out the citation, and for you to please sign the register. I understand that we have one request for early departure by virtue of flights. We understand all of you have had some degree of difficulty coming here, but you made it like we all have. Thank you for that. Is there any other business we need to do, Santosh? Santosh is not here, so good. So we don't have any other business. So let's get, normally there is some business that we transact for the fellows is, yeah. So we will begin the induction ceremony, in which we will ask, we'll read the name, request you to come up here, and then two things will happen. you will be given the shawl and the badge. And then as you go out, we request you to sign the register. Where is the register, please? Can we keep the register on the front desk? Where is it kept?
I think we can keep the register here.
Yeah, maybe you can. Yeah. So you can sign the register as you leave, and all right. So I've been handed this this agenda for matters of business. So let me breeze through it. Agenda item number 1. So I call this meeting to order of all the fellows, newly inducted as well as our existing fellows. Agenda item number 1 is to read and confirm the minutes of the fellows meeting held on September 27 at 3:30 p.m. in the council room of the Academy at Prayagraj. I think the minutes have been circulated. We have not received any. Santosh, we have not received any comments on the minutes? No comments. All right. So can we treat as read and passed? Yes, please. Okay, thank you. The second point is to confirm the recommendations of the council regarding the number of fellows and foreign fellows to be elected during the year 2025 as under. The number of fellows, excluding those in the area of science and society, will be 80. And the number of fellows in the area of science and society for the year 2025 will be 4, and number of foreign fellows will be 8. It has been recommended that the combined maximum limit of foreign fellows to be elected in a year shall be 10. Earlier it was 5 in each, now it is 10. So is this is recommended by council, it is approved by fellows? May I have an approval? Yes, approved. Okay, thank you. So it's approved. And now I think that concludes other business. Now the important task of the induction. So we will begin this task of induction. I would request our Executive Secretary, Dr. Santosh Shukla, to read the names, and we will do the needful. Thank you. Sorry. So may I suggest we follow this order? May I suggest we follow this order, that you will please come this way. We will give you, and you will sign and go out that way. Right? So this will be the process.
Some of the fellows who has leave to, because their flight is very soon, so we can call him or her first, and then we will start the rest.
Do you know who that is?
Sir, क्या नाम उनका? हाँ?
I understand there is a special request from 1 or 2 fellows who have a flight to catch.
क्या हुआ?
Do we or we don't? Okay, we do. Sir, can you please? Yeah, can you please come? We'll make. Okay, so we'll go as per order.
Certificate, please, just this is in the order. So we will start this newly elected fellows for the year 2025, and start the name in alphabetical orders. Achari Srin Guru Naga Bhushan from the Bhabha Atomic Research Center, Mumbai. I'm calling the name, maybe some of the fellow are not here, so then we can call the second one.
Yeah, we'll move to second one.
Then Adiga Satish Kumar from the Manipal Academy of Higher Education, Manipal. Nahi hai? Then the Agarwala Amit from the Indian Institute of Technology, Kanpur.
Yeah, please come, sir.
Kindly just, I request to the General Secretary, sir, to kindly read the citation and then hand word.
So Dr. Satish Kumar Adiga, Kasturba Medical College. Is this yours? No, this is not yours. Sorry.
Oh, please. तुम इसको चेंज नहीं करते जा रहे, जब नो हो तो देन अमित अग्रवाल.
This one? All right. So Dr. Amit Agarwal, Indian Institute of Technology, Kanpur, has been elected fellow of NASI for his pioneering work involved condensed matter physics, theoretical physics, and physics in general. Congratulations, sir. Please sign the register on the way out.
Then the next name is Amit Avasthi from the Transitional Health Science Technology Institute of Institute Faridabad. Sir, are you here? Yeah, thank you.
So while Dr. Amit comes, Dr. Amit Avasthi has been elected Fellow of NASI for the year 2025 for his pioneering work involving infection immunology, cancer biology, and inflammatory bowel disease. Congratulations, sir.
Next one is Bala Bamsi Krishna from the CSIR Central Glass Ceramic Research Institute, Jadhavpur, Kolkata. Sir, are you here? Oh, yes.
So Dr. Vamsi Krishna Bala, CSR, CGCRI, for his pioneering work involving biomaterials, additive manufacturing, and surface engineering. Congratulations.
The next one is Bihari Sanjay, Director, Sri Chitra Institute, Trinal Institute of Medical Science and Technology, Trivandrum.
Thank you, sir. So Dr. Sanjay Bihari, Sri Chitra Tirunal Institute of Medical Science and Technology, Trivandrum, has been elected fellow for his pioneering work involving neurosurgery. Thank you. And many other fields.
The next one is Pratap Bhattacharya from the ICAR National Rice Research Institute, Cuttack. Pratap Bhattacharya?
Pratap Bhattacharya is here. So Dr. Pratap Bhattacharya, ICAR Central Rice Research Institute, Cuttack, has been elected fellow for his pioneering work involving soil science, climate change, and carbon dynamics. Thank you, sir.
The next one is Jyotirmaya Biswas, Director of University Ocular Pathology, Shankaracharya Netralaya Medical Research Foundation, Chennai.
So Dr. Jyotirmaya Biswas, Shankar Netralaya, Chennai, has been elected fellow, once again, sir, for his pioneering work on uveitis, ophthalmic pathology, and ophthalmology. Congratulations.
The next one, Surya Sathi Bose from the Indian Institute of Science, Bangalore.
He is here, Surya Sathi. Yeah. Thank you. Please come, sir. Dr. Surya Sathi Bose, ISC Bangalore, has been elected fellow for his pioneering work involving polymer science and engineering, plastic upcycling and recycling, and vitrimers. Thank you.
Then one Rajarshi Chakrabarti from the Institute of Technology, Bombay, Mumbai.
So,
sir, further name is also, sir, on the display. So the next fellows are requested to kindly just read it for them.
For his pioneering work involving theoretical chemistry, statistical mechanics, soft and active matter. Congratulations. Thanks for coming here. Thank you. Please sign on the way.
Then Shubhananda Chakrabarti from the Institute of Technology, Mumbai.
I don't think he's here. No, he's not here.
Then Kaushik Chakrabarti from the CSIR Institute of Genomics and Integrative Biology, New Delhi.
Please come. Dr. Kaushik Chakrabarti, CSIR Institute of Genomics and Integrative Biology, Delhi, for his pioneering work involving biochemistry, biophysics, and yeast genetics. Congratulations, sir. Please sign the register.
Subrata Chakrabarti from the Indian Institute of Engineering, Science and Technology, Shivapur.
Shivapur, yeah.
Sir, are you here?
Yeah. Please come, sir. Dr. Subrata Chakrabarti has been elected fellow of NASI for his pioneering work involving civil engineering, structural engineering, uncertainty quantification. Congratulations, sir.
Okay.
Thank you, sir. Please sign on the way out.
Pranjal Chandra from the Indian Institute of Technology, BHU Varanasi.
I don't think he's here, yeah, not here.
नहीं है. Then Praveen Chandra Sikh Karappa from the TIFR Center for Applicable Mathematics, Bangalore.
Not here.
Then Tapan Kumar Chaudhary from the Indian Institute of Technology, Delhi. Sir, are you?
Not here.
Then Harsh Chauhan from the Indian Institute of Technology, Roorkee. Tapan, oh sorry, sir. Sorry.
Sorry. So Tapan Kumar Chaudhary, Indian Institute of Technology, Delhi, for his pioneering work involving protein folding, molecular chaperone research, and recombinant biotherapeutics protein. So you'll get official photographs, don't worry. Thank you, sir. Please sign on the way.
Then Harsh Chauhan from the Indian Institute of Technology, Roorkee. Harsh Chauhan.
Harsh is not here.
Viswanathan Chinnuswamy from the ICAR, Indian Agriculture Research Institute, New Delhi.
Please. Dr. Viswanathan Chinnuswamy, ICAR, for his pioneering work involved abiotic stress signaling in plant phenomics and genome editing. Thank you, sir. Congratulations. Thank you, sir. Please sign on
The fellows who has conferred this award, we request to kindly stay here. We have a group photographs to all the presented fellows, sir, please. Joyanta Chaudhary from the Indian Institute of Science, Education and Research, Bhopal.
Joyanta is here, yes. Welcome, Joyanta. Joyanta Chaudhary for his pioneering work involving organometallic chemistry, catalysis, and energy. Special honor for you, sir. Sir, nahi diya. Thank you, sir. Badge, please sign on.
Then Ashwin Dalal from the DNA Fingerprinting and Diagnostics, Hyderabad.
Dr. Ashwin Dalal, Center for DNA Fingerprinting and Diagnostic, Hyderabad, for his pioneering work involving medical genetics, clinical genetics, and pediatrics. Congratulations. Wonderful work. Thank you, sir. Yes.
Next one is Santa Sabuz Das from the ICMR, National Institute of Occupational Health, Hyderabad. Occupational Health, Ahmedabad. Oh, so during your application we have received, and even the fellow card also, I hope that this
is correct. Is this correct or is not correct?
But this is for the
This is correct. Okay, great. For his pioneering work in molecular medicine, microbiology, and immunology. Thank you, sir. That's Sandeep Babu Das. Thank you, sir.
Next one, Jyotirmay Das from the Indian Association for Cultivation of Science, Kolkata. Okay, sir. Next one, Niloy Ganguly from the Indian Institute of Technology, Kharagpur.
Welcome, sir. Please come. Dr. Niloy Ganguly for his pioneering work involving natural language processing, network science, and machine learning. Thank you, sir.
Santosh Janardhan Gharpure from the Indian Institute of Technology, Mumbai.
Yeah, he's here. Please give. Thank you. Come, Santosh. Dr. Santosh Gharpure, elected for his pioneering work involving organic chemistry. Congrats, Santosh. Sign the register.
Next, Santanu Kumar Ghosh from the Indian Institute of Technology, Bombay, Mumbai.
He's here. So Dr. Santanu Kumar Ghosh, IIT Bombay, for his pioneering work involving chromosomes, plasmid, and fungi. Congrats. Please sign on the way.
Sandeep Sitaram Ghugare from the UGC DAE CSR, Kolkata.
Please come, sir. For his pioneering work involving in-beam gamma ray spectroscopy, shell model calculations, open source tools for teaching and research. Congratulations. Thank you, sir. So please sign on the way.
Next, Dhinkar Raj Gopal from the Madras Veterinary College, Tanyus, Chennai. Okay. Sonali Gun from the Institute of Mathematics Science, CIT Campus, Chennai. Then Pawan Gupta from the CSIR Institute of Microbial Technology, Chandigarh. Pawan Gupta. Next one, Sandeep Gupta from the Tata Memorial Center, Mumbai. Heartiest congratulations, sir. Please
Dr.
give a big
Sandeep.
hand to Sandeep Gupta.
Please come up, sir. Congratulations. Thanks, sir. Long. So, Dr. Sudeep Gupta, for his pioneering work involving medical oncology, breast cancer, and gynecological cancers. Heartiest congratulations. Long deserved.
Pallab Kanti Haldar from the Jadavpur University, Kolkata.
For his pioneering work involving phytochemistry, phytotherapy with special reference to diabetes, pharmacology, and toxicology. Dr. Haldar, please. Thank you. Congrats. So please sign on the way. Thank you.
The next name is Lakshmi Sanjeev Dudmani Inamdar from the Karnataka University, Dharwad.
She's here. She's here. For her pioneering work involving endocrinology, reproductive biology, and developmental biology. Congratulations, ma'am.
Please give a big hand to Dr. The next one is Vikas Jain from the Indian Institute of Science, Education and Research, Bhopal. Dr. Vikas Jain. Then Siddhartha Sankar Jana from the Indian Association for the Cultivation of Sciences, Kolkata. Rupam Kapoor from the Delhi University, New Delhi. Rupam Kapoor is...
Rupam Kapoor, yes, she is here.
Rupam Kapoor.
Yeah. So Dr. Rupam Kapoor, University of Delhi, for a pioneering work involving interaction of plants with pathogenic and symbiotic fungi and microbial biotechnology. Congratulations. Please. Yeah, welcome, ma'am. Well deserved. Please sign on the way out. Thank you.
The next one name is Nagaraj Amritesu Kestur from the IQAC program, University of Mysore.
For his pioneering work involving plant microbe interaction, plant protection, and nanotechnology, agriculture, and plant taxonomy. Congratulations, sir. Lot of fields, sir. Congrats, sir. Please sign on the way out, sir. Thank you.
The next name is Sneha Sudha Komat from the Jawaharlal Nehru University, New Delhi.
Yeah, just a moment. We are. Please come. Please come, Dr. Sai. For a pioneering work involving glycobiology, enzymology, and biophysical chemistry. Dr. Sneha, please. Thank you. Heartiest congrats. Thank you. Please sign in the way.
The next name is Sanjay Kumar from the Institute of Science, BHU Varanasi.
Dr. Sanjay Kumar for his pioneering work involving theoretical physics, biological physics, and computational physics. Congratulations, Dr. Sanjay. Please sign on the way.
The next name is Vatsala Devi Adarsh Nair Kumaran from the Indian Institute of Science, Education and Research, Bhopal.
Yeah, please come. For his pioneering work involving ultrafast and nonlinear optics, low-dimensional semiconductors, and applied physics. Thank you. Please sign on the way.
The next one is Manoj Kumar Kumhakar from the BARC, Mumbai. Manisha Rajan Madhikar from the ICMR National Institute for Immunology, Mumbai.
Congrats, Manisha. For a pioneering work involving immunology and hematology. Yeah. Please sign on the way out.
The Shishu Madhav Maganti from the Central Tobacco Research Institute, Andhra Pradesh.
Please come, sir. For his pioneering work involving plant molecular biology, agricultural biotechnology, and host pathogen interactions. Thank you, sir.
The next name is Tapas Kumar Manna from the Indian Institute of Science, Education and Research, Trivandhipuram.
Not there.
Then Ram Sarup Meena from the Institute of Agriculture Science, BHU Varanasi.
Not here.
Ram Mohan Mekala from the National Geophysical Research Institute, Hyderabad.
For his pioneering work involving igneous petrology and geochemistry. Congratulations, Dr. Raman.
Asmita Mukherjee, the next name is Asmita Mukherjee from the Indian Institute of Technology, Bombay, Mumbai.
So Dr. Asmita, IIT Bombay, for her pioneering work involving high energy physics, theoretical QCD, and hadron physics. Congrats. Please sign on the way out. Exam हो रहा है. Traffic jam. Signing. ठीक है. We'll go ahead. We'll move ahead.
Sir?
We'll go ahead. We'll move.
Then Viswanathan Arun Nagaraj from the Institute of Life Sciences, Bhubaneswar.
For his pioneering work involving malaria, parasitology, and biochemistry. Congratulations, Dr. Viswanathan. Thank you. Please sign on the way.
The next is Santosh Nampi from the Calicut University, Kerala.
Please come, sir. Aye, sir. Speak this up here. For his pioneering work involving angiosperm taxonomy, pollination biology, and pteridophyte taxonomy. Thank you, sir. Yeah, thank you, sir. Okay, thank you, sir. Please sign on the way up, sir.
The next name is Dibyantu Nandi from the Indian Institute of Science, Education and Research, Kolkata.
Please come, sir. For his pioneering work involving astronomy, astrophysics, and planetary sciences. Congratulations. Thank you. Please sign on.
The next name is Gayatri Panaghat from the Indian Institute of Science, Education and Research, Pune. Not yet?
Not yet.
Then Siddhartha Pandey from the Indian Institute of Technology, Delhi, New Delhi. Next name is Dr. Sanghmitra Pati from the ICMR, Department of Health Research, Ministry of Health and Family Health, Government of India, New Delhi.
For a pioneering work involving public health, multi-morbidity, primary care strengthening, and implementation science. Thank you very much, ma'am. Heartiest congrats. Oh, thank you.
The next name is Vandana Bharat Patravale from the Institute of Chemical Technology, Mumbai.
Yeah, please come, ma'am. For a pioneering work involving medical device development, nanoparticle engineering, lipid-based drug delivery systems. Congratulations, ma'am. Well deserved, ma'am. Please sign the register on the way.
Amritanshu Prasad from the Institute of Mathematical Sciences, Chennai. The next name is Ravi Shankar Ramchandran from the CSIR CDRI, Lucknow.
Yes, sir. Welcome, sir. Welcome, sir. Congratulations. Always welcome, sir. For his pioneering work involving structural biology, drug discovery, and molecular mechanisms. Please sign on the way.
The next name is Ashish Ranjan from the NIPGR, New Delhi.
for his pioneering work involving leaf development, photosynthesis, and environmental signaling. Please sign on the way out. Thank you, sir.
The next name is Jyoti Babu Retnama from the Regional Center of CSIR National Institute of Oceanography, Kochi.
Are you here? Yes. He is
Jyoti Babu.
For his pioneering work involving oceanography, ecosystem functioning, and plankton dynamics. Congratulations.
Rajesh Sagar from the All India Institute of Medical Sciences, New Delhi.
For his pioneering work involving psychiatry, medical and allied sciences, and neurodevelopmental disorders. Thank you, sir. Thank you, sir. Oh, yeah. Please sign on the way out. Thank you.
The next name is Deepti Ranjan Sahu from the IIT Delhi, New Delhi.
For his pioneering work involving structural engineering, earthquake engineering, and vibration control. Dr. Sahu, congratulations. Thank you, sir. Please sign on the way.
Next name is Nand Gopal Sahu from the Kumai University, Nainital.
Welcome, sir. For his pioneering work involving solid waste management, energy storage, polymer composites. There you go, sir. Please sign on the way out.
The next name is Jitendra Sheetal Sangwal from the IIT Madras, Chennai.
Congratulations, sir. For his pioneering work involving chemical engineering, petroleum engineering, and environmental engineering. Congratulations, Dr. Sankar.
The next name is Gopalan Srivatsan Srigachi from the Indian Institute of Science, Education and Research, Pune.
You're here.
Dr. Gopalan.
For his pioneering work involving chemical biology, nucleic acid technology, and chemoenzymatic labeling technologies. Yes, sir.
The next name is Aditi Sen De from the HRI Prayagraj. Prateek Sen from the IIT Kanpur. Atul Sharma from the IIT Bombay, Mumbai.
Congrats, Atul. For his pioneering work involving theoretical and computational fluid dynamics, AI/ML, mechanics and computing, fluid structure interactions.
सर साइनिंग का भी फोटो लेना है दोनों हो जाएगा प्रवीण शर्मा फ्रॉम द एम्स जोधपुर
For his pioneering work involving metabolic syndrome, lead toxicity, and molecular diagnostics. Congratulations, Dr. Sharma. Thank you, sir. Thank you so much, sir.
The next name is Pratyush Shukla from the Institute of Science, BHU Varanasi.
Welcome, Dr. Shukla. For his pioneering work involving enzyme technology and microbial biotechnologies. Congratulations. Thank you, sir. Thank you, sir. Please sign on the way out.
The next name is Abhay Kumar Singh from the CSIR Central Institute of Mining and Fuel Research, Dhanbad. Dr. Abhay Kumar Singh, not here.
Not here.
The next name is Harminder Pal Singh from the Punjab University, Chandigarh. Ranjay Kumar Singh from Indian Council of Agriculture Research, New Delhi.
For his pioneering work involving community-based conservation of natural resources, multiple stressors, and adaptation strategies, social ecological systems, and livelihood resilience. Lots of fields, sir. Congratulations.
The next name is Ravi Prakash Singh from IIT Delhi, New Delhi. Next name is Richa Singh from the Indian Institute of Technology, Jodhpur.
Hi, Richa. Heartiest congratulations, sir. Well deserved. Dr. Richa Singh for her pioneering work involving machine learning, biometrics, and responsible AI. There you go, ma'am. Thank you. All the best, ma'am. Please.
Trilok Nath Singh from the Indian Institute of Technology, Patna. Sachi Srivastav from the University of Delhi, New Delhi. Nahin? Suresh Babu Nair from the Space Physics Laboratory, Vikram Sarabhai Research Center, ISRO, Trivandrum. Nahin? Shashikant Utpal Tatu from the Indian Institute of Science, Bangalore. Govind Swami Umapati from the Center for Cellular and Molecular Biology, Hyderabad.
For his pioneering work involving wildlife endocrinology, biodiversity conservation, and genomics. There you go, sir. Thank you, sir. Congratulations.
The next name is Raghavendra Reddy Varimala from the Consortium for Scientific Research, Indore.
Please come up. For his pioneering work involving material science, multifluidics, and Mossbauer spectroscopy. Thank you, sir. Please sign on the way out.
The next name is Sri Lakshmi Yelli Maharaju from the University of Hyderabad, Telangana. नहीं?
Not yet.
सर ये पूछना है हमारे पास साइंस सोसाइटी है फॉरेन फेलो है पहले किसको बोला
Science Society. Science Society.
So in the category of science society, now we invite the name of the candidates who has been elected for the year 2025. Name is Akhilesh Gupta from the visiting professor IIT Roorkee and senior consultant in New Delhi.
Yes, sir. For his pioneering work involving weather forecasting, climate change, and above all, science policy of this country.
The next name is Uday Mitra from the Indian Institute of Science, Bangalore. The third name is Dr. Alka Sharma from the Ministry of Science. During that time, madam, it was DBT, Government of India, but presently, I hope this may be correct.
Yeah, so Dr. Alka Sharma, for her pioneering work involving biomedical research and its policy in this country. Thank you. Thank you.
The next Professor S.C. Verma from the former Professor, Indian Institute of Technology, Kanpur. A great applause by all the audience present here. Many, many thanks. Heartiest congratulations. And
yeah, I think Dr. H.C. Verma is a name known to every child in this country, even those children who have grown up like me. So thank you for his pioneering work involving physics, education, and research. Thank you, sir. Namaskar, sir. Sign kariye, sir.
Now we have the foreign fellows also. NASI elected the foreign fellow for their outstanding contribution to in the context of Indian science, and I will request to the name is the first one, Dr. Asim Biswas from the Canada Research Chair in the Digital Agriculture, Canada.
Come, Dr. Asim. for his pioneering work involving soil physics, soil health, and digital agriculture. There you go, sir. Glad you could make it. Thank you, sir.
The next name is Lennon Eric from the Institute of Physics, University of Amsterdam, Netherlands.
I don't think anybody else.
Amit Goyal, I think so, from the USA. The Wolf Kiefer from the Germany. And the Venkat Kumar Kudur from the USA. Ewing Orer Andrew John from University of Bristol, UK. Monica Raj from the Imra University, USA. Satish Chandra Singh from the Paris City University, Paris. Sir, one of the fellow who has been just during the first announcement, he, sir, was not there here, but now I think sir is here.
Okay, great. Dr. Sanjeev Kumar Agarwal, please, you're here. Yeah,
we
please.
have announced the name, but at the, during
Yeah, I'm
that
sorry,
time.
there was some mismatch. Please come, sir.
No, but at that time, sir was not here.
Acha, you were here, but we missed you. Our apologies. Please come. For his pioneering work involving high-energy particle physics, astrophysics, and neutrino physics, sir. Thank you, sir. This can never be wrong, sir. We are wrong, sir.
We are all on the same boat.
Thank you. Thank you, sir.
I hope the list is also displayed on the here display board. If anybody are present here from the NASI elected fellow 2025, and I have missed the name, so kindly just raise your hand. We can.
Okay, so now we do two things. One is that we will invite all of you who have been inducted this year to please come up here for a group photograph.
Yes.
And we will also request those who have not signed, those who in previous years have been inducted but could not get inducted due to not coming for that year's event. If there are any such, please, you are there, please come, sir, please come. Anybody else, sir? Anybody else who missed out? Venkat also, yes, of course, please come, sir. No, come here. So but we don't have his certificates, do we? Yeah, but we can't give it to you here. Okay, you just sign the register, I guess. Yeah. So we'll photograph you signing the register, and then we'll request to. Come here, no, we'll chadav the shot, we'll chadav the utriya on you. इतना तो कर सकते हैं हाँ तो उतरा दीजिए अरे है ना अरे गिफ्ट शाल है कि नहीं हाँ वो दे दो यार उतरे दे दो शाल तो दे दे यार शाल also you cannot have got the shawl. ये थोड़ी पोस्ट से भेजेंगे अरे कौन है फोटोग्राफर किधर है हाँ अरे फोटो खींचे और कौन है हाँ यस
सर मुझे लगता
है जरूर
इसके लिए भी सीलिंग
मेरा भी चाहिए आप भी आइए
आफ्टर 20 इयर्स बंद करते हैं फोटो लेते हैं
हाँ सो
ग्रुप फोटोग्राफ्स के लिए फोटोग्राफर कैन गाइड अस
कहाँ तो ऑडियंस में बैठे यहाँ से ले लें
अगर ऑडियंस बीच में बैठ जाए तो ले सकते हैं
व्हाट इज योर फील्ड ऑफ व्यू यू विल कवर द मिडिल सेक्शन
को खाली कर दें
लाइट नहीं
खत्म हो जाएगा ना तो
लाइट नहीं
एक मेरे को उतारना पड़ेगा
आपका तो कहीं Okay, so we are trying to see how the photograph. I understand they'll all sit here. Okay, so the request is for all the fellows to please sit down in the center section so that we can take a photograph from the top here. Can you? Yeah, I'm sorry. I'll have to evict. I'm sorry. I'll have to request those sitting in the middle section to please vacate your seats for a few minutes. Yeah. We will try to give you vacant possession in a few minutes. Yeah. अभी क्या बाकी है जनरल बॉडी में
सब चले जाएंगे सर, सब चले जाएंगे। नहीं एजीएम करके नहीं जाएंगे, ऐसा नहीं है। फोटो हम फोटो
just get it up. So may I request you all to sit down, please. Please sit down. Please sit down. ठीक है, पूछ लेंगे। अच्छा, फोटोग्राफर जी खड़े रहें कि बैठे?
खड़े रहने में ज़्यादा अच्छी आएगी, क्योंकि शॉल।
हाँ, खड़े। आप यहाँ के इंस्ट्रक्ट करिए यार इनको।
पीछे आ जाएंगे सब लोग, हम लोग नीचे खड़े हो जाएं।
I think they are. You want them to stand, ना? खड़े हो जाए ना? आप हाँ आपको Yeah, please try to occupy the center section only. That's the widest angle the lens can go. Yeah. Sir, I think we are obstructing people here. Oh, we are obstructing people here. So we'll stand at the side.
थोड़ा झुक के खड़े हो।
Hey, Venkat, you should be here.
हम लोग इधर
एक दो चेयर करिए यार।
एक दो चेयर करें।
दो तीन चेयर करिए।
I think chair will be better.
हाँ, that will be better. No, there are, yeah, I think there are enough chairs. और एक दो चेयर। हाँ। बैठ जाइए। किधर है वात्सा कैन कम। We'll share it all, don't worry.
More a little bit closer. We request everyone to move towards the center a bit closer, not stay far apart. Just if the second row could just move a bit more closer towards the center. Third. Yeah.
या तो उसको आगे करके आप उसके पीछे खड़े रहिए या तो पीछे हाँ या तो बैठ भी सकते हैं आओ अशोक
We request you all to allow the photographer to take the photo and then you can take in your cameras. The photographer requires to take a photo, so please wait. We request other people to wait and allow the photographer to take a photo.
Yeah, or take a chair and sit here. No, you can take a chair and sit. Thank you.
Enough cameras. Venkat को भी तो बुला लो.
Venkat, why are you hiding here?
Why are you there? You should be here somewhere.
Come. He's still taking. He's still taking. Come. You got your. Hold on here. Hold on. We need Venkat also here. Come. बैठिए सर Yeah, close pack as much as you can. Still too wide. Too wide. It's too wide. कौन है? Only front row.
नहीं तो इसके ऊपर चढ़ जाओ ना.
नहीं, फिर भी नहीं आएगा. It needs a wider angle.
फिर क्या करें? एक पीछे जाए.
Can you push little more in which chair? Yeah, we can close back. Yeah. Yes.
भालो अच्छे. आ गया. I don't think you can squeeze anymore.
We can squeeze the chairs.
हाँ वही. आ रहे? Yes. नासी बोलो सब लोग. नासी.
Nasi.
नासी.
Take few more, yeah. Ishan, take a few backups here.
और ऊपर से लो. हाँ यहाँ से यहाँ.
Yes.
और close, bring the phone closer to your eyes, then.
You'll get wider angle.
चलो ठीक है, हमारा तो आ ही जाएगा, हम बीच में बैठे हैं.
Thank you all. आपको मिल गया ना सर? अभी क्या बाकी है? किधर है संतोष? किधर है संतोष? क्या बाकी है? अरे संतोष क्या बाकी है अभी?
सर एजीएम. सर हमारे न्यूली इलेक्टेड विंडो ये न्यूली इलेक्टेड मेंबर्स इज आल्सो हियर. वो लोग चाहते हैं, कुछ लोग हैं फोटो खिंचाने के लिए, तो उनको बुला सकते हैं क्या? तो आप अनाउंस करते हैं मेंबर्स.
Okay, can I have your attention, please? We have two small items of business. We have the general body meeting, which we shall do in the greatest possible hurry possible. Is there an agenda?
Yes, sir. This agenda is on the display, sir.
Okay, agenda. Two.
Will be also distributed to the going to.
Can we scroll it up, please, to read and confirm minutes?
Sir, these fellows are also has to be signed on.
Go, yeah.
ये लोग जाए ना, sign करके जाए.
So minutes are confirmed. Any objectors? Any comments? No.
No, sir.
Okay, minutes are confirmed.
Please announce people to settle down. It's getting chaotic.
Yeah, can I request some order in the house, please? Ladies and gentlemen, can I request for some order in the house? I may request, but I may not get, but I will still request. Yeah, can I request for some order in the house, please? Yeah, just give us a couple of minutes here. We also request members, those who have been elected as members. We also request those who have been elected as members to please wait. We will be taking a group photograph with you, those who are still here. Yeah. So can I call the house to order, please? We have a couple of items of business. First item. So first item is to read and confirm minutes of the annual general body meeting held on December 2nd at 6:30 p.m. in the VH Visitors Hostel Auditorium of IIT Bhopal. Any comments? Approved. Okay, approved. Thank you. Second item of business is presentation of annual report 24-25. Where is the report? Annual report copy, please.
The website will be going to display on the website.
Okay, so here is the annual report, and here it has been speed read. So it is approved. Okay, annual report is approved. announcements of the names of the office bearers and members of the council. Can we display that? Can we display that? Can we display? Arey, council members here.
Yeah, sir.
So display it, no? So we'll display the names of the office bearers and members of the council.
We can read also if they want.
Well, where is it? अरे ये कितने नाम पड़े हैं?
डिस्प्ले कर दें अच्छा है।
अरे उसमें सेकंड पेज पे है ना?
संतोष अरे ये सब पीडीएफ प्रूफ के रखना चाहिए। क्या बताएं?
कितने बजे लेक्चर है?
7 बजे टाइम है उसके लिए। पढ़ लीजिए 2-3 छूट जाएगा doesn't matter.
All right. So while that display is coming up, let me read. Okay, it's here, and it's so small that even I can't read it. So we will treat it as read. I will read the first few names. Is it legible? Okay, great. So let me read the first few names. So President is Professor Vinod Kumar Singh. Past Presidents are Professor Balram Bhargav, Professor Ashok Mishra. Vice Presidents are Paramjit Khurana and Devang Khakkar. Treasurer is Punita Batra. Foreign Secretary Rajesh Kumar Vatsa. General Secretary is Prabodh Kumar Trivedi and Daya Shankar Pandey. And we have a long list of members of the council, which we will, in the interest of time, treat as read and request you to read. Is there anybody local here from Guwahati? No, I don't think so. Next time. So, okay. So, what's the next order of business? To report on the changes incorporated in rules and regulations of the Academy as duly adopted by Council in its meeting held on December 9, 25. Do we have any rule changes to report?
Only 2 to 3 years we have.
Yeah, so there is one significant change, and that change is that the tenure of the council, which includes all the names I've read, of those who will be assuming office 1st of January 26 onwards, their term will be of 3 years instead of 2, which has been the norm all these years. So this has been adopted by council in the last couple of meetings. Yeah. And then the fellowship areas have been realigned a little bit. Now there are 10 groups and covering areas. There have been some realignment of those areas, and that will be in the minutes which will be circulated. So those are the major changes that have been made by council. And is there any other matter that has to be taken up? With permission of chair, we can. Okay, if not, 2 announcements. We have a lecture by the renowned neurologist and computational neurophysicist, computational neurobiologist, Dr. Mriganka Sur at 7 p.m. in a few minutes. So please don't leave. This promises to be a great lecture. He's going to be speaking remotely from MIT. And before we do that, in the intervening time, if there are any members here and you want to join for a group photograph, the newly inducted members can join for a group photograph. And in the meantime, I request others can take a short break. Is there some tea or something outside? No? Okay, maybe not. Yeah. All right, so we'll take a short break. This concludes. Yes, we have one very important announcement by those who have been elected fellows and members here. You have a great responsibility here. Under threat of revocation of your fellowship, which I'm joking, of course. Under threat of revocation of your fellowship, let me repeat, you will submit a paper to one of the journals of NASI, right?
Members के name हम यहाँ पर display कर दे रहे हैं, सर उनको भी बोल देते
हैं। Your best paper. Yeah. In fact, I've got request from editor that it should be your best paper. So we will monitor and report next time. Thank you. Yeah, so now I think we will announce the name of the members and members who, although there will be no formal ceremony of handing over, but we are happy to take a group photograph if you so desire. So members who are here, please hold on here. Can we read the name of members, please, or at least display the names? Yeah, so those who have been elected as members of this academy is on display on the screen, and we would welcome if any of them are here to please join us for a group photograph here. Yeah, I think this is, yeah.
We have the certificate also, sir.
Yeah, and yeah, if there are a few, we can even do a ceremonial handover of certificates. We normally don't do this, but नहीं कितने लोग हैं यार? 4-5 ही है ना, तो दे दो ना, नाम पूछ के दे दो. नाम लिख के ले लो ना, संतोष नाम पूछ ले. अरे सर आइडेंटिटी थेफ्ट हो जाएगा. You will be prosecuted under new digital, क्या नाम है उसका, digital data law, protection of digital data laws. नाम बताइए. कुसुम सिंह.
Sirisha नाम.
हाँ, सीरियल नंबर के हिसाब से वही टेक करना. सर्टिफिकेट दे दो फिर फोटो खिंचवा लें.
7.
सबको देंगे फिर एक एक करके लेते हैं.
7, 10, 9.
फोटो इधर से लीजिए. संतोष.
सर सब 1 by 1 करना है क्या सर?
9 तो गलत है.
नहीं गलत है.
kindly be seated. We are starting the last session of the day. I, Yashodhara Goswami, the host of this last session of the day, welcome you all back to this plenary talk, the 9th session of 95th NASI Annual Session and Symposium. I would like to introduce our chair, Professor Venkata Subramanian ji. We are fortunate to have Professor Venkata Subramanian Ganesan, Professor of Psychiatry and Consultant Psychiatrist at NIMHANS, Bengaluru, as the chair of the Session 9, 95th NASI Annual Session and Symposium. Professor Venkat is a leading clinician scientist in schizophrenia research, neuromodulation, and translational psychiatry. He leads the Translational Psychiatry Laboratory at the Neurobiology Research Center and leads major initiatives at NIMHANS, including the INSTAR program for schizophrenia and the WISER neuromodulation program. His work spans clinical neurobiology, metabolic abnormalities in psychiatric disorders, TDCS applications, and advanced brain imaging. Can we have a big round of applause for Professor Venkata Subramanian ji? Welcome, sir.
So good evening, everybody. I think we have assembled here for a very important plenary talk. And it's a great honor to welcome Professor Mriganka Sur, who has joined us online. Professor Sur is a Newton Professor of Neuroscience and Director of the Simon Center for the Social Brain at the MIT. He's a visionary neuroscientist, and Professor Sur's pioneering research on brain plasticity, perception, and cognition has led over 250 influential publications. He's also a fellow of the National Academy of Sciences, USA, and the INSA. He has received numerous accolades, including the George Miller Prize in Cognitive Science. His groundbreaking work continues to shape modern neuroscience globally. So we look forward to learn from his plenary talk. Over to Professor Sur.
Can I share my slides? I'm going to share my slides now. Somebody needs to turn on the sharing. And I tried to share, it says sharing is not turned on.
Sir, now you can share your screen.
All right. Very good. Okay, can everybody see my slides? My
Yes,
first
sir,
slide?
it's clear and perfect.
All right, thank you so much. I need to, all right. Okay, so it's a very great honor for me to be asked to speak at the 95th meeting of the National Academy of Sciences of India. The National Academy of Sciences was the first academy to which I was elected more than 30 years ago. And I myself am from Allahabad. My grandfather did his PhD with Meghnad Saha. And so we have deep roots in Allahabad and with the National Academy. And my wife has written scholarly articles on Meghnad Saha and his science. So for all these reasons, it's a very special honor. Thank you for inviting me. I'm going to talk today, in the next 45 or so minutes, about some new ideas as to how neuroscience, or the study of the brain and mind, can influence AI and machine learning. All of you know that there is a transformation, even a revolution, taking place in the world of artificial intelligence, driven by computing power, large amounts of data, and new ideas. And today I'll share with you a little bit about how neuroscience, or what we know today or are learning today about how the brain works, can actually influence artificial intelligence. All right. So since this meeting, this session of the National Academy is devoted to the mind, cognition, human brain, and brain health, I think I don't need to emphasize that the human brain is a powerful information processing machine. The brain differs from other organs of our body, such as the lung or the heart or the liver, precisely because not that the brain has cells, but the nature of those cells. Brain cells generate electric activity, and this electric activity encodes information, and the job of the brain is to process information. So the brain has nearly 80 billion neurons. I hope you can see my pointer and the collective activity of these neurons. And there are neurons and there are non-neuronal cells called astrocytes, and together this activity creates the mind. And the formal word for mental activity is cognition. So what is cognition? Cognition is the activity of the mind created by the brain and its cells, underlying perception, action, learning, memory, attention, everything we do, communication, decisions, empathy, up to and including consciousness, but I've put consciousness within quotes because while we have a general understanding of what it is, we don't really know what does it mean to be conscious. Okay, so the brain has often been compared to a computer. And indeed, there are many similarities between brains and computers. But the truth is that today, computers, in terms of their processing power, far, far outstrip the human brain and mind. This is just one of the latest general processing units, graphic processing units from NVIDIA, and showing how rapidly computing power has grown just in the last 8 years for processing for AI and machine learning, not just doing arithmetic, but for complex processing of information. And this is already outdated because the latest chip from NVIDIA is 10 times faster than this chip from a year ago. So this massive increase in processing power is at the heart of how large language models, which is a form of AI driven by machine learning that drives algorithms like ChatGPT or generative pre-trained transformers to do amazing things. If any of you have played with large language models or LLM, you can download ChatGPT, even the latest version of it, ChatGPT 5.0, and you can ask it questions like, not only give me detailed instructions for how to make bhel puri, or you can say, make me a slide deck of 10 slides on how neuroscience does, how discoveries are made in neuroscience, or write me a grant proposal on how I might do functional magnetic resonance imaging of the social brain, etc., etc., etc. It is amazing. By mining massive amounts of data available on the web, and there are issues around that, but these AI models have been able to cull or extract information in ways that today far outstrip the ability of human beings. But these large language models and modern AI requires massive power. This one chip requires 600 watts to run even a simple query, and you have thousands of such GPUs to run a large language model. US data centers consume 183 terawatt hours in 2024. That is almost 4 times the energy consumed by New York City. it needs massive amounts of data. And there have been concerns about what is it that these AI algorithms really do. Do they understand? Do they have common sense? And of course, they are susceptible to hallucinations, errors, different kinds of mal or misinformation, etc. So, and it should also be said, it may be a surprise to some of you, that apart from borrowing some words, such as neural and network, artificial intelligence and machine learning have not been influenced very much by advances in neuroscience. In fact, these are engineering feats that rely on statistical analysis of large amounts of data, but they do not work the way human brains do or the mind works. And so what is it about the brain and mind that is unique? How might we understand how the brain and mind work, and what might that tell us about the next generation of computing, or for AI and ML? So the first thing to understand is that the brain is not a general purpose computer. The brain is a very efficient processing device with many remarkable features. The brain makes internal models of the world. The brain focuses its energy and processing power on specific things via mechanisms of attention. The brain's memory system is a distributed memory system, unlike in your computer or laptop, where there is a processor and a memory. It's called a von Neumann machine, where information goes back and forth between the processor and memory. Not so in the human brain. Processing and memory live in the same elements, and the brain has remarkable and powerful capacities for learning. Here's a very quick set of images from now a classic paper showing how specific brain regions are involved in specific kinds of processing. When this observer, these are positron emission tomography or PET images, when you look at a car, the visual cortex lights up. When you listen to the word car, the auditory cortex lights up. When you speak the word car, the motor cortex lines up. And when you generate language, such as associations between car and other verbs, then the language area, Wernicke's area and Broca's area light up. So it shows at a glance that the human brain has distinct regions with unique functions. So the issues for neuroscience are, how is the brain wired? How does this capacity come about through a combination of evolutionary wiring and developmental wiring? And how do brain wiring and neuronal dynamics, the activity of neurons, create cognition? How might understanding the brain shape AI? That's a topic for today's talk. And so today I'm going to talk very briefly about these two questions. First, on how might brain activity create specific components of cognition. I'll give you a flavor of some of the key ideas in the field, in my opinion, drawing importantly from our own work or my own lab's work and that of my students and postdocs. And I will end with a set of comments on how might understanding the brain, the kind of understanding I will share with you, shape the next generation of artificial intelligence. Okay, so the first thing to understand about the brain, as I already mentioned, is that the brain is made up of neurons as well as non-neuronal cells or glia. I'm not going to talk about them, but there are two things about brain cells or neurons shown here massively magnified. I should point out that a neuron, typical neuron in the brain is about 10 microns wide. A human head is about 80 microns wide. So it is 1/10 the width of a human hair. That is why we can fit 80 billion with the B of them in a volume of little more than 1 liter, which is what our brain's volume is. So a neuron differs from any other cell in our body in two important ways. The first is that it generates electrical potentials or spikes, shown here at the bottom on the right-hand side. Nobel Prizes have been given for understanding how
brain cells generate these electrical spikes via a combination of sodium and potassium currents. The second way by which brain cells differ from any other cell is that brain cells connect to other brain cells, thousands of other brain cells, via tens of thousands of synapses or connections. A brain cell has a wire, and a typical neuron has 10,000 connections onto 1,000 other cells via the specialized junction shown at the bottom left, where the electrical activity of neuron 1 coming in ends. Chemical transmission happens, and then neuron 2 picks up that chemical transmitter and generates its own action potential or electrical activity. By this method, you have thousands of neurons can influence any given neuron, and this neuron integrates the electrical activity of its presynaptic partners, but in complex ways. This is the essence of a neural network, as to the complex connectivity between thousands of neurons to make an entity that is much more than 1,000 times 1. Here's a brief example of how such networks in specific brain regions underlie cognition. These are 4 images, self-portraits by a German artist named Anton Rederscheit. He's now dead, but when he was 60, he had a stroke. And a few months after his stroke, Rederscheit is looking in a mirror and making a self-portrait. A trained neurologist can probably take one look at this set of pictures made 3 months apart and tell you where his stroke is. I will tell you. Rederscheit looks at a mirror and he draws half a face soon after his stroke. He draws one eye, half a nose, half a mouth. The left side of his face is completely blank. This is a classic sign of what is called a right parietal lobe stroke, which is a specific brain region that integrates information from the left side of the brain. There is nothing wrong with his eyes. There is nothing wrong with his ability, too much wrong with his ability to draw. But there is something profoundly missing in his ability to acknowledge the left world, the left side of the world relative to his body. And then in 3 more months, there is still poverty on the left side of his face. And 3 more months, and Rederscheit knows there is something wrong. He turns away. And 3 more months, and Rederscheit was lucky. His function has almost entirely recovered. The other amazing thing about neurons is that once they are dead, and they are dying all the time, particularly in somebody like me, who has moved on in years, neurons are being lost all the time. In fact, soon after we are born with all the neurons we will ever have, except in 2 small brain regions called the dentate gyrus and the olfactory bulb. From that point on, neurons keep dying. What saves the day is that we start with a lot of neurons. Neurons, once they are dead, which is what happens when you have a stroke, because neurons are deprived of oxygen and glucose, they die, but sometimes after a stroke, recovery happens because neurons adjacent to the stricken area can recover function. What does this tell us? It tells us that the parietal cortex, or this part of the cortex in the right side of Rederscheid's brain that sits in the middle of the cerebral cortex, is a crucial node for spatial attention, and also that the brain does not simply mirror the world. It creates an internal representation or an image of the world, and that's of the essence in understanding cognition. Here are some more examples of how
disorders of cognition reveal the brain's internal representation. Again, this is from a textbook. This area of the brain that I have just been telling you is the parietal cortex. And when patients have a stroke in this part of the cortex, it's actually a fairly common area for a stroke because this artery called the middle cerebral artery comes up and is sometimes blocked. It's a very large artery that feeds this entire middle chunk of the brain. When that happens, you can see that when asked to draw a watch, the patient draws only the right side of the watch face. The left side is blank, or the left side of the house or the flower is blank. And yet, when the patient moves his body, there is no question. He or she can see all this. They don't register it. They are not attending to it. And this tells us one powerful trick, if you will, that the brain uses called attention. At any time, we are bombarded with information. Right now, when you are listening to me, you are sitting on a seat and there is probably some noises taking place, etc., etc. But if you are not attending to me and removing all the other distractions, it is very unlikely you will understand or even remember anything I have said. So attention is a powerful device used by the brain, not only for conserving energy, but focusing it on things that matter. And attention is crucial for many components of cognition, including perception, decisions, learning, memory, action, etc. How do we attend is a very important issue for understanding the brain, and I will submit to you for building the next generation of smart machines. Another idea from the field of neuroscience is, how does memory work? And memory also creates an internal representation of the world. We know more about memory from this one man. His name is H.M. Henry Molaison, and he is not a neuroscientist. He was not a neuroscientist. He's now dead. What is it that H.M. told us about memory? Remarkable things. H.M., when he was 25 years old, 27 years old, in 1953, he had a remarkable operation done by a neurosurgeon called Scoville. In 1953, Scoville, H.M. used to suffer from intractable epilepsy. He had major seizures, and it was diagnosed that these seizures happened because he had excitable cells in one important part of his brain called the hippocampus. And so Scoville went in with a knife. Remember, this is 1953. And he removed the hippocampus where the arrows are on both sides of the brain, shown here in the left and right side, in very simple, very early CT scans. I met H.M. when he visited him. We have a clinical center, and I met him and I talked to him, and my colleague Suzanne Corkin introduced me to him. And H.M., the remarkable thing about H.M. is that you meet him, you go away, you come back, seconds later, he has no idea who you are. He lost the ability to make memory. He lost the ability to make certain kinds of memory. And this told us that human memory has unique features. Memories for people, places, events, and things are created in this part of the brain that was removed for H.M. in order to treat his epilepsy. And indeed, his epilepsy was treated, but he could never make new memories anymore. The memories he did have were those from before his surgery, before 1953. You ask him about the Second World War, which was between 1939 and 45, and he had completely normal for his age, recollection of the events of that war. And what that told us is that memories for such things, called episodic memories, are created in the hippocampus, but they don't live there. they are stored in the cerebral cortex. And the cerebral cortex that I started out by showing you is the major processor via its networks of information together with other brain regions. So what this tells us at one glance is that memory and processing reside in the same elements in the brain, in the cerebral cortex. And why is that remarkable compared to computers? A computer is a von Neumann machine. Von Neumann was an engineer who devised the first digital computers. And he made a processor and he made a memory. Even today, in the computer that I'm speaking to you from, or in any laptop that you have in front of me, a huge amount of time, effort, energy is spent in moving data back and forth between the memory and the processor. You can lose the computer's memory if there is a data crash, and that is a disaster. In human brains, memory and processing live in the same elements. It's a remarkably efficient device. And that is why the human brain, instead of the terawatts of power, operates on 20 watts of power by virtue of the remarkable efficiency and devices, mechanisms that have evolved. Okay, so new technologies have transformed our understanding of brain function and structure. In addition to functional magnetic resonance imaging and positron emission topography, we can now bring to bear high-density single neuron recordings, including from human beings when they are undergoing surgery for epilepsy, for instance, like I just told you about HM. But then as we go into animals, because there's only so much you can study in human beings, but in animals like monkeys or mice or other animals, we can use finer and finer levels of resolution to study the brain and its elements, including the organization of neurons into groups at the level of hundreds of microns to the organization and activity of single neurons using optical methods to imaging single synapses. I mentioned them to you, 1 micron in size to sub-micron elements inside neurons and synapses using other tools. So all these tools have transformed neuroscience. And in the next 15 or so minutes, I'll give you a brief glimpse of how we can use these tools to get at some of the deepest questions about how the brain works. And then we will come out and very briefly discuss how can this inform the next generation of machines and artificial intelligence. And we'll end up also very briefly mentioning, is that a good thing? So, how do brain dynamics or brain activity create cognition? Suppose you're at a red light and you see the light and it's foggy. You nonetheless have to decide, is it red or is it green? And you decide it is green. You make a decision and then you press down on the accelerator and you move forward. Many, 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 many brain regions are involved in this simple act. Human beings do this all the time. In fact, we learn red means stop, green means go through a process called reinforcement learning. And then there are brain mechanisms for vision, for decisions, for action, combined, wrapped together with attention, that make this simplest of acts possible, and it embodies profound ideas about cognition. We can hardly study any of these in the human brain. When you do fMRI, each voxel, or each of the pixels, if you will, in the MR scan, contains within it 1 million or millions of neurons. So there is no resolution in terms of how to analyze. What do single cells do? How do their networks work? Though fMRI has been remarkably successful. I'll show you how we can use very humble creatures, such as the mouse, to understand brain functions underlying cognition. Okay? The mouse brain is is 1,000th the size of a human brain. It has only 50 million neurons as opposed to 80 billion with a B. And the mouse brain is not a miniature version of the human brain. When you blow up the mouse brain 1,000 times, you see that brain regions that deal with sensory processing, vision or audition or simple or movement, such as shown in red, take up most of the brain. But the mouse brain, if you look in the right way, has certain areas that do constitute higher cognitive areas. Shown in green here is this parietal cortex that I've already shown you, that I told you for Anton Rederscheid creates spatial attention. And so this cortex exists in mice. In fact, I would argue that no mammalian brain that deals with anything resembling complex processing, every such brain needs to have such areas that bring together sensation, perception, and action in order to mediate behavior. How can we understand the function of this area in the context of attention and in the context of processing, underlying cognition? Well, I'll show you one experiment, okay? And around this experiment, because I don't want you to go away without some idea of how does neuroscience work. And maybe you have heard about this from other speakers at the meeting. How do we know what we know? Here's an experiment to understand attention-based visual discrimination in mice. Here's a mouse. I hope all of you can see my pointer and this image of a mouse from the side sitting in an apparatus. And what is the point of the experiment? The point of the experiment is a version of the red means stop, green means go behavior of human beings. We train this mouse to look at visual stimuli on the screen at the back. And when we show it horizontal stripes, the mouse is supposed to lick for a water reward. This mouse has been kept deprived of water a little bit in order to train it. This is how circus trainers train animals. This is how my students, who are better than most circus trainers, can train a mouse that weighs 15 grams, whose brain weighs about 3 grams, to do this task. And so when this horizontal stimulus comes on, after a while, this lick spout will come forward and the mouse will lick to this stimulus, but when this stimulus comes on, the mouse will not lick. And the point of this experiment is to ask at the end of this, how does the mouse carry out this task? Let me show you a little bit of the behavior. Here's the mouse, its nose is twitching. Here is the horizontal set of bars. The lick spout comes forward and the mouse licks. And now there is the vertical set of bars and the lick spout comes forward and the mouse does not lick. And this is what is called the stimulus response matrix. The mouse licks, the mouse does not lick, and on top of this, we can play another game with the mouse in order to study attention. In certain conditions, we do not bring the lick spout forward. In the engaged condition, we do exactly what I just showed you. In the passive condition, we do not bring this lick spout forward. So in this block of 50 or 100 trials, the mouse has nothing to lick. So the mouse switches off. The mouse knows I'm playing a different game. There is no reward to be had from this task. And that's the non-attentive or passive condition. And is the mouse really attending? Yes, it is, because we can monitor its attention by looking at its pupil, for instance. And that shows us, when we attend, if you are attending to my talk, or to me, or to my slides, I guarantee you your pupils in your eye are slightly dilated. And that has to do with attention mechanisms that in the brain that release chemicals that make you attend. But in the passive condition as opposed to the engaged condition, there is nothing to lick and the mouse is not attending. So what? Well, we can now use very high resolution optical techniques to record the activity of brain cells. And we can do this for this set of slides in two brain regions, the visual cortex. I showed you the visual cortex in human beings. It gets visual information from the eyes, and the parietal cortex. And I showed you this parietal cortex in human beings, which integrates information via attention. And we can record from these two regions using optical tools, very sophisticated tools called two-photon imaging, where we make brain cells light up when they fire electrical action potentials. So when they are active, we can image their activity using light because of this sensor that we genetically put into the mouse's brain cells. What does this tell us? It tells us something remarkable, that when we look at neurons in the primary visual cortex, at the back of the mouse's brain or in the back of our brain, it does not matter whether the mouse is engaged and attending or passively viewing and not attending. Here are a set of neurons that responds to horizontal bars, shown in red. And in either condition, there is a response to this visual stimulus in front of the animal. In contrast, when you look at the parietal cortex in the middle of the brain, engaged with attention, as we know from human studies, but now looking at the level of single neurons, it's only when the mouse is attending, when it can get a reward, when the lick spout comes forward, hence the mouse is engaged in the task, do these neurons respond to the same set of horizontal bars. But when there is no reward to be had, the mouse is passively viewing, then the same stimuli lead to no response. And that tells us that even though the visual stimulus is identical during the engaged and the passive trials, only the internal state of attention is different. And this is how we do these experiments, that nothing is changing in front of the animal. Only the internal state of the animal's mind is changing. How can we study these soft cognitive phenomena like attention? This is how. By observing the mouse's behavior and inferring what's going on in its head. And what this tells us, what's going on in its head, is that there are brain regions that create attention. And these brain regions bridge perception and action. And these brain regions have neurons that provide the substrate for attention. When they fire, the mouse attends. When they do not fire, the mouse does not attend. So this tells us the remarkable capacity of brain activity to shape cognition and behavior. We can go further. We can derive mathematical models of how the brain puts together attention. We can read out the mouse's decision. We can create decoders. Here are a set of, let's say, 24 neurons. And we can record the activity of these 24 neurons under different conditions. When the mouse licks to the correct stimulus, that's called a hit. The mouse does not lick to the incorrect stimulus, that's called the correct reject. We can build decoders, and as the trials go by, we can ask, what happens? Can we devise a mathematical boundary between the activity of a certain set of neurons and the activity of another set of neurons? These are important ideas in neuroscience. How does the brain encode? How does the brain decode? We can even ask, is this decoder constant across all time, or does the activity of neurons dynamically change and the decoders change as time goes on? And this is how not only we, as neuroscientists and physiologists and statistical experts, decode the activity of brain cells, other brain regions must also work this way. Because how is it that the visual cortex can tell the parietal cortex to create attention, and the parietal cortex then tells the motor cortex to now lick? So this is how one brain region can interpret the activity of another brain region. And to make a long story short, dynamic encoding of choice occurs in the parietal cortex, but not in the primary visual cortex. And in the parietal cortex, for example, this decoder changes over time from trial to trial, because in one trial you get a horizontal stimulus, and another trial you get a vertical stimulus, and so forth. The decoder keeps changing, whereas in the primary visual cortex, the decoder is constant. Neurons are responsive either to the horizontal or to the vertical stimuli, and that does not change. So the dynamic contribution of attention comes about because there is a dynamic decoder in the parietal cortex. One more idea based on the same kind of task. How and where is memory created? I told you about HM and the role of the hippocampus, but short-term memory. If I tell you a phone number and ask you to put it in your phone, you only need to remember that phone number for a few seconds. Can we study that? Indeed, we can, because now in the same kind of task for the same mouse, we give it a stimulus and then we give it nothing. We just let it hold this in its memory for either 0 seconds or 3 seconds or 6 seconds. And then we bring this reward spout forward and we ask, can the mouse do this task? And so here you see this is a horizontal set of bars, and there is a delay. The lick spout is not coming forward, and then it comes forward and the mouse licks. Where is this representation of memory stored? And to make a long story short, this representation, when we record the activity of visual and parietal and motor cortex, is stored in the motor cortex, just which generates the action of licking. If you look at the activity in these neurons, the stimulus comes on and the activity in visual cortex goes up, in parietal cortex goes up, but in motor cortex, the activity goes up more slowly but remains constant through this delay period. And then when the animal has to lick, its activity goes up. And so in this delay period, I remind you, during this delay period, if you notice, there was nothing in front of the animal. A stimulus was presented, it was taken away, and then the lick spout came forward. But during this period, there's just a blank screen, but the mouse's brain is still active. It is holding that memory. You can see it at a glance in the activity of these neurons. There is only an internal state of working memory, and we can record the activity of brain cells, and we can show you that indeed the mouse is holding that memory, just as I'm showing you here. And that is an internal representation of time. We can go forward, we can do statistical analysis and mathematical analysis of this activity. I told you millions of neurons are involved in this task. When you have 1 million neurons, if you have just 3 neurons, then you have a high dimensional space. The activity of any of these three neurons, in the case of 1 million neurons, the activity of 1 million neurons can be varying, co-varying. This is a 1 million dimensional space of representation. How can we understand this? We can do what's called a dimension reduction. We can derive principal components that abstract into just 2 dimensions the critical components of this activity. And when we do that, we can have some insight, some intuition into how does the brain, so many neurons, nonetheless can work together to represent, encode, and decode information. And I'll give you a brief glimpse. So in the motor cortex, you have what are called attractor dynamics underlying cognition. And here is what this 2-dimensional space shows. When the stimulus comes on, this activity sits in a certain... The memory is this constant potential well, and then the action is a change in the activity of this group of neurons to generate the lick. And so this also says that in these same neurons, in our case, 321 neurons that my students imaged, memory and processing live in the same neurons and represent the cognition of short-term memory and behavior underlying the sensory motor processing. So then, I've told you that brains have very low power consumption, 20 watts as opposed to gigawatts for even the smallest language models. The brains have flexible architecture. The parietal cortex can change its dynamics in order to mediate components of attention. The brain, attention is a very critical component of brain function as opposed to machine learning and AI, but in the next 2 minutes, I'll tell you how that is changing. Processing and memory are in the same elements as opposed to separate memory and processor in computers. Learn from very few examples. And nonetheless, what computers do by definition is computations. And what the brain does, what I'm trying to leave with you, the brain also carries out computations. We can understand these computations mathematically. We can derive principles. We can derive concepts to understand their logic, as I have shown you. And these computations underlie cognition. So human beings have always built machines that mimic nature, but by deriving principles from it. Birds fly, and we have built machines that fly. For a long time, human beings built machines by mimicking birds, by human beings putting on wings and flapping them. And that did not work. It required us to understand Bernoulli's principle, that when you have an aerofoil that moves through the air, that generates lift to overcome the weight of a flying object. And you need to generate thrust to overcome drag. And then you fly. And we have built machines that derive from these concepts that way outperform birds. I believe is the same for computations. If we understand the principles of computation, we can build machines in computers, in silico, that will not only match, but will one day outperform the human brain. And they already do, but they have not relied too much on neuroscience. But there are a couple of ideas that are already taking shape that are transformative. For instance, you can ask, does this mouse reason? And if so, how? How does it try to understand its world? And to do that, we need to look at what are called error trials. Amazingly, even though the mouse has learned the task, every so often it makes a mistake. And there are two kinds of mistakes. One kind of mistake is that it licks when it shouldn't. That's called positive error modulation. So when a visual stimulus comes on, that it should lick to, horizontal bars, it licks. But when a visual stimulus comes on that it shouldn't lick to, such as the vertical bars, it usually does not lick. That's called the correct reject. But every so often it licks. Why does it lick? That's called a false alarm. It licks because its brain tells it to lick. You might think, what else? But I think it's a profound idea. Because when you look at the brain activity, when the mouse makes a mistake, you can see that is just as high as when it should have correctly licked. And the other kind of error is when it should have licked, but it doesn't, and that's called a miss. And when you look at the brain's activity, there is a reduction, exactly as if it was a correct, exactly as if when it shouldn't have licked. but in this case, it should have and it didn't. So these are positive and negative error modulations. What does this tell us? It tells us that the mouse is exploring its world. Every so often, it wants to know, has the rules of the game changed? Am I playing a different game where instead of not licking, I should lick to see if I can get more of a reward? Or instead of always licking, maybe I should not lick, maybe then I will get a reward. This is called reinforcement learning, where an agent interacts with the world, and based on the reward that it gets, it changes its view of the world. It's called changing the brain state. And this is a very powerful mechanism by which we understand the world. We don't come into the world knowing all its rules. We don't come into the world knowing red means stop, green means go. We learn it by trial and error. We may be told about it by our parents or by our friends as well, but we have to try it out. This is a very powerful idea because brains have evolved in the world to deal with it. And you deal with the world by learning about it, and you learn about the world by playing with it and by getting rewarded or punished. This idea of reinforcement learning combined with attention and deep reinforcement learning has been transformative for science. In fact, there is a company called DeepMind that built this model called AlphaFold, and it built many other models based on this idea of reinforcement learning and attention. And it used it to predict the structure of proteins. This is a very complex problem. There was a time when it used to take decades. Venki Ramakrishnan, who won a Nobel Prize, solved the structure of an energy-producing molecule in cells, and it took him a lifetime to solve that problem. But AlphaFold, or made by this company DeepMind, generated an algorithm based on the ideas that I've been telling you to predict three-dimensional protein structure from protein sequences. And by 2020, it had outstripped the most advanced human-derived structural models. Today, it predicts millions of proteins, including a protein structure that we are very interested in because my lab also studies brain disorders and diseases. And this has led to a tremendous acceleration of biology and drug discovery. In fact, the Nobel Prize in Chemistry in 2024 was given to Demis Hassabis and John Jumper, who created the AlphaFold, attention-based, deep reinforcement learning-based models. So this is just, and indeed my own slide is created with another large language model called ChatGPT-5, because I just wanted to see what it would do, and it did a remarkable job. So where are we then? To conclude, well, there are many capacities of brains that make the human brain remarkable. And almost none of these have been used for training or making algorithms that are used for machine learning. But when they have been transformative, like in the example I gave you. For a long time, human beings have thought computers cannot be the same as human minds, and I think to an extent they are right. But I must confess my view is changing. There have been two kinds of objections. Alan Turing, who many of you might have heard of, devised the Turing test. And Turing said, a computer to be truly human, another human being should not be able to tell the difference between the output of a computer and the output of a human. And this Turing test has long been demolished. There are thousands of examples where the average human being cannot tell the difference between the output of a large language model and a human. In fact, the computer's outputs are superior, though they can be stilted, they can be more formal, etc., etc. A philosopher called John Searle argued, a computer doesn't really understand. In a Chinese room that he proposed, if you were to give a computer, if you were to give in a page of English and give this computer a dictionary and some other information and tell it to translate this page of English into Chinese, the computer will do it, but does it really understand Chinese like a human translator would? And indeed, that is true. It is not clear what does it mean to understand, but it's also true there are levels of understanding that all human beings have. I understand more about the human brain today or about the brain today than I did 40 years ago when I started. So when you put it together, you know, the history of science has been a progressive retreat of the centrality of human beings. We used to think that the earth is the center of the universe, and we now know the earth is a speck in a massive universe. We used to think human beings are the epitome, are the peak of development. And we now know we are a continuum. From the simplest worms and flies, we share the same numbers of genes. What we differ in is how they are organized and when they come on and when they turn off, etc. And the human mind, perhaps, is the last category of exclusivity. And it is possible. We already know human beings have always built machines that have outstripped human capacity. And with each such machine comes a reorganization of our work and our view of ourselves. And I do believe we are at that point with AI and machine learning. The power of AI is enormous. And if we bring to it the understanding of the human brain, I think that these remarkable advances that have already been made by AI and machine learning will be transformed by neuroscience, which leaves us with a very important question in a world that is as fragmented as it is today, both in terms of people and in terms of countries. Will the gains of AI be equitably distributed? So I'm going to leave it at that, and thank you very much for listening.
Yeah. So thank you, Professor Sur, for this captivating, fascinating, elegant presentation. It was insightful, and perhaps we can look for a few questions. Is it all right with you, sir?
Sure.
Yes.
Priyanka, it was a fantastic talk. You mentioned that the memory and processing are separate in digital computers. And when these two in the brain, these two are together or same. Would it be possible that in future that this memory and the processing are combined to make the computers more efficient and less power hungry? More than that, would it become cognitive? Would the computers become cognitive?
The answer to whether memory and processing can be combined in a chip or in transistors. You know, this NVIDIA chip I showed you, it has 80 billion with a B transistors. When I was an engineering student, we were given one transistor and resistors to build a circuit, and 80 billion of them is mind-boggling. But, so that is to say technology is amazing. However, processing and memory, the answer is yes and no. With current technology, it is going to be very hard to seamlessly integrate memory without destroying computing or processing. So that remains a very deep, evolutionarily adaptive property of neurons and mammalian brains, actually, in my opinion, all nervous systems that human beings will have a hard time emulating. And indeed, as you pointed out, that is at the core of the power efficiency of the human mind.
Good morning to you.
And yeah, I'm sorry. You go ahead.
No, go ahead. Yeah, good morning to you, Mriganka. What a fascinating talk. Really, we are all enthralled and so much learning to be taken. I would just like you to make a comment on, we're talking of quantum computing, and of course quantum technologies, there are many, many things. How will that affect what you're talking about? Will that change things in terms of a computer and the brain and so on and so forth?
Yeah, so quantum computing is yet another thing altogether. Quantum computing relies on tangled and entangled states and ways of representation that are in a different conceptual realm from brain function and neuroscience as we understand it. A scientist would never say quantum phenomena do not affect the human brain and mind, but it is difficult for me to see in the mesoscale world that we live in, the world of microns and tens of microns and even millimeters or centimeters, how quantum phenomena will play a role at the level of quantum computing. And that's all I'm going to say right now. But maybe, Ashok, when you and I meet next, we should have a bigger conversation. I need to leave soon, but I'm happy to take another question if that...
Yes. So one last question, sir.
Hello.
Okay.
Hello, sir.
Yes?
Sir, a lot of speakers and neuroscientists say that for rewiring of brain, we can do some hope, no technique or affirmation technique. So as a neurologist, what's your point of view to rewire the brain and make it a healthy?
Well, I think the brain has a few properties that we all know. We should use it or we will lose it. So keep using your brain, hopefully for good things or for challenging things, for learning new things. The more you use the brain, the more you will strengthen appropriate connections, the more... I didn't talk about plasticity very much, though my lab has studied that for a long time. There are very powerful mechanisms for making connections, for strengthening them, for making networks that process information. And the more you use brain cells and networks, the more likely that they are going to be healthy and even happy. And of course, that is at the heart of things that I did mention briefly, such as rehabilitation after stroke or trauma. Brain cells, even if they don't regenerate, the existing brain cells and the connections they make with other existing brain cells can be plastic or can be molded. And I think that ideas of wellness, ideas of mindfulness, these are all... Mindfulness, in my opinion, is a very powerful component or aspect of attention itself. And there is no question being able to attend, training oneself to attend, training to focus on things, on positive things, on learning new things. These are all very powerful ideas for keeping one's brain strong, happy, and healthy.
Can I ask one last question, Professor Soor?
Sure, okay.
You said that we learn about the world by playing with it, and then you talked about positive and negative errors. My precise question is, are those positive and negative errors made stochastically, or is there an underlying method to those?
Oh, very good question. to my mind, I used to think they were stochastic. And I now think there is actually a method. In fact, I don't think there is anything random in the brain. Even though it has so many neurons and you cannot predict everything, nonetheless, there is a lot of, if not determinism, at least a directed, goal-directed behavior. So, you know, you take an animal, the animal needs its water from this task. It is tremendously motivated to perform the task as accurately as it can. If it doesn't perform, it's, you know, we have strong survival instincts. We, circus trainers, everybody who's lived with an animal knows that these are powerful drives. So then, when an animal, when you see unchanging, small proportion of errors, it is reasonable to conclude this is actually the brain's way of understanding the world.
Thank you.
Okay, thank you so much.
Thank
I
you,
need to
Professor
run
Kumar.
because I have an appointment at MIT in about 20 minutes, and it'll take me that long to get there. So thank you very much again for inviting me. Thank you, Ashok. Thank you, National Academy, for electing me and giving me this opportunity. It was fun. I hope you had fun.
Thank you, Professor Mriganka Sur, for this enriching presentation, which has contributed to the depth of this session. We sincerely appreciate our chairperson, Professor Venkata Subramanian ji, for his valuable time and perspectives shared with us. Also, we extend our sincere gratitude to all the delegates and participants for their valuable presence and active involvement, which greatly contributed to the success of this session. Now, I would request to join everyone for a dinner, which is arranged at the Lake Lawn View near the main auditorium. Another important announcement is that this is to inform you all, tomorrow's annual sessions are scheduled to start at 9 a.m. sharp. So hoping for the timely beginning of the proceedings. Thank you. Wish everyone a restful night. Thank you.